We are good to go.
Great.
Good morning, everybody. We'll start the session of diabetes in Asia. And for the first speaker, do we have the first speaker? Dr. Abdullah Hamak from Qatar. He's MPH, PhD. He's currently Executive Director of Qatar Diabetes Association, Foundation for Education. He was elected the Regional Manager of IDF in 2010. He was a President of Diabetes Asia Group till 2011, a Fellow of Royal Society of Public Health, Member of Advisory Committee, College of Health Science, Qatar University, Member of American Diabetes Association, Member of EASD and ACE, General Secretary for the Gulf Group of Study of Diabetes. Dr. Al-Hamak participates in research activities with Vale Cornell Medical College and Hamad Medical Corporation in the fields of diabetes. Most of these studies have been published in international journals. Over to you, sir.
Prevention program in Asia. The prevalence. First, I would like. Okay. First, I would like to thank the organizer for inviting me for this conference. Okay, I will talk about the challenges in diabetes prevention program in Asia. Next. So just to give you highlights about the prevalence rate in the world. So this is IDF estimated that 1 in 10 adults aged from 20 to 79 years has diabetes. This is now about 537 million people are suffering from diabetes. And 1 in 8 adults aged from 20 to 79 has embedded fasting glucose. That's estimated about 390 million people. And 3 in 4 people with diabetes live in low and middle income countries. So 1 in 2 adults is undiagnosed, about 240 million people, and 1 in 6 live birth affected by hyperglycemia in pregnancy. About 80% have mothers with GDM, and about 9% of global health expenditures spent on diabetes is about 960 billion in US dollar. And 1 in 10 adults aged between 20 to 79 has impaired glucose tolerance, about 541 million people, and about 100.2 million children, adolescents below 20 years old have type 1 diabetes. Now about 6.7 million deaths attributed to diabetes. Next, please. Okay, now about the impaired glucose tolerance, we have 1.67 million, and about the that expenditure about 206 billion spent in diabetes. We have about 700,000 pregnancies affected by hyperglycemia, and 7.8 million more adults with diabetes undiagnosed, and about 149 500 more children and adolescents with type 1 diabetes, and we have 2.5 million more deaths caused by diabetes, and 73.6 million more adults with diabetes. This is according to the last Atlas edition 10 is published in 2021. Next, please. This give you the broad spectrum of the diabetes in the region. So with different colors, so you can see the prevalences is actually increasing from America to Asia and to Africa. Next, please. This slide is also just illustrated that the diabetes is rising worldwide, and it is set to rise even further. So if we start in 2000, we start with 151 million. So when we reach to 2021, it's come to 537. So and the projection to the global prevalence of diabetes in the age of 20 to 79 years age group in millions. So in 2250, it's come to 335, and in 2045, it's come to 700 million suffering from diabetes. Next, please. Okay, let us just look to the Asia map. Next. So the IDF South Asia SEA region includes 7 countries and territories, currently representing about 11 diabetes organizations in 6 countries. It is the second most populous IDF region. Next, please. So about the Southeast Asia region, this is the highlights of what is about diabetes. So 1 in 11 adults have diabetes, about 90 million. India accounts for 1 in 7 of all adults living with diabetes worldwide. And the number of people living with diabetes is predicted to increase by 69% to 152 million by 2045. Over 1 in 2, about 51.2% adults in living with diabetes are undiagnosed, and diabetes is responsible for 747 deaths in 2021. The total diabetes-related expenditures in the region, I mean the Southeast Asia region, is about 10 billion, the second lowest of all IDF regions. And 1 in 4 live births are affected by hyperglycemia in pregnancy. Next, please. So this is the same. It is the figures in Southeast Asia. So if you look to the map about the IDF in Asia region will increase 68%, as I mentioned. It's already about 152 million, and by 2045, at 45, and the proportion of undiagnosed diabetes is the 3rd highest of the IDF region at 51.2%. Only 10.1 billion USD was spent in diabetes in the Southeast Asia region. Next, please. So the proportion and the number of adults who died from diabetes before age of 60 is about 6.9%. In the IDF Southeast Asia region in 2021. This is according to the last atlas. The proportion of the region, the proportion of the pregnancy affected by the hypoglycemia is the highest among IDF region at 25%, almost 25%. About 10.1 billion was spent on healthcare for people with diabetes in IDF Southeast Asia region in 2021. Next, please. Okay, this is the top countries actually. So they put it in so the highest one is India, 61.3 million. The second one is Bangladesh, is about 8.4 million. This is in 2011, and in 2021 is 13.1 million. Sri Lanka is 1.1. This is in 2011, and 2021 is about 1.4 million. Nepal is 488, and in 2021 is 1.1. Mauritius is 138, and in 2020 is about, it's a double, 250.400. Next, please. So by country, if you look to the countries, because for example, China is, because it is in Asia, it's about 140.9 million, has the largest number, followed by India. So first China, and then India, and the Asian countries, other, including Pakistan, Indonesia, Bangladesh, are among the top 10 according to the Atlas, IDF Atlas. Next, please. This is show you the top 10 countries, not only from Asia, but also from other countries. So, for example, number 1 is China, number 2 is India, 3rd Pakistan, 4th United States of America, and then the 5th is Indonesia, 6th is Brazil, 7 Mexico, 8 is Bangladesh, and then 9 Japan, 10th is Egypt. This is in 2021, and then in 2045, it's there. There's a change. Second, the 10th is Egypt, but in 2045, Egypt will come 9th, and then Turkey will join the top 10. Will be the 10 of the country is increasing in diabetes. Next. This is come from EASD and also from the American Diabetes Association. Show about the number of the promoted research from the Asia. So in Europe about 55 million, Middle East about 55, Asia about 251, North and South America is 80 million. This is for the better diabetes care in Asia. Next, please. Okay, this is the showed from Mr. Abdul Ghaffar. They show that the number of the people, number of the leaders in thousands, in thousands. So you mentioned, you will notice that the increasing from 2000 to 2025, there is a very much increase in the numbers from Bangladesh up to the Sri Lanka. Next, please. I remember the IDF is emphasized in the National Diabetes Prevention Program. They ask all the countries, either in the Southeast Asia region or in the Middle East region, to have the DPP. This is very important because by this program, you can tackle the diabetes preventive diabetes, and also to have a program focusing on prevention. Next, please. So the DPP, according to the IDF, is an evidence-based lifestyle change program for preventing type 2 diabetes in those at high risk. This program actually is provide an infrastructure to facilitate collaboration among federal and state government agencies, community-based organizations, employers, insurers, healthcare professionals, and academia and other stakeholders. Next, please. Next, please. Okay. Now let us look to the no, before the previous slide, please. Okay. So there is a different program actually in the world focusing on the lifestyle changes. For example, in China, they have that group-based RCT was the first longest running of such studies. It began in 1986 with a follow-up study conducted in 1997 to 2006. The study actually demonstrated a 43% insulin reduction in the intervention group after 14 years when compared to the control group. It's a very, very successful prevention program in China. In the US, they have what we call it DPP, the US Diabetes Prevention Program. It began in 1996. The study found that lifestyle change interventions focus at 4.7 weight loss and moderate increase in physical activity over 1 year achieved about 58% relative risk reduction in type 2 diabetes, and that use of the metformin achieved about 31% reduction. When compared to a placebo, the TPP used in terms of 1-to-1 counseling with the minimum of 50 racially and ethnically diverse individual across both male and female genders at high risk for type 2 diabetes, elevated plasma glucose about 95 to 25 millimole on fasting glucose of 7.8 to 11 millimole. Next one. Next, please. Next slide. Okay, and there is other program actually in Finland. They call it the Finnish DPS, and actually, no, please, the previous slide, please. The previous slide, please. Okay, thanks. So we have, as I mentioned, that there is also a prevention study program in Finnish. They call it Finnish DPS, and they started in 2001. Tested lifestyle intervention in a community-based primary healthcare setting, and designed and implemented at high-risk screening system for type 2 diabetes that is used worldwide, called the Finnish type 2 diabetes score. The study demonstrated, is very important, at-risk reduction of 58%, as well as a legacy effect of 43% reduction in type 2 diabetes in 3 years after completion of the study. In Japan, also they have one, they call Japanese DPP, conducted in 2005 in male participants with the IGT more than 150 milligram per deciliter, found a cumulative 4-year incidence 78 beige 2 of 11 currently died about 2019, about 1970 diabetes of 9.3% in the control group versus 3% in the interventions group. Next, please. Next. Okay, let us now go to the India. India, they have also they have a very good diabetes program, Indian DPP1 trial. That's what is conducted in 2006. Was a community-based random involving 531 subjects with IGT across 3 interventions arms. One was given advice on lifestyle modification. One was treated with metformin, and the other was given the lifestyle modification plus metformin, and the one control arm. A relative risk reduction from 26 to 29% after 30 months was similar in 3 interventions arm. Addition, 3-year results suggest that both metformin and lifestyle changes were cost-effective in preventing type 2 diabetes. Next, please. Next. Okay. I was just going to give you an example of from the MENA region in my country, Qatar. In my country, Qatar, what they call the Qatar Diabetes Prevention Program, QDPP. It's a research project expected to transform a way for diabetes prevention. Will start recruitment of subjects early in 2020. The research program aims to identify the best method to predict, prevent, and reverse type 2 diabetes. The 5-year program is funded by Qatar Foundation and Qatar National Research Fund and co-funded by the Hamad Medical Corporation. The QDPP research project supports the National Diabetes Strategy led by the Ministry of Public Health. Next, please. Next. The QDPP is composed of 7 complementary sub-projects. The project number 1 is aimed to prevent the progression of the pre-diabetes in type 2 diabetes into type 2 diabetes. The project 2 is aims to find the best method to prevent gestational diabetes in subjects with diabetes risk factors discovered by the pre-marital screening. Project 3 is aimed to find the best method to prevent progression of gestational diabetes into type 2 diabetes. Project 4 is aimed to achieve diabetes remission in patients with newly diagnosed type 2 diabetes. And then Project 5 aims to identify genetic factors associated with pre-diabetes and type 2 diabetes. And Project 6 aims to identify the proteomic and metabolic markers associated with the pre-diabetes and type 2 diabetes. Project 7 is aimed to develop e-health tools and mobile application to support lifestyle intervention for diabetes prevention and management. Next slide, please. Next. Okay. There is a Transform a Digital Diabetes Prevention Program. This is a new concept that transform, integrate interactive mobile compound, example, smartphone application, wearable tracking device, example, activity tracker, remote health monitoring, hardware, example, digital scale, and professional health coaches to effectively address the complex factors that impact behavior. Transform is a 12-month intervention that uses the same 2-phase program structure as the CDC's program, a 16-week high-frequency core intervention followed by 8 months of complementary maintenance program to support the new health behavior. Next, please. There is a very important factor that we always, one of the challenges is the policy makers. So the policymakers face a number of challenges when they attempt to implement changes needed for improved management and prevention of diabetes. Next, please. Next. Okay, also one of the challenges is about the health service reform. The effective surveillance and management of diabetes may require rethinking traditional model of healthcare. The ideal model is one that takes an active approach to support patient health over the long term and a positive role in activating behavior change. Then the second one, we have also disease versus broader health focus. To gain support for the prevention of type 2 diabetes, policies need to include broader cross-disease perspective that concentrate on risk factors rather than on the disease. That's a very important point. This approach creates a more compelling and consistent program for action. Next. Next. Okay, now we have the health ministries versus cross government. Many elements of the diabetes care are managed by the health ministry. We know that. However, the wider preventive agenda calls for a cross-departmental approach that involves other ministries such as education, planning, transport, and industry. Long-term frame, turning the tide on diabetes will take longer than a single parliamentary cycle. Therefore, the emphasis should be on developing and embedding coordinated multi-party commitment to action that is sustainable over the medium term. Next. Next. We have the tailored approach. There will be no one size fits all solution. Suitable intervention differ from country to country, align with the country's different cultures and degree to which they already have an environment focused on prevention. There's other challenge is the prioritizing, carrying out the extensive agenda for managing and preventing diabetes require both time and resources. To secure this, it is necessary to make diabetes a priority for both the public and the politicians. This is not an easy task, given the competing priorities that these groups have. Next one. Next. Okay, the policy goals. So now let us look to the policy goals. Next. So the key goals for the policy makers: minimize and reduce the risk of type 2 diabetes and its complications by increasing knowledge, skills, support, and access to the quality services. Very important, and reducing environmental risk. Next. Okay, primary prevention of type 2 diabetes in South Asia, challenges and the way forward. Next. Challenge. Okay, we have to translate the research funding into community-oriented upstream programs poses a huge challenge because of the following characteristics. South Asia is a diverse region with a huge population consisting of nearly 20% of the world population. Number two, existence of the varied rates of literacy, poverty, socioeconomic disparities, urban, rural, and cultural differences. Three, high risk for type 2 diabetes, cardiovascular disease, hypertension, and associated metabolic disorder. Metabolic abnormalities developed at young age. Therefore, preventive strategies have to be started in early life. Next. Okay. This is some challenges in different countries in Asia. So, for example, in India, guidelines have been laid down by the Indian Council for Medical Research, ICMR, Government of India for providing minimum standards of care, prevention, survey of disease prevalence, and training health services. The Ministry of Health, Family Welfare has launched the pilot phase of the National Program for Prevention and Control of Diabetes, cardiovascular disease, and stroke. This is one of the effort in India. In Nepal, the Nepal Diabetes Association has active in diabetes detection and awarenesses raising programs. A number of challenges, including issues related to the maternal and fetal nutrition and pregnancy and diabetes, have been identified, which are most linked to cultural practice and beliefs. Next. Next. Okay, the challenges in Bangladesh, the diabetes prevention study, joint program of the Diabetic Association with the Bangladesh and the University of Oslo, Norway, to prevent type 2 diabetes in subjects with impaired glucose tolerance has recently been completed, funded by the World Diabetes Foundation. The objectives of the project have been to raise public awarenesses about diabetes, to train doctors to improve national healthcare capacity, and to develop a national policy of diabetes prevention with endorsement by the Minister of Health. Culturally suitable strategy for creation of awarenesses have been developed. Next, please. Next. In Sri Lanka, the National Diabetes Center for Sri Lanka, with the collaboration of the scientists at the King College, London, UK, has reported a high prevalence of risk factor for type 2 diabetes in youth, an adult aged between 10 to 40 years. The study is part of the research program aimed at creation of awarenesses and developing methods to prevent diabetes in young Sri Lankan. Next. Next. This is the Healthcare in Gulf Cooperation Council country in the MENA region, a review of challenges and opportunities. This study was undertaken to review the healthcare status in the Gulf Cooperation Council, GCC, member of state, and explore current challenges and future opportunities. Next. So there is challenges and opportunities in health services delivery and workforces, healthcare financing, informations and research, public-private partnership with the consumer and community, public health and clinical leadership, and strategic vision. Next. Because proven and effective action to tackle diabetes joined in the national effort, diabetes prevention and management can be improved with strong health system. This is a very important point. Number two, there are interventions and lifestyle changes that can improve the health outcomes of people living with the risk of diabetes. Everyone can play a part in preventing type 2 diabetes. It's not only the government, not the private sector, but everyone. This is the responsibility for everyone that can play a part of preventing type 2 diabetes. Raise awareness of pre-diabetes. Unfortunately, this is a very important point. Promote the national DPP as a covered health benefit. Next one. This is the last slide. Thank you very much for your listening.
Thank you very much. After that wonderful overview by Dr. Hamak, we know that retinopathy is one of the leading causes of blindness in the world, and it's a complication, it's a dreaded complication of type 2 diabetes. To share her overview on the future prospects of screening of diabetes retinopathy, I now call upon the next speaker, Dr. Shehnaz Karadaniz. May I have her? Yeah, thank you. Dr. Shehnaz is a professor of ophthalmology at Istanbul Florence Nightingale Hospital. She's a founding member and a board member of Turkish Diabetes Foundation. She's a president and of Living with Diabetes Association, and I welcome her to please give her talk. RX events.
Is Dr. Shehnaz joined yet, or I don't see her name?
Ria, RX events.
Yes, ma'am.
Is Dr. Shehnaz here?
No, ma'am. No.
And Dr. Adel, is he here? Dr. Adel Syed is here.
Dr. Adel Syed is also not.
I've already informed actually RX event on phone and the group also, but they have not joined yet.
Yes, I had also mailed in the.
Okay. In the meantime, we can probably discuss about diabetes prevention program. Ria, please let me know once she joins in.
Yeah, sure, ma'am.
Yeah, any one of them. So we can have either of the speakers. Dr. Vyas, I think diabetes prevention program will go a long way in really taking a little bit of a hold of the calamity that we are all facing today. In the post-COVID era, it's really gone exponentially high. So I think we need to have some good intervention so that we can take care of the future diabetic patients as well.
Definitely. It has to start from the prevention, from the basic of it, not only decreasing the burden of it, but we have to plan and see the future aspects that it should not further increase the burden of it.
Absolutely.
Not only type 1 patients are increasing, but type 2 patients have exponentially gone up after the COVID. It may be because of the steroid therapy or the lifestyle, whatever it is, but they have gone extremely up, as we have already seen in the data which sir told us.
Yes, absolutely. And I think we are special people, being the thin fat Indians, as we put in. And in fact, the Kerala Diabetes Prevention Program has published a data showing that 1/3 of the population actually has a normal BMI, but a very high fat percentage is quite high. So that means just by checking the height, weight is not enough really for us to screen diabetic patients as well. So I think we need to go beyond it. And I think the adolescent obesity is a big worrying factor now, because everybody is glued to the screen like how we are today. I know I think that's something which is really worrying. So I think intervention should start right at the children, at the school level now.
Definitely. If we convince somebody to eat healthy, it is actually they are taking it as we are telling them to be on a diet.
Absolutely.
The normal diet has completely changed.
Absolutely agree. Absolutely agree. And unfortunately, the fast food is,
A basic diet.
Big way. And initially, in the early stages, the rural population was quite healthy because they used to have home cooked food. But now, I think with the spread of the media and the availability and the advertisements, I think everything is available everywhere, and that's where we are going to land up in problems. So similarly, if you talk about retinopathy, I think a wonderful thing that a colleague of mine and I was doing was we were screening retinopathy in rural India, and then you send across the pictures and we get it evaluated from an ophthalmologist. So I think that's another way that we can help being glued to the screen in a better manner rather than increasing our BMI. So, have you had any experience? Do you routinely screen for retinopathy in your patients as well?
Yes, we routinely do it. Actually, if there is no risk factor about it, we do it yearly, and otherwise every 6 months.
Perfect. I think early intervention is the key, because they do not realize they do not have symptoms, and that is what is a major drawback of diabetic complications.
Yes.
So I think yeah. Go ahead.
The first thing when we tell the patients to go for any kind of screening, their first response is, "But I'm fine. I'm completely fine."
I think that's the biggest hassle that we are going to face every time, because they don't want to check. They don't want to check for complications, and they feel it's a waste of money. But there are numerous patients who are diagnosed in the early stages, and recovery is much better, and the prevention to complete blindness is sort of restricted to the early stages, and then that is where I think we score over in treating the patients rightly and correctly. So
yes,
I think counseling is the key in every aspect here.
Yes, to give equal amount of time to all the patients and make them aware that whatever is happening is just the screening part of it.
Absolutely. I think that's one of the major things that comes into picture. The second thing is the food labels, because I think Indian government also should involve themselves more in food labeling, because there are so many food labels which are available, but most of us do not know how to read them. So if we can simplify it, and then you can tell them this is the amount of things that are there, even in whatever best we can do, because we are a carbohydrate rich country, and we are a sugar rich country as well. So whether it is good occasion, bad occasion, good omen, bad omen, everything has to start with a sweet. So I think if we can involve the government in such a manner that we can make the people have an informed food. So it need not be a diet food, but they can at least be informed. Like for example, right now wheat is the main culprit. So everybody is talking about wheat. But if you ask me personally, I don't think wheat itself is bad, or anything in moderation is acceptable if a patient is not diabetic. So I think we have to make the patients aware about all of these programs. And I think the best way out is the social media, because there are a lot of information, a lot of wrong information by wrong people looking out for clicks and likes and subscriptions. So I think that is where I think if we can get the government involved in some manner, I think we can do. And I think RSSTI is doing a wonderful job at that. Banchi sir is doing a wonderful job at that, where you are having patient education programs going on at every point on social media. So I think that is a wonderful.
But people have to understand the mindful eating habit part, because after the entire counseling, the only question, but can I eat this? What was the session about then?
So true, so true. I think you hit the nail on the coffin. So I think, yeah, that is, I think, where we probably lack a little. So we need a little mindful eating, as you properly said. Ria, RX events.
Yes, ma'am. Next speaker is not joined yet.
Okay.
I went also, but
The third speaker is also not here as yet.
Do we have their
No.
sessions? Do we have their sessions recorded or?
It's live, ma'am.
All right.
So, okay. So if you talk about, let's talk a little about diet. So what do you, diet and exercise, I think, form the basis of any prevention program that we can talk about. So I think we need to instill that feeling in the mind that it is not how much you walk, but how much you exercise, how much time, how much speed. But I think it is more to do that you have to keep moving. If you can keep moving, I think that's the way to go to prevent any kind of non-communicable disease in the future.
Lifestyle diseases, yes.
Absolutely. So, for example, if you talk about a couple, one can walk at a pace where he can cover probably 5 kilometers in an hour, and the other one can probably cover only 1 kilometer in an hour. And then there is always a fight between them. So you have to count the number of steps rather than, the speed of the steps or the distance of the steps or the time per se taken to finish that amount of work and exercise. I think that forms a very important aspect as well.
Yes, that can be inculcated from the childhood, but I do agree with you, ma'am, but I also agree that some patients can just feel like they can run away. They can burn the diabetes by running, which is also not true.
Absolutely, I agree. In fact, most of the patients feel that if they do diet and exercise, their sugars are going to go away, and they will not need the harmful, as we put it, the medicines that are available with side effects. So I think overall, diabetes is a lifestyle disease. So we need to incorporate a good amount of diet, exercise, planning right from the start. Unfortunately, what happens is when the kids are young, they are playing a lot, and then they come into 9th, 10th, and 11th, 12th, and then they are busy either studying or they are busy socializing. And that puts an end to their sports activity. And we see a number of sportsmen who are playing on, district level, state level, national level, and then they suddenly go into jobs, and then they're sitting on the desk, and then they have no time to exercise. And these patients, I think, are more prone to develop lifestyle diseases than the people who have been, moderately sedentary, moderately active all throughout their lives. So we need to incorporate that as well into the picture.
I think there's a running RSSDI approach to it, that from 7 to 12 years, you have to change the lifestyle. You have to make the person aware or the people aware. So that is the age you can. Hello, ma'am.
Hello.
Hi. Hello, ma'am. Welcome.
Hello. Thank you very much. Am I in the right room? And Dr. Chen, for the lecture at your time is 10:45. My time is 1:15.
Yeah, you are in the right room, ma'am. You are in the right room. Your lecture is going to be your session is going to be started after some time.
Okay, good. So just want to make sure that you see me and you hear me, right?
Yeah.
Yes.
Okay. Thank you very much. I'll join you later on. Thank you.
Thank you.
Okay, so her lecture is after Diabetes Asia.
Yeah, that's the next state of the art lecture.
So we've got 2 speakers from that session now.
So do we move on to the next session, sir?
I think rest of the speakers in your session they are not going to join probably.
Yeah, I don't think they have joined in as of now, so I assume.
So I think we can start with the next session.
Hello.
Yeah.
Ma'am, just a second. We will search कि ये शहनाज का डॉक्टर शहनाज का recording आया है कि नहीं. So please wait for 5 minutes.
Okay, sure, will do.
Okay.
Do you want to continue the live stream till then? Yes, ma'am. As we were saying that we have this ongoing RSSDI project, making the young females aware so that the next generation is not born with weak pancreas, as we put it in layman terms.
Yes, absolutely. So I think it's a wonderful idea, especially for ladies, because I think women are the backbone of the society. And if you can train a woman to, exercise, keep moving, eat healthy, I think finally at the end of the story, she's going to cook for the whole family. So, so I think that's a good idea. And I think it's RSSI is doing a wonderful job at that. So, I feel the people who are into gestational diabetes is also, the numbers are going up nowadays, and we see more and more patients who are obese before conception. They have a lot of PCOS as well, and there is a lot of infertility as well. Infertility is on a rise as well. So, in your area, do you see similar kind of a picture?
Yes, very much so. Almost in the age of getting married has increased, so that the obesity is also a problem, and PCOS we find in 1 in 3 women. I don't know the exact stats of it, but it looks like the picture is very real.
Absolutely. Absolutely. I think infertility is also gone up extremely and to a great extent. And the next generation is going to be in big trouble because they're obese right at the adolescent level. So it's just going to keep on increasing. And that is the biggest fear that we have, because we know that once the patients are diabetic, they need extra care. They need to take their sugars, under control to a greater extent, because most of the patients, especially from the peripheries who come to me, they always say that the values are within the limits which are given on the paper. So my sugars are under control. So it takes double the effort to make them understand that those values are not for you. And
Exactly.
I make it a point to write on every paper what your target range should be. So I think if we can incorporate that and make the women more aware of their bodies, more aware of their sugar levels, and how they can continue with the diet henceforth, I think that again will be a huge boon that we can have.
So the learning process will be now shifting from points in range to time in range.
Absolutely, absolutely agreed. Absolutely agreed. So
we have one more speaker from the next.
Yeah. Good morning, sir.
Good morning.
We'll hand over the session, ma'am.
Yeah, I think we can hand over the session.
Parimal sir, can we hand over the session to the next chairpersons and start?
You can, but I'm not seeing their name. The chairperson. I have seen. I see all the three speakers are there. We can call because it's still 10:30. So the session would have started at 10:45. For Dr. Mayura Kale, and I'll arrange for the call them, Dr. Kale and Dr. Ghosh.
Yes, sir, no problem.
I'll do that.
Sir, if you permit me, may I introduce the next speaker for the state of art? Dr. Julian Chen is here.
Ma'am, it's still 10:30. The next session time is 10:45. So probably because of that, the chairperson of that session have not joined.
Yes,
I'm making phone call to them. I'm trying to arrange to make a call to them.
Okay.
Can I ask, while we're waiting here, when it comes to our talks, you will be sharing the screen and then we'll be delivering it from our computer, yeah?
Yes, sir.
Yeah.
I'm sorry, sir. Two speakers could not make it in the previous session, so that's the reason for the delay. I'm extremely sorry.
No, it's fine. I mean, I'm not due to speak for an hour yet, yeah, so.
So since you're here, how often do you conduct screening programs in your country, in your area for diabetes?
How often do we have screening programs?
Yes, sir.
It varies from place to place. So that some places have got, it's targeted just now in areas where there's a higher prevalence of type 2 diabetes.
Sure.
And that's particularly places that have got a large ethnic minority population. So in England, it's places like Birmingham and Leicester, where if you do screening, you're going to have a very high pickup rate, rather than places that have got a lower rate. But it's not universal just now.
True, very true.
Dr. Shefali, I think you can take this
we'll
of
hand over
Dr.
Yes.
Kale, and you can begin the session. And if Dr. Ghosh joins us later.
I think Dr. Ghosh is already here, sir.
Okay,
So,
he's already here. So you can begin the session. I think you can.
I thank Dr. Panchi Sabu sir and the entire team for organizing this session, and I hand over the mic to Dr. Ghosh.
Hello, Dr. Ghosh. You are the speaker for the next session, I think.
Chairperson, Dr. Ghosh is the chairperson.
Chairperson, yes.
So you're muted.
Hello.
Yes, so we can hear.
Yeah. So can you get the slides for our speaker? So our first speaker for today's talk is none other than Dr. Julian Chen. So Dr. Julian Chen, the professor, is a clinical scientist graduated from the Liverpool University, UK, with accreditations in endocrinology, clinical pharmacology, after receiving a period of training in psychiatry. She is currently the professor of medicine and therapeutics, founding the founding director of the Hong Kong Institute of
very diverse. And these are some of the diversity points that we have. Every 50 kilometers, 100 kilometers.
Her major area of interest includes epidemiology, genetic, clinical trials, and care model in diabetes. She is one of the principal investigators.
It's difficult to be a doctor in India, to be treating diabetic patients constantly.
So, with this, I just want to welcome Dr. Julian Chen for her talk.
So many things to be talked to the patient.
Thank you. Can you hear me?
And most of the time,
Can you hear me? Yes. Thank you. So I just thought, could you hear some of the background noise, or is it just my? Are there some background noise? Will it interfere with the presentation?
Yes, I think that's taken care of.
Okay, so thank you very much indeed. So first, I would like to thank the organizing committee for inviting me to give this talk on RAS inhibitors and pneumonia and beyond. So I'll share my screen first. Can you see my screen? Yes, thank you. Okay, so these are my disclosures. I think diabetes is a very complex disease. We are not just dealing with hyperglycemia, but the clustering of hyperglycemia together with dyslipidemia and hypertension is associated with the activation of many pathways, as well as the loss of some of the protective pathways, resulting in cellular death and loss of structure and functions, resulting in cardiovascular renal complications. And of course, this is further influenced by epigenetic and genetic factors, as well as treatment and environment factors. One of the most important pathways, of course, the renal angiotensin system. The defining studies regarding the benefit of RAS inhibitors are really the LIFE study as well as the Renal studies. In these studies, which are looking at patients with hypertension and left ventricular hypertrophy, we could see that actually in the 9,000 patients, comparing to atenolol, losartan, ARB, is associated with nearly 20% reduction in terms of cardiovascular outcome. And in a subcohort of patients with diabetes, because of the high-risk nature, the benefit is even more marked. Patients treated with the losartan had nearly 25% reduction in terms of cardiovascular outcome. The Renal study is another defining studies, again, showing that patients with diabetic kidney disease had 16% reduction in terms of composite endpoint and about 25 to 28% reduction in risk for doubling of serum creatinine in end-stage kidney disease. And of course, this is also the period where the definition of renal endpoint was first coined. So now ARB is really the standard care for people with diabetes, particularly those who have got cardiovascular and renal disease. We are now still in the middle of a pandemic, and at the beginning of the pandemic, a paper in Lancet has actually raised some alarm because the use of renal angiotensin system blockade is associated with sometimes the elevation of ACE2, which I'll go into in a minute. And the SARS virus actually can hijack the ACE2 to enter into the cells and cause a widespread damage. And so there was a concern whether patients treated with RAS inhibitors are at particular high risk for developing SARS. But after a period of controversy, a large number of studies have come out really showing that there's no evidence pointing to increased risk of COVID-19 in people who were treated with RAS inhibitors, and that people should not discontinue or change their treatment to decrease the risk of COVID-19, given the cardiovascular renal protective effects of ACE inhibitors or ARB. Indeed, going into the literature, even back in 10 years ago, people have asked the question, because of the pluripotent effect of the renal angiotensin system, whether the use of RAS inhibitors, be it ACEI or ARB, may reduce the risk of pneumonia. And this is one of those meta-analyses really looking at both randomized clinical trials as well as cohort studies, and essentially showing that for ACE inhibitor, there seems to be a reduced risk of pneumonia, and this was not seen in patients with ARB. But of course, these are really post-hoc analysis, and none of them had pneumonia as the primary outcome defined a priori. But reassuringly, one could see that most of the hazard ratio is actually on the left side of the unity line. In Hong Kong, which has 7.7 million people, we are fortunate to have universal health coverage provided by a single healthcare organization, which is the Hospital Authority, similar to very much the NHS in UK. And we share a territory-wide electronic medical record system, which has provided a rich resource for analysis of real-world evidence to complement clinical trial data. And so we have published a series of papers. One of these is actually looking at nearly 0.8 million adults, followed up between 2001 to 2016. And we have noticed that because of the improvement in care standards, also access to these life-saving medications, there is a decline in terms of the death rate by nearly 70%, particularly in the elderly people over this 16 years period of time. However, we still see that actually the young people have 5 to 8 increased standardized mortality ratio compared to non-diabetic individuals. But by and large, the black line, which is the general population, there was still an overall reduction in terms of standardized mortality ratio. And this was in part because of the declining in terms of CVD death, cancer death, but unfortunately, the pneumonia death has actually not changed. And now actually 1 in 4 people actually died with pneumonia is now really a leading cause of death among people with diabetes. So making use of this Hong Kong Diabetes Surveillance Database, which as I mentioned consists of 0.8 million people with diabetes followed up in our public system, and about half of them have undergone very structured assessment, which actually allow us to perform a very comprehensive analysis because we can have adjustment of the baseline variables. And so we've been publishing quite a lot using this Hong Kong DSG. In this particular analysis, we asked the question whether there might be time varying risk association of RAS inhibitors with pneumonia in nearly 250,000 of patients. So this is the study design, and they're analyzed by Dr. Elaine Chow and Dr. Aimin Yan. Basically, the electronic medical, territory-wide electronic medical record system came in place in 2000. So we started at 2002 to ensure that most of the data are now captured. And then we defined actually the index date at the date of the RAS inhibitors actually being started. And then we actually adjust for the baseline for all the covariates, 1 year prior to the initiation of the treatment. And then they were followed up, over a period of time, and they were censored actually in 2018. And during this period of time, we captured all the medications, laboratory results and events and hospitalizations, and we did various adjustments. So essentially, we had 2 cohorts. This is the population cohorts. So this is the Hong Kong DST, which have actually, these people have actually undergone structured assessment where they actually have their eye, their feet, the blood, and the urine assessed. And these 0.5 million people. From there, we actually curated a subset of people. These are new users of RAS inhibitors, and then for further analysis. at our hospital, where we actually started this diabetes register in 1995, which was then taken up by the hospital authority to become a territory-wide diabetes risk assessment and management program. We actually also performed a similar curation of data, and in this particular cohort, we were able to retrieve the pneumococcal and influenza vaccines. So as you could see, among these people, this is nearly 250,000 patients, and this is about 13,000 patients for analysis. After exclusion of various criteria. Firstly, when they enrolled to these registers, there about 30% of them were treated with RAS inhibitor. Subsequently, 50% of them were put on RAS inhibitors and 50% were not. We further excluded patients who had type 1 diabetes, who had prior history of cardiovascular disease, cancer, COAD, or asthma, and also they were they have less than 90 days of exposure to RAS inhibitors. And so in the population-based cohort, we could see that 52% of these people were new RAS user, and about 73%, half of them were treated with ACE inhibitors only, and then about 1/3 of them were treated with ACE inhibitors and then later on to ARB, probably because of side effects, and then about 15% were treated with ARB. About 47% were never exposed to RAS inhibitors, and we find similar data actually distribution in the diabetes register. So this is really the top line results, and here you could see that actually in the population-based cohorts, the patients actually treated with RAS inhibitors actually had about 22% risk reduction for the first hospitalization due to pneumonia. And also 50% risk reduction in terms of deaths related to pneumonia as defined by the ICD codes. Interesting to note, actually, in the register cohort, where we actually adjusted for the vaccines. For this particular cohort, as I already mentioned, we adjusted for all the baseline risk factors, the time-varying cardiovascular cancer event, A1C, lipid, renal function, and medications during the follow-up. In the Hong Kong Diabetes Register, which is a smaller cohort, but we also adjusted for additional exposure to pneumococcal and influenza vaccine. We see that actually, again, there was consistent risk reduction in favor of the RAS inhibitors in terms of pneumonia hospitalization and death related to pneumonia. Because people who were not treated with RAS inhibitors might be a lower risk, therefore we curated another cohort. Actually, they were started with calcium channel blockers, and we also found that patients treated with RAS inhibitors also is associated with about 20% reduction in pneumonia and death from pneumonia. And this is after a propensity score matching. People with chronic kidney disease are at higher risk of actually developing pneumonia and related deaths. So we also looked at the risk association of pneumonia and the RAS inhibitors in people with different stages of EGFR. Again, here we could see very consistent reduction, 20% reduction in terms of pneumonia events in favor of the RAS inhibitors, and about 50% reduction in terms of pneumonia related deaths in all stages of EGFR. We further compare among the RAS inhibitors patients ARB versus ACEI, and here it's very interesting to note that for the first pneumonia hospitalization, again, there was actually a greater reduction. Only ARB was associated with reduced pneumonia events, and for deaths from pneumonia, again, it was the ARB which was associated with better outcome. So why should there be a difference between the ARB and ACEI? I think it is useful to revisit the complex biology of the RAS pathway. Here you could see that, of course, the angiotensin 2 is the bad guy. It has a lot of proliferative effects and also inflammatory effects. And so there are two ways that we can block the renin-angiotensin system. So directly, we can actually block the using ARB, we can block the effects of angiotensin 2 by the inhibition of the angiotensin 1 receptor. And this will result in reducing a lot of the inflammatory, oxidative stress, fibrotic, thrombotic, and fibrolytic, and also proliferative effects. One of the things is once we actually block the AT1 receptors, there is an inevitable elevation of angiotensin 2, and this angiotensin 2 can then be cleaved by the ACE2, okay, which to form angiotensin 127, and this 127, angiotensin 127, interacting with the MAS1 receptor, actually have a lot of cellular protective effects. Similarly, the elevation of angiotensin 2 is also accompanied by the elevation of angiotensin 1 because of the blockade of the AT1 receptors. And this is also cleaved by the ACE2 to actually form angiotensin 129, which also have actually a cellular protective effect. So this actually is contrast to ACEI, which really only just block the conversion of angiotensin 1 to angiotensin 2. So the effect of ARB is actually more widespread than ACE2, the ACEI. The other point about ACEI is, of course, ACE is not only involved in in converting angiotensin 1 to angiotensin 2. ACE also breaks down bradykinin. So by actually blocking the ACE, we might actually have accumulation of the bradykinin, which can actually interact with the bradykinin receptors to cause some adverse effect, which might including inflammation, vasodilatation, angioedema, and cough. So this is really one of the reasons why sometimes patients with ACE inhibitors have angioedema. And ACE2 here can actually block this conversion facilitates the breakdown of the bradykinin. So against that background, ACEI reduced the conversion of angiotensin 2 to angiotensin 1 to angiotensin 2. However, it will reduce the breakdown of bradykinin, and the increase in bradykinin may cause cough, which might lead to treatment discontinuation or poor compliance, vasodilatation, and rarely angioedema. So in a way, it might counter some of the benefit of the reduced angiotensin 2 activity. On the other hand, ARB blocks the angiotensin 2 receptor, type 1 receptor, and then it will increase the angiotensin 2 would actually, the angiotensin 2, the angiotensin 2 is converted by the ACE2 to angiotensin 127, and then also the angiotensin 1 is converted by ACE2 to angiotensin 129. All these polypeptides actually have organ protective effect. Therefore, actually, the ARB would actually reduce the angiotensin 2 activities. At the same time, this is accompanied by increase in ACE2 with actually a beneficial effect by increasing some of the peptides of 127, 129, and also breaking down the bradykinin. So why are these information important? Sometimes we forget the importance of pneumonia, particularly in people with diabetes. This is a epidemiological study looking at two cohorts, the cardiovascular health study cohort and also the ARIC cohort. And here you could see that actually people who have pneumonia actually have about 2 to 4-fold increased risk of cardiovascular disease in the immediate period from 1 month, and which might go all the way to 1 year after the pneumonia event. So in this analysis, very beautifully, they actually stratified patients into different risk groups. So people who were actually in the 21st percentile covariate risk profile, you could see that patients who had a pneumonia, they had actually got about 2 to 3 times higher risk of cardiovascular death. And that actually lasts even well beyond 10 years. And again, you could see here, these are, they give some scenario. For example, this is an elderly woman with 2 risk factors, and of course have high event rate mainly because of the age, whereas a middle-aged woman, actually the risk is lower. For those people who are in the 50 percentile covariate risk profile, again, you could see the rate of cardiovascular disease is higher, and particularly those who have a history of pneumonia. Here again, these are people who are in the 70th percentile covariate. So classically, like this patient, 77 years with multiple risk factors, hypertension, history of smoking, LDL cholesterol, obesity, chronic kidney disease. And you could see that these people already have very high risk, 4% per year in terms of CVD. And then this is increased to nearly, to 80% by, 10 years. So here we could really see how pneumonia can actually amplify cardiovascular risk to increase the risk of cardiovascular disease. And this forest plot really demonstrates quite nicely that particularly in the first 90 days, okay, you could see that these people, because of the activation of the inflammatory processes, the cellular proliferative processes, after the pneumonia, these people have nearly 2.5-fold increased risk of cardiovascular disease. And this actually remained fairly high, actually up to 1.8-fold increased risk at 2 years. So really having a pneumonia is not very good news in these individuals who've got high cardiovascular risk. So why do people get pneumonia? So clearly influenza is very important. And this is a paper from China where they actually looked at the flu. Every year we have actually a seasonal flu. And in this particular year, they actually found that about 50% of these patients actually died after a influenza. So who are the people who are likely to die after influenza associated severe pneumonia? And not surprisingly, it's patients who have chronic COPD as well as diabetes. These people have twofold increased risk of having severe pneumonia after influenza. So having influenza vaccination is really very important. So again, in the middle of the pandemic of COVID, people start looking at these issues. And again, UK, because they have this huge GP prescribing databases, they reported that there were about 5 million people who have ever exposed to ACEI, 4 million people ever exposed to ARB. And then they could see that actually patients who were exposed to ACEI or ARB have nearly 50% risk reduction in terms of having influenza related influenza risk. And again, the risk of actually having influenza is actually the risk association or the reduced risk association of influenza associated with ACEI and ARB actually accumulates over time, so that the longer you have been on ACEI or ARB, the less likely you actually get influenza. And this actually complements very well with the analysis. We actually found that using our database, we're able to demonstrate that the beneficial effect of RAS inhibitor RAS inhibitors in terms of reducing first pneumonia, hospitalization, or death from pneumonia actually accumulates over time. So this is very important given that pneumonia and also influenza are very common in people with diabetes. And yet only 50% of people are put on RAS inhibitors, probably because they do not have cardiovascular renal disease, because they do not have hypertension or albuminuria. So ladies and gentlemen, I would like to conclude by highlighting that the renal angiotensin system is widely expressed in many tissues, not just in the pulmonary system, but also the cardiovascular and renal system. They are widely expressed with pro-inflammatory and cellular proliferative effects. Both randomized clinical trials and real-world evidence confirm the cardiovascular renal protective effect of RAS inhibitors. ARB would decrease the angiotensin II activity by directly blocking the AT1 receptors. The accompanying increase in terms of ACE2 would actually convert the increased angiotensin II because of the blockade to increase angiotensin 1 to 7 and 1 to 9, as well as to promote the breakdown of bradykinin. The consequences, there will be further reduction in terms of the inflammatory and proliferatory effects. So from that point of view, it has actually got more beneficial effect than ACEI. Not to forget that pneumonia is a leading cause of death, okay, because of the reducing incidence of cardiovascular disease and also elderly population. Diabetes increases the risk of influenza-related severe pneumonia by 2-fold. And those people who have a pneumonia, they actually have 2 to 4-fold increased risk of cardiovascular disease, particularly in the first 2 years after the pneumonia. And this is so particularly in people with multiple risk factors, including diabetes. I think, you know, suffice to, although many of these are observational data, but taking into consideration the mechanisms of the drugs, you know, the biological implications of the RAS, the renal angiotensin system, I think it is fair to conclude that the use of rouse inhibitors is associated reduced risk of influenza, pneumonia, and also related death by nearly 50%, which will accumulate over time, and therefore making it very important in those people who have young onset diabetes, who face long disease duration. And use of rouse inhibitors is associated with organ protective effects, which is beyond the cardiovascular renal system. Thank you, chairpersons. Thank you.
Thank you, ma'am. It was such a wonderful talk. During the COVID, there was a lot of discussion regarding RAS inhibitors and association with COVID, and your deliberations have really clarified all the doubts. And it have been the studies which have been already there. It's you just put some more information to our confusion. Thank you.
Thank you very much.
So,
thank you.
RX team, can we have the slides for this next speaker? So our next speaker will be Dr. Mahel Vajasuriya from Sri Lanka. So our sir is MD, FRCP and FCCP. He's Honorary Secretary of Diabetes Association of Sri Lanka, Honorary Director of National Diabetes Center. He's the chair of IDF SEA 2003-2009, and he's also an Executive Director for Global NCD Alliance from 2017 to 2019. IDF Board of Management from 2000 to 2003, and IDF Executive Board from 2000 to 2009. So on this note, I welcome our Dr. Mahan Vajasuriya for his deliberation. Over to you, sir.
Thank you, Chairperson. Let us now proceed with our presentation. Yeah. Can you see what is projected? Is there a problem of the audio or the video?
So it's fine, sir. It's audible and visible too.
Now, I have asked a very basic question. Everybody knows about diabetes, but
Sir, can you zoom the screen, sir? So can you put this in slideshow?
Already put it in the slideshow. We already make it in the slideshow.
Hello.
Yes, can you see now the
Sir, there is a below button on zoom out, zoom in, besides the zoom out and zoom in.
So here.
Yeah.
Is it okay?
In downside. In downside.
Yeah.
From the beginning.
This is a normal slideshow. I think this is a slideshow which can you see now the show slideshow?
No, ma'am. No, on the left side. Yes, from the beginning.
Is this the one start from beginning?
Yes, ma'am.
Yeah, there is a, it was on the top written setup slideshow. Please click on that.
Okay. Setup slideshow. Yeah. Okay. Shall I? Can you see now? Because for our laptop, we can see the full slideshow. That's why. Can you
Ma'am, can you just stop screen and then slideshow mode and then share screen?
stop sharing? Okay, I'll share screen. Can you see now the slide? Hello.
Can you see the slide now?
Slides is visible, ma'am, but not the full screen. It's not slideshow mode.
Yes, we can see the slides. I think why don't we just proceed? It's the, there is this screen. There's like a screen icon in the right lower, in the lower bar. If you can't do it, we can just see like this, right?
Can you see the slides that when does T2DM start?
Yes, we can see very well.
Yeah. Can we proceed then?
Yeah, can we proceed, please? Yeah.
Yeah.
Right. Now, I have asked a very basic question. When does T2DM start? Because we know that we have millions of patients all over the world. Some of them are young, some not so. And they have started the diabetes life in their way of thinking at different times. But there is agreement on an early start. So I want to take you through that. Diabetes has been known to mankind for several thousand years. However, consensus on etiology of T2DM was not formulated till 2002 in Colombo, organized by the DASL. IDF president and board was present, and the consensus was accepted. Diabetes can occur at any age. And in our study of 23,000 patients, we worked out the risk factors, the highest being physical inactivity, the others being race BMI, race waist circumference, and family history of T2D. Now I want to show you a graph which depicts an early start. The 5 to 14 age group gave us an indication of a very early evidence of prediabetes, which gradually increased to a tremendously high figure of 23% and 26% dysglycemia. Right? So this kind of indicator tells us that whatever the diabetic state of the individual patient is today, he has started his diabetic life pretty early, and therefore we have to concentrate on the early onset rather than the current onset of diabetes. The etiological factors agreed upon by this group of 500 odd senior diabetologists in Colombo, Sri Lanka in 2002.
Excuse me, sir. I think your slide is fixed, sir. It's not moving.
Good.
So I will go like this. Can you see now?
Can you see it now?
Yeah.
We will go this way.
The first etiological factor that everybody discussed was the genetics, which is a non-modifiable situation. The second being fetal origins, what happens in the mother's womb, which tends to produce problems in the future. The third is lifestyles, which has been depicted here, which adds to the problems of the fetal origins. And last but not the least, which a lot of people could not think was relevant, was stress. So we have 4 potential areas to discuss, right? Now, genetics was not a modifiable entity. Multiple genetic markers identified, no single marker has been associated. That is our problem. If there was a single marker, then life would be easy. We attack that situation and we produce a reduction in the prevalence of diabetes. We don't have that, but we have markers of varying kinds. Genetic engineering and counseling is not possible with this knowledge. Slow to change, unlikely to account for rapid increase. But rapid increase is the name of the game in diabetes type 2. Next. Fetal origins are modifiable entities, nutrition being critical, nutritional deprivation or excess, both are detrimental to the growing fetus. What is the interactive factor? Is it stress? Nutritional deprivation is the greatest stress in the world. T2DM emerges as pre-diabetes. From a normal body, it emerges as a pre-diabetic state. Obesity in childhood, which is preceded by undernutrition in utero. If there is undernutrition in utero, when the baby is born and thereafter, increased nutrition will be supplied by the mother, which produces this problem. Then the presence of a primordial state where the mother gives birth to a child tending to produce redirection of diabetes in later life, both in the baby. This has been brought forward by Yachnik from Pune, India. And in the case of a female child developing, a predilection goes further to the 3rd generation. So we have problems, multiple problems in that area. We are depicting that this way. I hope you can see it and understand it. Mother carrying a baby, first outside, then in the womb, and then on the 3rd generational transmission. Nutritional deprivation. Undernutrition in utero produces stress related to maternal undernutrition associated with low birth weight, presets metabolic syndrome. Now, we have studied patients in our group where a birth weight and subsequent raised BMI of developing metabolic syndrome under 2.5 kg at birth predisposes relative risk of developing metabolic syndrome to 8.1, which is significant. Nutrition postnatal. Postnatal nutrition is usually in the hands of the individual or the parents. Irregular meals is a classical situation which people don't disregard or don't regard as a problem, but it is a problem. Refined foods, poor satiety, quality variable, frequent bouts of hunger because the food ingested does not last till the next meal. Excessive total calorie consumption as a result of eating in between meals of a high calorie items. Lack of exercise to go with it, comfort seeking, and tending to stay in the same place even to watch the television. Obesity is the result of it. Lifestyles, modifiable lifestyles, abnormal nutrition and lack of exercise leads to obesity. Exercise has to start early. Children have to be allowed to play. There is a major problem of fear of the patient's parents, especially in the COVID situation where they won't allow the child out of the door. And they sit and watch television or computer or anything like that, and problems arise. Exercise must start early, must be regular and adequate. Nutrition should be qualitatively correct, quantitatively adequate, and should be on time so that severe hunger does not come about. Maintenance of ideal body weight and waist are essential. Creator of psychosocial problems. Modern concept of life has changed the emphasis from health, wealth, and happiness to wealth, happiness, and health, which is compromised. If pediatric stress, the trigger factor, may impair growth and development, accounts for a number of endocrine, metabolic, and autoimmune and psychiatric disorders. Prenatal, infancy, childhood, and adolescence are critical periods. Continues as stress in adult life. What starts in pediatric age group does not stop there. It goes further. Stress is a neuroendocrine response to a threat to physical health, mental well-being, and the survival of an individual from conception to death. Beneficial in the short term, detrimental in the long term, long term. Pathophysiology of stress. Stress leads to increased cortisol, adrenaline, and noradrenaline. Increased cortisol leads to elevated blood sugar and blood pressure. Elevated blood sugar leads to oxidative stress. Oxidative stress leads to insulin resistance, endothelial dysfunction, and apoptosis of beta cells. As depicted here, a slide from Antonio Cerillo indicating how stress works in the body. How do you define the mind? The mind is the main component of this speech because mind precedes all physical activity. Mind is the fast-track processor of all sensory inputs, past and present, and the creator of thoughts, words, and deeds. Integral part of the human body, as depicted by Professor George Crusoe, mind and body. Mind-body interaction. Man's greatest love is life. Life's greatest asset is health. Health determines happiness and longevity. Health is based on mental and physical well-being. If the body is unwell, the mind is under siege. If the mind is under siege, the body becomes unwell. So it's a bilateral equation, one producing the other. Mind-body interaction. Increased intake of food, reduced exercise leads to obesity. Increased desire for economic gain. Now this is a driving force. Leads to migration from a rural environment to an urban to a foreign in search of better prospects of financial gain. Failure of expectation, lack of contentment leads to stress. Failure of expectations is when the person does not reach the objectives that he started life with due to migration. Response to stress leads to addictions, alcohol, depression, suicide. This too depicts, as I said before, the mind where the deprivation and the desire, reduction in the desire leads to problems of failure of success and wealth, education, employment, lifestyles, obesity, metabolic syndrome, T2DM, and the body preset in genetics and nutrition. Deprivation created by natural disaster. Now we are in a state of the world where natural disasters are ever present. We in Sri Lanka have a problem at the moment of financial collapse. Then people in India have their own problems, and Ukraine has its own. Even Hong Kong went through a problem here. Compromised health due to loss of loved ones, housing, sanitation, nutrition, and livelihood. Results in stress response in survivors. Increased pre-diabetes in tsunami victims was a case in point as depicted by Ramachandran in India. Infections and inflammation. Risk factors for T2DM include stress and activated innate immunity as seen in the inflammatory condition. John Pickup, Diabetes Care 2004. This may be an important factor in the poor and disadvantaged groups of the world. The last thing I want to say is, in human beings, the mind governs the body, and health and illness depend on it, as said by Antiphon in the 5th century. We are still struggling to understand. Thank you.
Thank you, sir. It has been well deliberated talk about when diabetes has been started. Most importantly, what factors we could have thought about is the stress, pediatric to adolescent stress, which really have an impact on our adult life, leading to like change of mental health, which can lead to a stressful life and diabetes. So with this, I would like to call the next speaker for today's talk. And at the end of everything, we will have a discussion. So RX team, please. So our next speaker is Dr. Mills Fisher. He's an honorary professor at the University of Glasgow. University of Glasgow, Scotland. He graduated from University of Glasgow in 1979. He received his MD in 1988 for his thesis on evidence for diabetes cardiopathy. He is in consultant position at Glasgow Royal from 2001 to 2020. So he has been author and co-author in many of the textbooks. And so with this, I would like to welcome Dr. Mills Fisher for his talk. Over to you, sir.
Okay. Now you need to allow me to share the screen. Can you confirm you can see that?
Yeah, sir.
Fine. Okay. Thank you for inviting me to speak at Diabetes India. I've very much enjoyed in the past attending India and speaking at the meeting. My presentation today is entitled Reducing Cardiovascular Risk in People with Diabetes. Should everyone be on an SGLT2 inhibitor? The short answer I'm going to try and persuade you is yes. Resources allowing, that means that if the healthcare system can afford it, and that won't be true everywhere and for every patient, that people should be started on an SGLT2 inhibitor at the time of diagnosis of diabetes. These are my declarations of interest. I've worked and lectured for the manufacturers of the major SGLT2 inhibitors in Europe. Lexicon were developing sotagliflozin, which of course, for commercial reasons, did not become available for prescription. Now, we've just completed a book called Diabetes Drug Notes. It's a John Wiley book, and it's going to be published at the end of July. In it, we have a diagram about the mechanism of action of SGLT2 inhibitors. Now, I know for this audience, a diabetes audience, that the mechanism of action of SGLT2 inhibitors will be well known. I want to use this slide to emphasize to you one thing. We are focused as diabetologists on the glycosuria, because increasing glycosuria reduces HbA1c. But remember, the class of drugs are sodium glucose transporters, and a major change happens in the filtering of sodium with major hemodynamic and renal effects. And we now have so much evidence of these. That's why I think we should be starting to think about using SGLT2 inhibitors independent of their effects on HbA1c. It's 2015 that the EMPEREDGE outcome trial gave us the first and a very strong indication of the benefits of these patients. This was entirely in people with type 2 diabetes who had atherosclerotic disease. And the trial was performed to satisfy the cardiovascular safety requirements of the American FDA, which followed on from the concern over rosiglitazone. The primary outcome in all of these cardiovascular outcome trials is major adverse cardiovascular events, a composite cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. And this was highly significantly reduced. In particular, it was an early reduction in cardiovascular death that was driving this reduction. And because cardiovascular death is such a common cause of death in people with diabetes, we also saw a reduction in all-cause mortality. And then the unexpected finding was an early and a rapid reduction, statistically significant, in hospitalization for heart failure. So all of the harmful effects on the cardiac, that is cardiovascular death and heart failure, were reduced with this medication. Now, of course, we needed to get supporting evidence, and we have that from 3 further trials in diabetes. So we saw reductions in MACE with canagliflozin in the CANVAS trial program. And in that, we unexpectedly saw an increase in fractures and amputations. With dapagliflozin in the DECLARE-TIMI, we also saw reductions in cardiovascular death and heart failure. And it was really only with ertugliflozin in the VERTUS trial, we did not see significant reductions in MACE. So that tells us it's not a class effect. 3 of the drugs in the class gave clear reductions, 1 didn't, although it did give a reduction in hospitalization for heart failure. Now, following on from that, there was a meta-analysis performed by Darren Maguire and colleagues. I've chosen here just the heart failure data. And that's because I want to emphasize to you, in the trials, there was a substantial number of people who did not have atherosclerotic disease, and yet in them, there was a significant reduction in the hospitalization for heart failure. So the heart failure benefit extends beyond people with type 2 diabetes who already are diagnosed as having atherosclerosis. Now, in these trials, there was also a look at renal outcomes as secondary effects. Now, we are now familiar with the effect of SGLT2 inhibitors on eGFR, very similar to ACEs and ARBs. So that when we start an SGLT2 inhibitor, we see an initial drop in eGFR, which then plateaus out. And in comparison to the placebo group, where, as expected in type 2 diabetes, there's a steady decline in eGFR, in the empagliflozin groups, there were 2 in EMPEREDGE outcome. This doesn't happen. Now, in each of the cardiovascular outcome trials, there were renal secondary outcomes. These were composites which included worsening of eGFR, the development of end-stage renal disease, and death from either renal or cardiac causes. And again, in the empagliflozin, canagliflozin, and dapagliflozin, the defined renal composite outcome was statistically significantly reduced. In ertugliflozin, their chosen renal composite outcome was neutral, but when they analyzed it using some of the composite outcomes that we used in the other trials, that was also significantly reduced. So ertugliflozin seems to have benefits that are renal and cardiac, but perhaps not as strong as those for the other 3 drugs that have been studied in an outcome trial. So what have we learned collectively from these trials? Well, we are diabetologists, and we are always looking at HbA1c, which was reduced. Body weight, and we've heard the importance of that from the previous speaker, was reduced, and blood pressure was reduced. We know there are genitourinary side effects, and in people with type 2 diabetes, a slight but significant increase in the risk of ketoacidosis. So this slide was skipped. We also learned that the SGLT2 inhibitors reduce atherosclerotic disease in people with diabetes and existing atherosclerosis. They reduce heart failure in people with diabetes and a wider diabetes population, so not just the atherosclerotic. And similarly, they reduce renal outcomes in people with diabetes. Again, not just those who have atherosclerosis. Now, when the EMPERAGE outcome trial was presented, immediately this was shown to be of interest to the cardiologists and renal doctors. And in fact, the renal doctors already had a trial in diabetes called CREDENCE. And just very briefly, these trials are now completed and have shown positivity. And the important thing about these trials are these include approximately 50% of people with diabetes and 50% of people who do not have diabetes. So if we look first of all at the DAPA-CKD, a primary outcome, which is a standard composite outcome for renal trials, highly significant reduction with dapagliflozin, and the degree of reduction is identical whether you have diabetes or not. And then just to remind you for backup, in the non-diabetic population, the EMPA kidney trial, we recently got this top line information that the trial has been halted because of positivity, and results will be presented later this week. So for patients with CKD, regardless of having diabetes, we see significant reductions in renal outcomes. Similarly, if we look at the heart failure population, again, I choose the first one, the DAPA heart failure trial, a highly significant reduction in cardiovascular death, hospitalization for heart failure. And again, regardless of whether you have diabetes or not. We also have supporting evidence now with empagliflozin. We have evidence in patients who have both reduced ejection fraction and preserved ejection fraction, which is a very common form of heart failure in people with diabetes. And again, we have new data just arriving. DELIVER is the dapagliflozin trial in people who have got preserved ejection fraction. The top line results show that it is positive. And again, it's going to be presented at meetings later this year. Now, the fact that heart failure and renal outcomes are reduced in non-diabetic subjects where there is no change in HbA1c tells us that the mechanism of benefit is not directly related to glucose lowering. So the question I'm going to pose to you today is, why then, in people with diabetes, when we've got sufficient evidence of cardiac benefit beyond HbA1c lowering, do we only give treatment based on an HbA1c? Now, I've looked at the current Indian guidelines for the management of type 2 diabetes, the RSSDI ESI clinical practice recommendations from 2020. And I looked to see what statement was made about the use of SGLT2 inhibitors. Now, there's a large list of recommendations on pharmacotherapy for type 2 diabetes, and I've just chosen selected bits of this. Metformin should be initiated in combination with lifestyle at the time of diagnosis. So you're not waiting for 3 months after lifestyle, metformin and lifestyle together. You then have a dual therapy if glucose targets are not achieved. And you can add an SU, TZDs, SGLT2 inhibitors, DPP4 inhibitors, or an AGI. And I would emphasize here, of these drugs, it's really only SGLT2 inhibitors that have been convincingly shown to reduce cardiac disease. Pioglitazone might, based on the results of the proactive trial, but of course there was an increase in heart failure. And then again, triple therapy if glucose targets are not achieved. you then start a third agent. And again, the choice of drugs is the same. And now you can add in GLP-1 receptor agonists, again, a class of drugs for which there's clear cardiovascular benefit. So this recommendation, this guideline on the use of diabetes drugs is very similar to most international guidelines. It's a stepwise approach where you start with metformin. If targets are not reached, you then go to dual therapy. If targets are not reached with dual therapy, you then go to triple therapy. Now, in the RSSDI, there's the therapeutic wheel, which I like a lot. You start with metformin, and then depending on what's important, you then use other available anti-diabetic drugs. And except for when you're considering cost, which is down here, you'll see that SGLT2 inhibitors really are the chosen first choice in nearly all of these. The only other group is in the elderly. So that the guidelines are endorsing the fact that SGLT2 inhibitors have got benefits beyond other diabetes drugs. While GLP-1 receptor agonists give cardiac benefit, they haven't been given benefit for heart failure, and they haven't been shown to give benefits for renal outcomes. So where should we go next for diabetes guidelines? Currently, diabetes guidelines are based on HbA1c, except for the ADA-ESD consensus statement, which says rather enigmatically to consider the use of SGLT2 inhibitors or GLP-1 receptor agonists independent of HbA1c, where there is existing cardiovascular disease, existing CKD, or high risk. Now, your Indian guidelines are very much consensus statements. I think to try and get further with this, you should be using proper guideline methodology, which involves an assessment of the literature, scoring it, and then deriving the recommendations from that. I think if we do that honestly, metformin will be demoted in the hierarchy potentially. Remember, the evidence for metformin comes from an extremely small subgroup in the UK PDS trial, and that trial was initiated in the 1970s when trial design was not as sophisticated as it is just now. The other thing you do if you do the methodology, and I've shown you really some of that today, is that SGLT2 inhibitors have a much wider benefit than GLP-1 receptor agonists, and therefore greater emphasis should be put on them. And then what you also do if you use guideline methodology is you identify gaps in the evidence, and you then request modern outcome trials where there are gaps in the evidence. But of course, you have to devise recommendations while waiting for the evidence or the gaps to be filled. So I think guidelines should now be based on cardiovascular risk, initially cardiorenal risk, rather than simply HbA1c. And I think it's time to turn the steps into pillars. Now, what do I mean by pillars? Well, we now need to take some acknowledgement of what cardiac doctors and renal doctors do. So in heart failure, you give them all of the available effective therapies that reduce heart failure. So an ACE inhibitor, an ARB, an SGLT2 inhibitor, and a mineral alcoholic receptor antagonist. And right now, the cardiac community is looking at starting SGLT2 inhibitors, the first of these, because these are the most easily tolerated. And you give them the pillars of therapy very early in therapy. You don't wait for years until you add in the next stage. So to summarize, while we are waiting further evidence, because the only group of people in diabetes where there's not clear proof of the benefits of SGLT2 inhibitors from a randomized controlled trial are those with lower cardiovascular risk. The real world evidence, however, is even pretty good for that group of people. So I'm suggesting at the diagnosis of diabetes, we should embrace a pillars of therapy approach that will give medical nutrition therapy and lifestyle modification at the start. We'll give the patient education about their diabetes. We'll give them metformin in the start as recommended by the RSDI, ESI, and then we'll also add in SGLT2 inhibitors based on extrapolation from the meta-analysis. Thank you for your attention.
Thank you, sir. It was a wonderful deliberation regarding SGLT2 and its importance in our diabetic patients, and why do we need to really step up in our approach in like choosing SGLT2 over other class of drugs. Thank you, sir. Dear speakers, like there is one more talk about today's in the last talk of today's morning from Professor Dr. Sehnaz Karadinç. He is a professor of ophthalmology, Istanbul Florence Nightingale Hospital, founding member and the board member of Turkish Diabetes Foundations, and the president of Living with Diabetes Associations. With this, I would like to welcome our Professor ma'am. Please, the stage is all yours now.
Thank you so much for this kind introduction, and very sorry for the complication in the morning. So I will try to give an insight into future prospects in the screening of diabetic retinopathy. Respected moderators and participants, I want to start by thanking to Dr. Arvind, to Dr. Sabu, and the organizing committee for giving me the opportunity addressing you. Always a pleasure to take part in the Diabetes India Congress. As the number of people with diabetes is skyrocketing, more and more people are at risk for micro and macrovascular complications of diabetes. An alarming fact is that in 1 in 2 adults with diabetes is unaware of their disease. That makes the case for long-term complications more complicated. Another alarming fact is that the data point to a significant increase in the diabetes population of the aging societies in the next 25 years. Currently, diabetes is one of the leading causes of preventable blindness among the working age population, even in developed countries. But not only the blindness, any degree of visual impairment that affects the quality of life of people with diabetes must be our reference point. Then the extent of the burden of this disease is beyond the given numbers and projections. A pooled analysis published in 2012 provided us with an estimate about the extent of the global numbers of diabetic retinopathy. Data were collated from more than 22,000 individuals from 35 population-based studies around the world. The fundus photographs were taken between 1984 and 2010, depending on the study. Approximately 1/3 of the people with diabetes had diabetic retinopathy with or without visual symptoms, any visual symptoms. So there should be around 162 million people with diabetic retinopathy worldwide. If they would be living together in a country, they would be 9th most populous country in the world. This is higher than the population of Russia. According again to this meta-analysis, a further 1/3 of the people with diabetic retinopathy have vision-threatening disease, meaning center-involving macular edema and or proliferative retinopathy. So this is again a big number. This number, just to give an insight, this number is higher than the population of at least 163 countries and territories in the world. All these numbers are not promising at all for now and as well for the future. Although we know how to maintain the quality of life of the person with diabetes, how to screen for diabetic retinopathy, and also how to manage it, especially if intervened timely. But we are still not successful in integrating this evidence into the real life of people with diabetes. There are many challenges at the level of the healthcare systems, at the level of the healthcare professionals, and at the level of the people with diabetes that need to be addressed. Socioeconomic barriers are among the most challenging ones at all levels, especially if we consider the estimates for 2045, that 94% of the increase in the number of people with diabetes will occur in low and middle income countries, where population growth is expected to be greater. For many decades, we defined diabetic retinopathy as a microangiopathy with microvascular occlusions and increased vascular permeability. But more and more studies show that diabetes damages not only the microvasculature, but the entire retina, involving retinal neurons and glial cells. Therefore, today we more and more define diabetic retinopathy as a highly specific neurovascular complications of diabetes. Currently, the screening for diabetic retinopathy still depends on the observed microvascular lesions at the back of the eye. Again, the decision for the treatment, the so-called sight-threatening disease, still largely depends on the extent and severity of these structural changes. I say largely, as we also consider the metabolic control and other comorbidities for the timing of the treatment in people with diabetic retinopathy. The problem is, one of the main problems is that patients may not have any visual complaint till late stages of diabetic retinopathy and may miss timely intervention for the vision-threatening disease. Therefore, regular screening is decisive for saving the sight in people with diabetes. Screening criteria for a disease is defined by Wilson and Jungner in 1968 and still valid today. All the diabetic retinopathy, screening for diabetic retinopathy fulfills all these classic screening criteria. Retinal examination for diabetic retinopathy can be done in several ways, but today we will be speaking mainly on advancements in technology that will lead us to the future. In real life, the numbers of the patients with diabetes are beyond the capacity of the healthcare systems to cope with. Therefore, most of the time, the ideal approach, the detailed eye examination for a patient with diabetes and regular follow-up cannot be followed in many countries, in many communities. The introduction of fundus camera and further advances in fundus digital imaging paved the way for mass screening programs in diabetic populations in the 1990s and 2000s. There are two main modes of their use in teleophthalmology. One is store and forward, and the other one is the real-time mode that involves a live telemedical consultation with simultaneous transmission of the images. Artificial intelligence may address the workload and some other challenges in the future. In the near future, already it's there. The mobile health is another option. All these advances have the potential to make screening more widely available, accessible, affordable for the people with diabetes, particularly living in rural and remote areas. But currently, there are several challenges that need to be addressed. The UK is the largest country that started a nationwide screening for all patients over the age of 12 years based on teleophthalmology. in England, Scotland, and Wales in 2003, and in Northern Ireland in 2008. Currently, the diabetic eye screening program has a grading pathway with 3 levels of human graders, except in Scotland, and has an uptake of over 80% of the diabetic population. In a publication from 2017 on the English National Screening Program, Scanlon pointed to more or less the most important points in developing such programs. At the end, there should be an allocated funding. The next stage would be availability of assessment and treatment facilities. Then reaching out to the cohort of people with diabetes, and the establishment of the IT infrastructure, and then choosing the camera. In line with the consensus statement of the British Diabetic Association in mid-1990s, the method should have a minimum sensitivity of 80% and a minimum specificity of 95% for referable retinopathy. Then the workforce should be trained and higher than trained. So the quality assurance of the program is very essential. The artificial intelligence technology using deep learning systems is one of the most promising areas for AI application in ophthalmology, particularly in diabetic retinopathy screening. The first national screening program to use an automated retinal image analysis system as a level 1 grader was in the Scottish screening program in 2011. Recently, the UK National Screening Committee reviewed a major program modification in the screening program in all UK nations, namely the implementation of automated retinal image analysis system. But they concluded that further evidence is needed on the accuracy, clinical utility, and cost effectiveness of automated retinal image analysis system. They also made an emphasis on social and ethical aspects of AI implementation, to which we will come back later. There are many studies around screening and follow-up of people with diabetes using AI-based procedures. Another nationwide program in this respect is Singapore. They already implemented telemedicine-based screening program back in 2010. With the advances in AI technology, they also did a multi-year program from development of a deep learning system to its integration into this retinopathy screening. And they are still working on this, and they are they do very successful initiatives in this respect. They found that in the preliminary studies, they found that the full AI model has over 90% sensitivity in detecting referable retinopathy, and again over 90% sensitivity and specificity in detection of vision-threatening disease and diabetic macular edema, including diabetic macular edema. mHealth applies to public health practices supported by mobile devices. On one side, this may offer a wonderful opportunity for maximizing the uptake for the retinopathy screening. On the other side, the image taken should have sufficient quality and should be integrated into the local or regional or national retinopathy screening system, of course, if available. Here you see some of the automated retinal image analysis systems. iGrading M is used in Scottish diabetic eye screening program. Red marker is used in local screening in Portugal and also approved in Australia. IDXDR is approved by the FDA as an autonomous detection software for diabetic retinopathy and diabetic macular edema back in 2018. FDA also granted to this IDXDR breakthrough device designation. IART has received also FDA clearance in 2020 as an AI technology for autonomous detection of both more than mild and vision-threatening disease. Google Eye is launched as a screening program in Thailand in 2018, and as far as I know, also in India in 2019. Selena Plus is a national AI project in Singapore. I would prioritize two topics for the advantages of the AI-based screening program. One is reducing the healthcare inefficiencies. When it comes on screening for diabetic retinopathy, with fundus photography and grading the retinal images, AI-based systems can grade thousands of images during a day and every day, and the system will not get tired. The images are read and the results can be given within seconds to minutes, contrary to remote reading by experts, where it can take several days. Artificial intelligence-based system may also help in reducing the cost of screening for the people with diabetes. But there are several challenges in its implementation. Some of them relate general to AI-based systems, and some others specific to retinopathy screening. The cost of the system is high, therefore the establishment in low resource settings may not be easy. And then the human graders are still needed for low quality images. The sensitivity and specificity of the systems need to be assessed according to the different outcomes, like diabetic retinopathy present or not, or diabetic retinopathy absent, or referable retinopathy, or sight-threatening retinopathy. There are several ways in which artificial intelligence could affect the legal system and ethics. The privacy and dignity of the patients must be carefully considered when designing services. The World Medical Association adopted a statement on augmented intelligence in medical care at its General Assembly in 2019. Protecting confidentiality, control, and ownership of patient data is a central tenet of the patient-physician relationship. So this is one of the things they are emphasizing. Liability for decisions made by AI systems is currently a huge question mark in situations where an AI is involved in a misdiagnosis or in a malpractice case. Question may arise around the legal approach to claims, whether it's a negligence or product liability. At the end, currently, our laws and regulations are based on the mistakes of the people, not on the artificial intelligence and so on. And this is also very much emphasized in other reports. One of them came from the European Parliament 2 or 3 years ago. And this was also one of the main concerns. These and other concerns need governmental regulations and the development of norms in all countries, and also, of course, worldwide. As a summary, screening and timely intervention, besides good control of systemic risk factors, is critical in order to save the sight of people with diabetes. The translation of current evidence base into the real life needs to be improved. Besides further research, focus on overcoming the barriers in this respect is urgently needed now, and also for all the use of technology and so in the near future. At the end, artificial intelligence already pervades many parts of our daily life even now. But the laws and regulations should catch up with the enthusiasm around the advantages of these advancements in the technologies. Artificial intelligence systems must be created and operated to respect, promote, and protect all human rights. Some concerns can be overcome by shifting our minds from healthcare professionals or computers to healthcare professionals and computers, as suggested as superminds by some MIT researchers, again, 2 or 3 years back. Adopting this perspective would shift the emphasis from what an AI can do to what HCP, healthcare professionals, and computer groups can do in the near future. So thank you.
Thank you, Dr. Sainaz. So with this, I thank the talk has been well started with and then our Dr. Mila Fisher, who have spoken about the SGLT2 importance, and at last it has been well said about screening, advanced screening, ophthalmologist screening by our Dr. Sainaz. So I think the time is also over, so we can forward. We can give the stage to our RX event for the next session. Thank you. Thank you, everyone.
Thank you all. Thank you.
Thank you.
Recording in progress.
I will not do it. Pratik है और कौन है? Pratik है, Simon है.
Good morning.
Good morning, Pratik. Can you hear?
We can hear you, yes. We have Dr. Professor Griffin and Dr. Dinesh Navaraja online as well. So we have our faculty ready.
Great. Good morning there.
Well.
Start. So what are we waiting for? RX events? Anybody? Can we have Dr. Pratik's introduction slide? Yes. So I welcome you all to this EST symposium. And the first speaker for this symposium is Professor Pratik Chaudhary. He is Professor of Diabetes at Diabetes Research Center at Leicester Diabetes Center. And before this, he has been working at University College of London, and I'm sure a lot of people here already know him. So without much time in between his talk and you, I will just hand over to Pratik.
Thank you. Let me try and share my screen. So thanks very much, Bansi and Dr. Makkar. And of course, this is now many years into our collaboration with the EASD. Have I got the right screen sharing? Was it this one better? Yeah. So yeah, just always pleased. I think now for the last 6 or 7 years, we've had a EASD symposium at the Diabetes India meeting, and it's always a pleasure to bring experts from across the EASD group who've been doing some amazing work to the Diabetes India meeting. We are virtual this year, of course, and I'm speaking today just to share some results of the latest in closed loop therapy. This is the results of the ADAPT study that we recently concluded, and I was part of, and that we presented at the ATTD meeting in a couple of months ago. And so we all know that there's still a care gap between what is achieved and what could be achieved. And we know that certainly in type 1 diabetes, as we move from the simple technology, multiple injections and either capillary or sensor monitoring, to adding in the next level of technology, insulin pumps, to moving towards the top level of technology, hybrid closed loops or automated insulin delivery, the percentage of users who achieve target increases. But actually, we know that the vast majority of our patients stay on this lower level technology, and a very small percentage of our patients achieve or are able to use that technology that provides them with the results. And this is a dichotomy or a problem with the way we organize our care. In the UK, there's a traditional stepped care approach, and we talk about this in terms of technology monotherapy, adding in a sensor or a pump, and if that doesn't work, adding in technology dual therapy, which is combining a pump or a sensor. And I guess one of the questions is, can we bypass some of that stepwise approach and say that in the UK for sure, where we have now about 70% coverage of patients with Freestyle Libre or flash CGM monitoring, go straight from there to the automated insulin delivery step. And so the question with the ADAPT study was to evaluate the safety and efficacy of a closed loop system, in this case, the Medtronic system, in patients whose A1C was not at target, compared with trying to optimize those people on MDI with intermittent scanning with them. So we took adults 18 years old, with at least 2 years of diabetes, using CGM for at least 3 months, and they had to be using the CGM properly. They had to be doing 5 scans a day, having more than 70% of their sensor readings available, but despite this, still being A1C above 8%. And you can see from the diagram at the bottom, we collected some baseline data from their sensor. Actually, they wore a Medtronic sensor because in these studies, it's really important that the CGM data is collected with the same technology. So they were using their Abbott device for their clinical care, but we used a Medtronic sensor to get the actual glucose data. Then they were randomized to go onto the Medtronic 780 system or continue on injections plus Abbott Libre. At the end of 6 months, then they were the people on Libre were allowed an open crossover. And at the moment, I'm only presenting data from 6 months. The 1 year data is just being completed. Actually, the last few patients in my center have just finished that study. And so the main outcome was a between group difference in mean A1C from baseline to 6 months, and with the usual safety endpoints and secondary CGM endpoints, along with some, which is very important, the patient reported outcomes. So just as a note, the current most advanced insulin pump is the Medtronic 780 system. But when this study was designed, that system wasn't approved. And so actually the system we used in the study was the algorithm that's in the current 780 system, but in the body of a 670 pump. And the only real difference was that this 670 pump does not have the Bluetooth connectivity, which allows real-time monitoring of the glucose by the clinician. So with the 780, because it's got Bluetooth, the data goes via the patient's phone straight to the cloud. And so in clinic, we can see the patient directly. But in this study, we could only see the data when the pump was downloaded in the old-fashioned way, connecting into a computer. And the other difference was that The 780 system has 3 levels of glucose control, 100, 110, and 120 milligram per deciliter. This system only had the 2 settings, 100 and 120 milligrams the target. But for purposes, because in other aspects, the algorithm is the same, I'm just going to call it the 780 system. So we assessed 105 patients, 18 were screen failed, mainly because the A1C wasn't high enough, and they were randomized equally to MDI, 40 people, and 39 people in the control arm and 36 in the intervention arm completed the study. And if you look at their characteristics, they're very similar to, if you look at a big population study of type 1 diabetes, you'll generally find an age of about 40 years, duration about 20 years, a BMI somewhere between 26, 27 kilogram per meter square. You can see here, though, these patients had a pretty high HbA1c. Despite using sensors, using Freestyle Libre, their A1C was 9%. And it's not that they weren't using the sensor. They were scanning 9 times a day. And if you look at the population data, the average A1C for 9 scans a day is about 7.4. So there's something about these patients, they were scanning a lot, but still the A1C was high. We don't really have the baseline data. Was there variability higher than before or not? But, whether there was psychological issues, fear of hypoglycemia in these patients, but there were a different cohort than what's usually been studied in the closed loop studies. If you look at the other studies, the entry A1C is usually about 7.5, 7.7%. So anyway, the main results, actually, just to show you, the main results were a 1.4% drop in HbA1c. So you can see here in the control arm, A1C was 9%, and despite frequent visits, remained about the same through the course of the study. So even though we were seeing these people at a higher frequency than they would be seen in clinical care, we weren't able to really change their A1C. But in the closed loop arm, they got down to almost to target, just to an average of 7.3. And that's giving you a difference of 1.4% HbA1c. As you can see, they're very highly statistically significant. And then, of course, the modern metrics that we analyze our data with, particularly for type 1 diabetes, is time in range. And you can see here in the control arm, as you'd expect for that HbA1c of 9%, the time in range is about 42, with very little hypoglycemia, but a lot of time, 23%, 25% spent above 250 milligram per deciliter. And in the control, with the 780 system, you can see there actually that group had an even lower time in range to start with, and it went up to 70%. So it crossed the target of 70% time in range with a very significant reduction in those very, very high glucose readings of minus 27%. So most of that gain was in those very high readings above 250 milligram per deciliter. And if you look at the actual glucose readings, you can see here the mean sensor glucose dropping from about 200 a baseline in this control arm, getting down to 150 average glucose. You can see the standard deviation, which is a measure of variability, dropping from 73 down to 54 milligram per deciliter. That's almost below the target we set. The coefficient of variation, interestingly, does not change. And that is because mathematically, if your mean comes down, then your coefficient of variation kind of comes down in proportionally. And then you can see the GMI there, again, dropping down to 7%. So if you look at what proportion of our patients met the target of HbA1c 7% using closed loop, in the open arm, it was 0%. And we know these people were really struggling, but it's about 30% met that A1C target. If we look at GMI, that was 60%. And this might just explain that, the target of 7% A1C, many of the rest of the people were just on that edge, maybe, and that's what allowed the GMI to get there. The GMI was calculated over the last 14 days, so maybe the A1C was still catching up at the end of the 6 months, but a higher proportion achieving a GMI of 7%. And again, about 52% achieving a time and range target of 70%. And if we look at that combined target, and again, a bit like in type 2 diabetes, we often look at a composite target of weight loss, A1C reduction, and no hypoglycemia. Similarly, in type 1 diabetes, I think it's important to look at that composite target of time in range 70% and time below range of less than 4%. And again, 40% of those patients achieving that target, which is pretty impressive given that they started so high. So if we look at the sensor usage, again, very high sensor usage, 90% sensor usage, as maybe you'd expect with the 780 system, we were using a 3rd generation Guardian sensor. So patients still had to do finger pricks 3.8 times a day. But again, look, in the control arm, it wasn't as though we weren't trying. The number of scans went up from 9 to 9.7, almost 1 scan a day increase, which should lead to a 0.5% drop in A1C. But in these patients, despite them working hard, we weren't able to improve the control there. And so the other thing to remember is from the real world data, at the beginning of the study, the protocol said that we wanted to get most patients using the target of 100 milligram per deciliter on the closed loop pump and using the active insulin time of 2 hours, because these settings are known to make the 780 algorithm the most aggressive. And using these settings, we see that in real world data, maybe you can get a time and range of 80%. But actually we know, what we found was, on a third of patients weren't able to use that more aggressive setting. Maybe they were having a few more hypos, they were getting a bit more anxious. As the glucose readings get down to 100, they feel uncomfortable. And so in a third of patients, you can see we weren't using the optimal target. And in about 40%, we were not using the optimal active insulin time. And in this system, the easiest way to think of active insulin time is instead of thinking about it as what the insulin is doing, we think about it as more as an aggressiveness setting, how aggressive you set the system. So 54%, the system was set at its most aggressive, and 40%, it was a little bit softer. And so, the way we're looking at these data is, there is potentially, as these people get used to staying at this level, there is still some added value to be found if we can move some of these patients, maybe over the course of the last year. We try to get some more of these patients onto 100, drop the insulin active time, and see if we can get these people a bit more to target. The other thing to see is how much insulin was being delivered by the system. So actually 38% of the insulin was delivered by the user. And with closed loop systems now, instead of thinking of basal and bolus treatment, we're thinking about user initiated insulin that they're bolusing for their meals. And the rest of the insulin is system generated insulin. And so here that's about 60%. And it's just a useful metric to be looking at in this type of study. Very interestingly, we expected if these people were at 9%, that there would be an increase in insulin delivery. And we have seen that in some other studies, but in this particular study, actually there was no increase in insulin, still at 55 units per day. But the weight, you can see there was a 2 kilo weight gain. And we think that may be related to the reduction of glycosuria you might expect to see from a 1.4% drop in A1C. And finally, if we look at adverse events, of course, no real differences between the systems there. Patient-reported outcomes. So, diabetes treatment satisfaction questionnaire going up quite significantly, which is what you'd expect if someone who's been struggling at 9% suddenly gets readings of 7%, 70% time in range. They're going to have a better diabetes treatment experience, and so that's not surprising. A reduction in hypoglycemia fear, again, that we're seeing that we would expect. Interestingly, the diabetes quality of life didn't change, and that's interesting. It might be because, we're speculating about why people didn't see an improvement in quality of life. These were people on injections who went to pump. Maybe they didn't like wearing the system. The system still generates alarms and they had to finger prick. These people were on Libre, so they'd stopped finger pricking the last 3 years, and now they were having to finger prick. So there were a few things that might contribute to that quality of life, and maybe that DQOL questionnaire isn't really sensitive to the things that change with closed loop. But that was an interesting finding that we're going to track through in other closed loop studies. But the most important comments are comments from the people with diabetes. And this is just actually one of the patients at my center. And just the comments were, no matter how much I tried to manage my diabetes, I couldn't get the numbers low. And that reflects, these people were scanning 9, 10, 12 times a day, but getting frustrated with presumably the variability and the challenges. I've gone from being completely frustrated and discouraged for caring for my diabetes to being back in the driver's seat. And I think the most important one is this, people with a high HbA1c might put on a brave face, might say whatever they say in clinic, but underneath, many of them will have this overwhelming fear of complications. And she says this, the fear of complications is dwindling and being replaced by a freedom I've never experienced before. And those are the sort of results that and many of you who have used closed loops will have heard their patients say. Finally, I just want to have 2 slides on a UK hybrid closed loop national pilot. And so in the UK, money was pulled out for 1,000 patients, up to 1,000 patients who were on pump and sensors, but still had a high A1C. So an even more higher or difficult category than the ones we studied in ADAPT to be offered closed loop. And people were given a choice of 3 different systems, a Medtronic, Tandem, or the Cambridge system. And here are just some results from a small group of those patients from 3 centers. There's 30 centers in the study. So these are data from about 100 patients. And you can see that 16.7 millimole per mole. So that's almost 2%, so 1.8% drop in HbA1c with the closed loop systems after adjusting for all the variables, and an increase of time range from 35 up to 65%. With, again, almost no hypoglycemia and a big reduction in that range, very high range above 250 milligram per deciliter. So showing that these systems really help those people who are completely struggling for many years. So I think we're moving to a system, certainly with the funded healthcare economies, where you can have a choice of move straight from MDI and sensor to automated insulin delivery, bypassing that middle segment, safely, effectively, with increased user satisfaction. And certainly in the UK and in kind of Europe, we're making a play or a thought process that it's the user's choice whether to drive themselves to be in control of their diabetes with injections and sensors, or to be driven. And this is a picture from, I have a Tesla, this is me being driven by the computer in my car, letting me enjoy the scenery as I go past. And that's letting people enjoy their lives while the system keeps control of their diabetes. So thank you for your attention. And I'm just going to thank all the centers that were involved in this study. Thank you.
Pratik, congratulations for a fantastic talk, and the data which you had shown of ADAPT for automated delivery insulin device is really great. And you had shown that how effectively it is not only reducing the A1C, but without causing hypoglycemia. And you had shown the picture of using MDI, where you have to control your car, and the same time you had shown the car where you can enjoy the scene also outside. With this, once again, I'm thanking you for this Diabetes India and ESD Symposia, and you are the key person for this ESD Symposia, which is happening on Diabetes India. We would like to have you all in person, and that's what we are planning at Indore, which is your hometown.
Oh, wow.
For the next year. So that's what I'm inviting you in advance for DI ESD Symposia for next year. One more important thing which I just want to make, that in this meeting, more than 10,000 doctors who are registered for online. We are doing hybrid meeting, and 1,000 doctors are just now at Goa, and 10,000 doctors are listening you online also. So that's just a information I must share with you. And with this, if anyone have any other question, we can have. Otherwise, at the end, we would like to have 1 or 2 comments from our co-chair also. I would like to invite our second speaker, and can I have the slide for him? Dr. Dinesh. Once again, Dinesh, first of all, thank you for joining on this Diabetes India ESD Symposia online. Dr. Dinesh is a senior clinical lecturer in diabetes at the University of Sheffield. His clinical and academic training and research experiences has provided him with an excellent background in multiple disciplines, including neuropathic pain, functional imaging, pain phenotyping, clinical trials in diabetes. He is amongst the world leading clinical research looking into the cause, treatment, and prevention of diabetic neuropathy. So we have with us Dr. Dinesh, who is expert in field of diabetic neuropathy. And can I have his slide? And I request Dr. Dinesh to share his slides. Over to Dr. Dinesh.
Yeah, thank you, Mr. Chairman. Thank you for that kind introduction. Can you see that screen?
Dinesh, we need to see slide view. It's in the notes view.
Okay.
Swap screens. Yeah, that's it.
Is that better?
Yeah.
Yeah. Okay. Once again, yeah, thank you all for this invitation to speak at this meeting this morning. So I'll kick off with the presentation. So I've just, this slide just gives you an outline of my presentation this morning. I'll just go through a quick background of diabetic neuropathy, and then touch on some of the new approaches that we're using to diagnose diabetic neuropathy, and then update you on some of the new updates or research findings on the pathogenesis and the management of painful diabetic neuropathy before concluding my presentation. So most of you here will know, diabetic neuropathy is one of the most common complications of diabetes. It affects about up to 50% of patients with diabetes over the duration of the condition, and it's the strongest risk factor for amputation and foot ulceration. It's a length-dependent neuropathy, so it typically starts in the toes, and as time progresses, it gradually progresses up the lower limb. And by the time it passes the knees, often patients then start to develop symptoms in their hands, and this can be quite disabling. But a third of patients develop painful diabetic neuropathy, which results in quite a significant impact on their quality of life. And when we look at the clinical consequences of diabetic neuropathy, I guess broadly speaking, then we can divide it into three different categories. So painful diabetic neuropathy, where patients develop burning, paresthesia, or contact hypersensitivity. We also have patients who report quite significant autonomic neuropathy, which again can impact on different organ systems in the body. So patients can develop quite disabling postural hypertension, GI dysfunction, incontinence, and genitourinary symptoms as well. And perhaps by far the commonest manifestation of diabetic neuropathy is painless neuropathy, which increases the risk of foot ulceration, which is the leading cause of lower limb amputations in patients with diabetes. And most of this, and together, these different manifestations of neuropathy results in a reduction in quality of life. And unfortunately, most of the treatments that we have to manage these conditions is directed at the symptomatic side of treatment. And unfortunately, apart from risk factor management, we don't have any treatments which target the pathogenesis of diabetic neuropathy. So we're left with managing the risk factors in order to delay the onset or prevent further deterioration of neuropathy. So what are the risk factors for diabetic neuropathy? Well, in this Eurodiag study, in which about just over 1,000 patients with type 1 diabetes were followed up for a mean duration of 7 years, and in those patients who developed incident neuropathy in this trial, what they found was that it was the typical cardiovascular risk factors such as hypertension, smoking, glycemic control, and dyslipidemia, which were the key risk factors for the development of neuropathy. And when we come to the diagnosis of diabetic neuropathy, what we tend to rely on are simple bedside tests, which are, to be fair, good at identifying patients with loss of protective foot sensation. And these individuals are the ones who are at high risk for developing foot ulceration, so that you can put in interventions such as education, regular podiatry, and footwear interventions in order to prevent them developing foot ulceration. So these tools that we use tend to assess both large fiber dysfunction, such as the tuning fork or the vibration sense, or small fiber dysfunction, such as temperature or pinprick sensation. But like I said, these tend to diagnose neuropathy too late. That's why when we see patients in the diabetic foot clinic, and here is a quote from one of the patients who we see in clinic, who said that, I was told that my feet were fine at an annual check until last year when I was told that I have nerve damage, and now I'm attending the foot clinic. So it's because we're relying on tests which identify patients with neuropathy late that by the time we then implement some of these risk factor interventions, we argue that that's then too late to actually alter the natural history of this condition. And now we've got ample evidence that early screening of complications does actually make a difference. So as we heard earlier on in the session this morning, we've got good evidence that in patients with diabetic retinopathy, that the implementation of an effective screening program and an intervention which is effective actually can have an impact on patients with diabetes. So, for many years, we were taught that diabetic retinopathy was the commonest cause of blindness in working age adults in the UK. But that's no longer the case with the introduction of an effective eye screening program. So similar interventions in diabetic neuropathy we think is possible, and I'm just going to show you some of these modern point-of-care testing devices which we've assessed, which only take a few minutes to implement. Doesn't take a lot of training to actually implement. And the first of these is the DPN check. And this is a handheld bedside test for sural nerve conduction velocity. So it only takes a few minutes to complete. And you get the sural nerve conduction velocity and amplitude, which actually has reasonably good sensitivity and specificity in order to detect patients with diabetic neuropathy. This is a measure of large fiber dysfunction. And a similar test or another test which can be used to detect small fiber dysfunction is a pseudoscan, and this is an assessment of pseudomotor function or sweat function in the hands and feet. So again, it takes a few minutes to complete. So patients place their hands and feet on these electrode plates, and the machine actually measures sweat function in the hands, which is a direct measure of autonomic dysfunction, a small fiber neuropathy function. In fact, the latest generation of the device actually does away with the hand assessment and just focuses on foot assessment. And in a study which we combine both the DPN check and the pseudo scan, what we find is that we can classify up to 85% of patients with diabetic neuropathy with a reasonably good sensitivity. And in a paper published in Diabetic Medicine, we proposed a screening algorithm for patients using these devices. So moving on to the management of painful diabetic neuropathy, well, we know that painful diabetic neuropathy is quite a distressing complication of patients with diabetes. Results in significant distress in quite a significant proportion of patients with this condition. Results in constant burning sensation, sharp shooting pains, paresthesia in the feet, which affects the sleep and quality of life. But also what we tend to, we've often forgotten about is the impact this condition has on the individual. It also results in quite significant psychological distress, but also social isolation. And part of the reason for this is because our approach to managing the condition is quite limited. So this is a meta-analysis of the commonly used drugs that we use to treat painful diabetic neuropathy. And in essence, what it shows us is that despite optimal treatment using these medications, only a third of patients achieve anywhere close to meaningful pain relief. And when we look at our treatment algorithms for this condition, and this is taken from our NICE guidelines in the United Kingdom, what it effectively says is that you choose one of three different agents, so an alpha-2 delta agonist such as pregabalin or gabapentin, a tricyclic antidepressant such as amitriptyline or nortriptyline, or SNRI like duloxetine. And you base your initial decision on which treatment to start based on whatever contraindications or comorbidities an individual has. So for example, somebody with peripheral edema, you want to probably avoid pregabalin. If there's a history of significant cardiovascular disease, we tend to avoid tricyclic antidepressants. And somebody with liver dysfunction, we avoid duloxetine. But if pain is inadequately controlled after optimizing treatment on these agents, then the recommendation is then to switch to an alternative agent. And if that's still inadequately controlled, then you would add an opioid agonist in combination therapy. But increasingly, this sort of guidance is so moving away from this type of guidance, partly because of the well-recognized risk of long-term opioid therapy in patients with chronic pain. And in fact, one thing NICE doesn't recommend, because the evidence for it is poor, is the use of combination treatment in painful diabetic neuropathy. In clinical practice, however, we use combination treatments quite frequently. But when you look at the evidence for the use of combination, for example, which combination is effective and how we should combine treatment in this condition, there's actually very limited evidence. So we completed a study late last year called the Option DM study, where we addressed these key questions in a large randomized crossover trial, looking to find out which is the most clinically beneficial, cost-effective treatment pathway for patients with diabetic painful neuropathy. So we looked at 3 different combinations of treatment. So we either combined amitriptyline supplemented by pregabalin, duloxetine supplemented by pregabalin, or pregabalin supplemented by amitriptyline over a 16-week period. And I mean, this is the largest crossover trial in patients with painful diabetic neuropathy complete today. So this is quite a busy slide. I won't spend too much time on it, but it just gives you an indication of the doses in which patients were initially started for. They had a 2-week titration period, followed by a 4-week maintenance phase. And then at this key juncture, after 6 weeks, we commenced combination treatment if the pain intensity scores were above 4 out of 10. And as I said, this is a multi-center study done across the United Kingdom. And essentially what it found, and this slide just shows you the results of our study, is that in patients with, regardless of whichever combination treatment that you use, so whether you use amitriptyline supplemented by pregabalin, duloxetine followed by pregabalin, or pregabalin followed by amitriptyline, actually each of these combination treatments are effective. But in monotherapy, what we find is that there are a good proportion of patients who actually do respond to monotherapy, bringing the pain scores below 4. But a significant proportion of patients actually need combination treatment in order to improve their pain control even further. And this is important because in order to achieve this pain score 4, which is what the targets that we're trying to achieve, these individuals then need combination treatment. So the summary of the Option DM study is that amitriptyline, duloxetine, and pregabalin are equally efficacious in order to achieve this numeric rating scale of 3 or below, but only a third of patients achieve this target. But with combination treatment, you can achieve significant improvement in pain relief in about half the patients with painful diabetic neuropathy. And in fact, actually combination treatment is actually well tolerated. And if any reason for patients to switch treatment occurs in the monotherapy phase, so usually by the time they need combination treatment, the treatment's actually well tolerated. But this leaves us the conundrum that despite the setting of a clinical trial where patients are followed up quite closely and treatment is actually managed relatively aggressively, we still find that around half the patients still don't achieve anywhere close to meaningful pain relief. And that leads us to this conundrum. So research in diabetic painful neuropathy over the last 10 years or so, we're starting to build a picture of different pathways which are involved and how we should manage these patients effectively. But there's still key details which are still unknown. In fact, what we find is that when we do a deep dive into this condition, and research is now pointing to the fact that actually painful diabetic neuropathy is a heterogeneous condition, and that not one patient is the same as the other. There may be many similarities that you can identify between them, but actually the key individual factors which identify those individuals are different. So in fact, the approach that we have, where we have a one-size-fits-all treatment approach, it's not surprising that it doesn't work. and that a significant proportion of patients don't achieve anywhere close to meaningful pain relief. And the different approaches now, which we're using to actually phenotype patients more carefully in order to target treatments which may be more effective in these individuals. And one approach here is using detailed quantitative sensory assessments, using different bedside tests in order to identify these different phenotypes. And in this study, what we found was that indeed that perhaps 3 different phenotypes of patients with diabetic painful neuropathy. The non-irritable nociceptive phenotype are patients with pain with accompanying numbness, and the irritable nociceptive phenotype, where these individuals have either contact hypersensitivity like allodynia or thermal hypersensitivity, hot or cold sensation. And proof of concept that this approach actually is effective, a more effective way of actually managing patients with painful neuropathy is presented by this study, in which patients were, first of all, stratified into the 2 different phenotypes before they were randomized to a crossover trial using oxcarbazepine. Now, oxcarbazepine, for many years, from the clinical trials which were done in the 1990s, was actually a failed drug in patients with painful diabetic neuropathy. It didn't show any clinical effectiveness in this condition. But what this trial showed was that if you phenotype patients carefully, in patients with the irritable nociceptive phenotype, these are patients with the contact hypersensitivity, oxcarbazepine, which is a sodium channel inhibitor, actually seemed to be more beneficial in these cohort of patients with irritable nociceptive phenotype compared to the non-irritable nociceptive phenotype. So perhaps in the future, we will be phenotyping patients more accurately in order to then target treatments which are more effective in these people. Another approach which has been used to phenotype patients more accurately is a genetic-based approach. So what we're finding is that, again, in patients with painful diabetic neuropathy, there are many different genetic variants which perhaps then manifest in the different clinical pain conditions. And this study, elegant study, which I urge you to read if you're interested in the field, actually perhaps shows us a path where simple genetic tools can be used to phenotype patients with painful diabetic neuropathy. So finally, moving on to the final part of my presentation, which is the pathogenesis of painful diabetic neuropathy. So for many years, we've always thought that painful neuropathy was a peripheral condition. In fact, which is true that the initial insult may occur in the periphery, but its subsequent changes in the central nervous system, which we're beginning to gain new insights on, which then alters the manifestation of painful diabetic neuropathy. And we've used many different imaging tools, particularly MRI imaging, in order to investigate the changes which are occurring in these individuals. And over the years, we've demonstrated changes within the spinal cord, the ascending somatosensory tracts, within the thalamus, and in the somatosensory cortex, which helps us to identify differences between patients with painful and painless diabetic neuropathy. But perhaps it's the changes within the cerebral cortex which we think is the key moving forward, which allows us to actually understand the pathogenesis of chronic pain. And in this study, we looked at alterations within the cerebral cortex and looking at cortical thickness within key somatomotor regions of the brain, which find that there is reduction in the S1 cortex and in the motor cortex in patients with painful and painless diabetic neuropathy. In fact, when we looked into it in more detail, we find that there is a functional change in the activity within the somatosensory cortex in patients with painful diabetic neuropathy. In fact, there is functional reorganization of the cortex. So in this experiment, we applied a heat pain stimulus to the foot and thigh in patients with painful diabetic neuropathy. And what we demonstrate was there's a shift in the somatosensory representation of the cortex from the foot region down to the face and lip region of the S1 cortex in patients with insensate or the non-irritable nociceptive phenotype of painful diabetic neuropathy. So as you can see here, what we find is that, just to summarize these findings, is that there is a reduction in the S1 cortex and a reorganization of the somatosensory representation of the cortex from the where pain is perceived in these individuals with the painful insensate cohort in the hip and knees down to the face and lips in these individuals. And we find that this reorganization occurs in patients with more severe neuropathy and more advanced neuropathy. Perhaps the imaging modality which holds the greatest promise in unlocking the pain condition in these patients is resting state functional MRI. So for those of you who are not familiar with this technique, we position patients in the scanner and we show them a cross and we ask them to just focus on that cross and to relax. And we're collecting baseline resting neuronal activity using this technique. It's a relatively simple technique to perform and it takes about 6 minutes to collect the data. So what we find is that when we look at the treatment response, so in patients who are responders to neuropathic pain treatment compared to non-responders, here we find that in the non-responders to treatment, there's a significant reduction in their S1 cortical volume compared to responders and non-responders. But when we look more closely at their functional connectivity, we find that in patients who respond to treatment, they have greater functional connectivity between the insular cortex and the cortical limbic system. And the cortical limbic system is the reward network in the brain and responsible for the top-down inhibition of the pain. In these patients who respond to neuropathic pain treatment, they have a better or more intact functional connectivity between these two regions. And why is this important? Because it's important because when you look at the regions that we've identified which are involved in treatment response, they actually map quite well to the opioid regions of the brain, the endogenous opioid transmission system. So this figure on the right was taken from a PET-MR study, which they used opioid ligands to map opioid-rich regions in the brain. And we find that in patients who are responders to neuropathic pain treatment, they have better target engagement of these opioid receptor systems compared to non-responders. To summarize our findings, we find that the initial nociceptive inputs are generated in the peripheries, which results in the pain experience in the brain. In patients who are better able to engage these top-down mechanisms of pain modulation, they have a better ability to inhibit these ascending nociceptive inputs, which results in a reduction of pain. And we're now looking to see how different clinical factors, patient-related factors, actually impacts on how patients perceive these pain experience.
Dr. Dinesh, you need to quickly wind up. We are...
Sorry, I've got a couple more slides. So we were now using machine learning approaches to train our clinical algorithms so that we can actually now start to identify different clinical cohorts of patients with neuropathic pain so that we can phenotype them better in order to understand the pathogenesis and treatment of the condition. So in conclusion, Mr. Chairman, I'm sorry I'm just running a couple of minutes late. We are diagnosing neuropathy late, and often the diabetic neuropathy is established by the time patients are identified, and perhaps these new point-of-care testing devices will allow us to diagnose the condition early so that we can intervene to slow its progression. We've identified the significant involvement of the central nervous system in patients with diabetic neuropathy, and perhaps these new clinical tools will allow us to phenotype patients better so that we can target treatment more effectively. In the Option DM study I've presented, we've identified that combination treatment is effective in patients with neuropathy and perhaps identifies a new approach to treating these patients more effectively. I'd like to thank you for your attention, and I'll take questions at the end of this symposium. Thank you. Thank you again.
Thank you, Dr. Dinesh, for a wonderful presentation. As Dr. Dinesh just mentioned, we'll have questions at the end of the symposium. Now we move on to the next talk by Dr. Simon Griffin. Can we have the introduction slide? So Professor Simon Griffin is Professor of General Practice at the University of Cambridge, leads the prevention research groups in the primary care unit and medical research counseling epidemiology unit. His research translates epidemiological knowledge into preventive action and evaluates strategies from behavior change to screening. And he has completed over 35 trials and authored more than 500 publications. And he is going to talk on obesity and cardiovascular risk. So over to Dr. Simon Griffin. Dr. Simon, welcome to the Diabetes India Symposium. Over to you for your session.
Thank you very much, and thank you for the invitation to speak. Can I just check that my slides are showing correctly? Thank you very much. So as you've just heard, I'm going to talk a little bit today about weight loss and cardiovascular events. And I'd first like to acknowledge my postdoc colleague, Dr. Jean Strelitz, who completed many of the analyses that I'm going to share with you today. The first thing to say is that weight loss in people with diabetes is possible. This was the Look Ahead trial in the US, and you'll see significant reductions in weight, improvements in physical fitness, reductions in waist circumference, and improvements in HbA1c associated with a very intensive lifestyle intervention. And this translated into significant reductions in cardiovascular risk factors. So for each risk factor, HbA1c, fasting glucose, blood pressure, and triglycerides, the more weight that was lost, the greater reduction in the risk factor. And as we all know from long-standing data from the UK PDS, that the lower your risk factors like blood pressure, the lower your risk of cardiovascular events. So for every 10 millimeters lower blood pressure, you can reduce your risk of premature mortality by 15%, your risk of heart attack by 11%, and your risk of microvascular disease by 13%. We also know that if you can reduce your HbA1c, again, observational data from the UK PDS, you can have an important and significant reduction in your risk of premature mortality, microvascular and macrovascular complications. The other thing we now know, following the DIRECT trial, is that if you manage to have a really intensive lifestyle intervention, and in this case, it was meal replacement with 800 calorie per day milkshakes replacing your meals, then you can actually achieve remission of your diabetes. And so a third of people achieve remission if they lost 5 to 10 kilograms of weight after their diagnosis of diabetes. And just under 3/4 achieve remission with 10 kilogram weight loss. So the question then is, how do we achieve weight loss? And how do we achieve remission? And there's been lots of different discussions about the different diets that one might use. And lots of people are making a lot of money promoting their own particular version of the keto or the paleo or the 5-2 or the vinegar or all sorts of other diets. So I was part of a group led by Mike Lean that systematically reviewed the reviews and of diets for weight loss and reviewed the trials of diets for diabetes remission. And the answer may disappoint those people promoting particular diets, because the evidence is that the diet that works is the diet that encourages and maintains a calorie deficit over a given time period. So there's no particular diet and no particular macronutrient profile that works any better than any other in terms of reducing weight and reducing HbA1c levels. Having said that, very low energy diets and formula meal replacements do appear to be the most effective approaches, but that's because they seem to be more effective at providing less energy than a self-administered food-based diet. Programs including a hypocaloric formula or diet replacement, certainly in the induction phase, do seem to be the most effective for diabetes remission. And a key limitation is that most of the evidence is restricted to 1 year or less. And so we don't know very much about maintenance in the long term. And another key limitation is that these studies don't look at complication rates. And I'm going to come back to this topic shortly. So do we actually have to have everybody with diabetes having meal replacement and having a really expensive intensive intervention like Look Ahead? Because this is clearly not feasible for the large proportion of the population who have diabetes. And the answer is no. There are alternative strategies that we can use. This is a trial from Oxford, the Be Well trial. And it was essentially people who are overweight who are attending their GP for other reasons. The GP pointed out to them that they were overweight, and in the intervention arm, offered them a free referral to a 12-week behavioral weight maintenance program, like Weight Watchers, Slimming World, that kind of thing. And this had an impressive effect in that the number of patients achieving 5% body weight reduction was 14% in the advice group, but 25% in the behavioral weight management group. And similarly, 10% body weight reduction, 6% in the advice group, and 12% in the behavioral weight management group. I was involved in a trial of a web-based approach, the Power Plus study. And again, this shows small but statistically significant effects on weight with a scalable intervention delivered in primary care. But I think it's important to bear in mind that those of us working in primary care are not responsible for reversing the evolutionary steps that seem to be taking place in human populations across the globe. And we must be mindful of the wider determinants of these changes, such as our access to healthy food, such as the availability of places to expend energy. William James is the father of American behavioral science, and he pointed out that most of our behavior is habitual and environmentally cued. In other words, our decision whether or not to eat a McDonald's is not a function of a rational, cost-effective analysis of the pros and cons of eating McDonald's. It's more habitual and not involving the part of our brain that makes those rational decisions. You'll all have seen pictures like this. Even at physical activity or diabetes conferences, the escalators are full and the stairs are empty. If we want to change people's physical activity to maintain weight loss, we need to change the environment, and we need to direct people towards ways of expending more energy rather than here directing people towards ways of reducing energy expenditure. We need to alter the environment that we live in and make it more walkable. If you live in a gated community, you have to get into your car to drive to the supermarket. Whereas if you live in an environment where there is a mixed environment with workplaces, social spaces, green spaces, all interlinked, then you'll tend to be more likely to walk. This is Glasgow. This is Copenhagen. I don't need to tell you which has the higher incidence of diabetes and cardiovascular disease. This is a study we did in over 5,000 middle-aged people in the area around Cambridge. And we measured the extent to which people were exposed to fast food outlets at their home, at their work, and on the route to home and work. And there was a linear relationship between their exposure to fast food outlets and their consumption of fast food and their body mass index. You'll be aware that the size of portions is increasing across all domains, including wine glasses. But there has been some success in trying to deal with this at the macro level. This is the Mexican sugar-sweetened beverage taxation, which seemed to suggest that taxation reduced consumption of sugar-sweetened beverages and increased consumption of alternatives such as bottled water. The question is, how far up the Nuffield's ladder of state public health interventions are we prepared to go? And unfortunately, most governments at the moment are somewhere down the bottom rungs. So the question is, if we do achieve weight loss, can we reduce risk of complications? Does achieving remission reduce risk of complications? And does weight loss or remission need to be maintained long-term to reduce risk of complications? Or is weight loss in the short term, over a few years before it's regained, helpful? So going back to the Look Ahead trial, these really impressive reductions in weight, waist circumference, and risk factors, what impact did they have on cardiovascular events? Well, unfortunately, the news is not good. There was a 5% reduction in risk of cardiovascular events, and the trial was stopped for futility. And this interestingly contrasts with the Predimed trial conducted in Spain, where the control diet was compared to a Mediterranean diet with additional nuts or a Mediterranean diet with extra virgin olive oil. And the subgroup of people with diabetes, which was smaller than the Look Ahead trial, showed an impressive 29% reduction in risk of events in only 5 years. So we looked in our own data at the risk of cardiovascular events and weight loss, and we looked at our Addition trial data with around 3,000 people with screen-detected diabetes. We looked at the weight changes between diagnosis by screening and 1 year, the weight changes from 1 year to 5 years, and we looked at the cardiovascular events from 5 to 10 years and the mortality from 6 to 10 years. So we allowed a 1 year gap here to try and overcome or deal to some degree with the problem of unintentional weight loss and reverse causality. In other words, if you have cancer causing your weight loss, then you're more likely to die early after the exposure period. And what did we find? Well, the first thing to say is, and this was consistent with some of the later evidence I'm going to show you, is that gaining weight after you're diagnosed with diabetes seems to be very bad news. It increases your risk of mortality threefold. However, losing 5% of weight in the year after diagnosis was also associated with higher mortality, and that was whether or not the weight loss was maintained. And even worse, if you lost 10% of weight in the 5 years after diagnosis, and you had a BMI at the start of less than 30 kilograms per meter squared, you had a 4.5-fold increased risk of mortality. The associations with cardiovascular disease were entirely inconclusive, and it may be we were underpowered to detect associations. But obviously this is concerning. So what about remission? Well, with remission, the news looked a little better. So again, we have around 3,000 adults with screen-detected diabetes who were enrolled at baseline. We looked at people who achieved remission at 1 year, people who achieved remission at 5 years, and we looked at cardiovascular events and all-cause mortality between 1 and 10 years and between 5 and 10 years. We also looked at kidney outcomes at 10 years. So what did we find? Well, firstly, remission is actually a lot more common than was previously believed, even in the absence of an intensive behavioral lifestyle intervention. So over 40% achieved remission at 1 year, and half of those were still in remission at 5 years in this screen-detected population. And what was the impact on risk of cardiovascular events? So remission at 1 year, there was no effect on risk of cardiovascular events, and there was no effect on all-cause mortality. However, remission at 1 year that was maintained at 5 years showed a 27% reduction in risk of cardiovascular events. And again, no significant effect on all-cause mortality, although the effect size was in the right direction. So what about kidney disease? So remission at 1 year was associated with a significant and impressive reduction in risk of albuminuria and nephropathy. And remission at 1 year that was maintained at 5 years was associated again with impressive reductions in moderate albuminuria, in severe albuminuria, and in nephropathy. So the continuous variable appeared to benefit more from the achievement of remission and the sustained achievement of remission than the binary endpoints where we had less power. So in summary, diabetes remission achieved 1 year after diagnosis and maintained at 5 years was associated with a 27% lower risk of cardiovascular events, but not statistically significant. Maintained remission was associated with lower risks of kidney complications, whereas remission followed by relapse was not. And this is the first evidence to suggest that diabetes remission may need to be maintained longer term in order to lead to reductions in complications. And many of the people who achieve remission at 1 year experience relapse of diabetes at 5 years. And the key challenge is how to maintain remission over that longer term. So next, we thought that we would review the world literature on the incidence of cardiovascular disease and mortality among adults with diabetes, and look at the relationship between weight loss and risk of cardiovascular events. So we included observational studies of behavioral weight changes. So we excluded drugs and we excluded bariatric surgery, for which the evidence is obviously very strong. So bariatric surgery is consistently associated with a reduction in risk of events and premature mortality. And diabetes medication are consistently associated with benefits in terms of cardiovascular events. So we were looking at the behavioral weight changes. We also looked at the trials of behavioral interventions targeting weight loss. So the studies had to report change in weight, and they had to report cardiovascular events and mortality or mortality outcomes among adults with diabetes. So we did a narrative synthesis of observational studies because the studies were so heterogeneous, but we did a meta-analysis of the trial data. And these are the findings. So the first thing to say is there's some degree of heterogeneity between the results. And there is certainly no consistent pattern that weight loss is associated with a reduction in cardiovascular events. In fact, the green arrows show where weight loss is associated with a reduction in risk of events, and the red arrows show where weight loss is associated with an increase in cardiovascular events in these observational studies. What about weight gain? So weight gain, again, the evidence is consistent and is consistent with our findings I showed you earlier from our addition trial. Weight gain after you're diagnosed with diabetes does increase your risk of cardiovascular events and all-cause mortality, and so should be avoided at all costs. What about the trials? So these are behavioral intervention trials targeting weight loss. And again, what we find is heterogeneous results, with some evidence suggesting that the interventions targeting weight loss increase your risk, and some studies, for example, look ahead, suggesting they reduce your risk, but not showing statistical significance. So overall, behavioral interventions targeting weight loss are associated with a non-significant 5% reduction in risk of cardiovascular events. So there is substantial heterogeneity in the associations between weight loss and cardiovascular events among people with diabetes. And these sources of heterogeneity include things like the duration of weight loss, the method of accounting for unintentional weight loss, which is clearly a problem in observational studies, but also the underlying cardiovascular risk. Short duration of follow-up of the behavioral intervention trials may be insufficient to detect associations with cardiovascular events. And it's therefore a great shame that the Look Ahead trial was closed prematurely due to apparent futility. Weight gain, however, is consistently associated with higher risk of cardiovascular events and all-cause mortality. But the impacts of weight loss on cardiovascular events or mortality remain unclear. The key thing we should be doing is encouraging patients to avoid weight gain, and that should be a major focus for patients and practitioners. Also, the impact of weight loss on risk of complications may actually vary between individuals in relation to things like their age and relation to things like their previous experience of cardiovascular events. So people who've had cardiovascular events appear to do worse with weight loss than people who hadn't had previous cardiovascular events. We need longer term follow-up of large behavioral intervention trials in order to understand the effects on cardiovascular disease and mortality, and to inform our advice and policy, such that we can move towards a more personalized weight management and advice strategy for people with diabetes. It may well be that the previous advice that if you've got diabetes, you need to lose weight doesn't apply, and one size does not fit all. But we need better evidence in order to inform a more personalized approach. Thank you for your attention, and I'm happy to join the panel to take questions.
Thank you, Dr. Simon, for a wonderful presentation on the nitty-gritty of weight loss with various trials and its impact on reduction in cardiovascular complications and cardiovascular events. And there are some very interesting data, which I'm sure there are going to be some questions. Let's see what are the questions from panel first. Can we have the questions coming?
No, not a question is coming.
Okay, so we can start with, can we have the panel on screen? Hello?
Hello, I think we're here.
Yeah, you are there, but I was talking to the events people. Can we have all the panelists on screen? So let's have one quick question from Dr. Simon. You showed wonderful data that, this weight loss is not the only thing. Sustaining weight loss is going to be important in achieving the benefits, and also showed some very interesting data that even weight loss, post-diabetes diagnosis is associated with increased risk. Now, was this intentional weight loss or it was just weight loss? Because intentional weight loss is different. We have to differentiate here.
Yeah, absolutely. So I think this is a real challenge in all the observational studies in this area. And many of the studies, it can be a fatal flaw that the people who are unintentionally losing weight have greater risk. But even
once we look at unintentional weight loss, possibly these are the people who are not well controlled, that they are in the catabolic phase.
Yeah, or they have other reasons for their unintentional weight loss. Because in our addition trial, for example, the 50% of the causes of mortality was cancer related, not cardiovascular related.
Yeah.
However, I would point out that some of the studies do make reasonable efforts to try and overcome the issue of unintentional weight loss and mortality by, for example, excluding the first year of follow-up after the weight loss has been observed, such that people who did have things like cancer and died in that period are excluded from the analysis. And it's true that the studies that make less efforts to look at unintentional weight loss show a more deleterious effect of weight loss than the studies that allow for it more appropriately. Now, some would argue, and my colleague Mike Lean would argue, that actually all the observational studies are flawed because of this. I would argue that actually, I think the studies that make reasonable efforts to overcome the problem of unintentional weight loss do still point in the direction that uniform weight loss advice to everybody doesn't appear to be the most appropriate thing to do, because weight loss may still be associated, particularly for some, with adverse events. And the other thing I'd point out to you is that if you look at the trials where you remove the impact of unintentional weight loss through randomization, you still don't see an effect of weight loss, of interventions targeting weight loss on the outcomes. So even with a really intensive approach like Look Ahead, and with 10 years of follow-up, and with weight loss sustained and the difference between the groups sustained over almost 10 years, you still didn't see an effect. And the analysis of the Look Ahead trial does suggest that there are some subgroups who may be actively harmed by the weight loss. So I would say that weight gain is consistently associated with worse outcomes. And we should really focus on encouraging people to avoid weight gain where the evidence is very strong. I would say that you may well want to encourage weight loss to reduce HbA1c and lipids and blood pressure and so on, because that will reduce your risk of microvascular events. But trying to suggest to people that losing weight will reduce their risk of cardiovascular events, I don't think we have, and all-cause mortality, I don't think that we have the evidence that we can robustly use to support that.
But as
what we need is longer-term follow-up of the intervention trials to better address this question.
As you mentioned, maybe the look ahead was stopped a little early, and maybe we need longer follow-up to actually see the benefits.
Well, if you look at the Daqing trial of diabetes prevention,
30 years
the Chinese population, where significant differences in behaviors were achieved over a sustained period, it took 25 years after randomization before the reduction in mortality and the reduction in cardiovascular events was observed with statistical significance.
Yes.
So the only trial that I'm aware of a behavioral intervention that shows a reduction in cardiovascular events in a relatively short time frame, like 5 years, was the Predimed trial. And that's why I wanted to show that slide, because it really does stand out as being almost unique. Most behavioral intervention trials aren't followed up long term. And if they are, you need to follow people up for 25 years and maintain differences over 25 years in order to demonstrate effects in cardiovascular events and deaths.
Thank you, Dr. Simon. Can we have Dr. Pratik and Dr. Dinesh also on screen? RX events, can we have the gallery view here? So Pratik, I have a question for you.
Sir, there is a view button in upside.
I'm not seeing that actually, so you have to do it from your end. Anyway, so Dr.
In the top right corner, there'll be a view button right there in the corner.
No, I don't have. Actually, I am logged in from my phone, sitting in the other meeting.
Yes, sir. Sir, please swipe the screen.
Okay.
And there is a button to view.
No, I can't. Anyway, it doesn't matter as long as we can have the questions going to the panelists and they are able to answer. So Pratik, you made a wonderful presentation on ADAPT study and showed some wonderful data. But in countries like India, where do you see the technology, moving ahead and what pace?
So I'm really excited. We were at the ATD in Barcelona, of course, a couple of months ago, and there's lots of exciting innovation in India. And I hope really that innovation will allow this technology to appear at a lower price. And then at the other side, I think, what's really pushed the access to these technologies in the UK is very strong lobbying for funding, because we know in India, now with various, Ayushman and other things coming through, I don't know how much we can get for these people with type 1 diabetes, some sort of coverage, because that's the, price is the main barrier. But it shows that, and the other angle is, I think some of the benefits of closed loop, some of the decision support will feed through algorithms to people on MDI, and we're starting to see that coming through. So I'm hoping in the next few years that we can use some of that decision support with injection therapy to help, people in India.
So are we going to see some cheaper alternatives, like now we are looking at, interpretation of SMBG values similar to the CGM data, and that maybe, gets connected to a interface which helps in decision making?
I think that's definitely an area of a lot of interest and a lot of work at the moment. Now that closed loops kind of have started working, a lot of interest and industry effort is shifting to that MDI group with decision support. Connected pens are the biggest enabler, connected pens and connected meters. So as soon as that comes through, and they are low-cost alternatives, that will help that process.
Thank you, Pratik. Dr. Dinesh, are you there? Yeah. So I was just, looking at these trials you showed and some very wonderful data, and the Optimat trial, you showed the differences between different agents. So what is the best option for a person who is coming with persistent neuropathic pain? Despite combination therapy, we are not able to, help more than 50% of the patients. So what do you, recommend for these patients?
So in in some of these patients who are already on combination treatment and the treatment's optimized, and they're still still suffering with quite severe neuropathic symptoms, there's a couple of interesting studies coming out now looking at the 8% capsaicin patch therapy, which can help some of these individuals. There's also some new evidence that spinal cord neuromodulation, so having spinal cord implants with some of the new algorithms which have been developed, also can help some of these individuals. But before we start using these techniques, I think it's important to optimize the medications that they're on already, because what we find is that often patients have started their medications and they're left on it, and treatments are not optimized to the maximum tolerated dose. And by doing so, you can actually improve their pain intensity scores. And we also need to pay attention to the looking at the psychological impact of pain on these individuals. So if you've got access to pain management groups, we find that combining pharmacotherapy with some of these psychological interventions also helps these individuals.
Do things like TENS therapy or local applications, do you use them in patients who are not responding to combination therapy?
Yes, so any adjunctive treatment such as that can be beneficial. So acupuncture, there's some evidence to show that that also helps in some individuals with painful diabetic neuropathy. I mean, the evidence for TENS in itself isn't very robust, but other adjunctive treatments can sometimes be beneficial.
Thank you. Thank you. I think we are already, we have overshot the time, so we'll come to close of this session. Thank you for making such wonderful presentation to all the panelists, and thank you for taking out time for this Diabetes India meeting. I think we all had wonderful sessions here. A big round of applause for all the panelists. Thank you so much. Thank you so much for joining.
Thank you. Thank you, Diabetes India, for this year's collaboration.
Thank you. Bye.
Thank you. Thank you. Bye.
Thanks, guys.
Good afternoon, Dr. Bakrai.
Hello, can you hear me?
Yeah,
Hello.
definitely, I can hear you.
I'm Laszlo Barker.
Hi, I'm Dr. Patni.
You are the first speaker.
Yeah.
Okay.
The chairs are missing. I hope they will join soon.
Yes, the voice.
Hi, Dr. Mashi.
The voice is a little bit blurred. I just tried to adjust. Oh, no, it's not.
Is it comfortable now?
Yeah, it's okay. Hello, Massimo. Okay.
Hi, Dr. Stephen.
Hi, Stephen. Okay.
You're not audible.
You are on mute. Stephen, you are on mute.
I think you can join through the computer audio.
Can you hear me now?
Absolutely. Yeah.
It's okay now.
All right, that's fine. I can hear you as well. Great. Okay. I dropped my computer a few weeks ago. Excellent. Right. There we are. Okay. Great.
Do we have the chairs? Oh, yes.
Dr. Dhruvi has just joined.
Okay.
Hello, there was some technical error and I could not connect on time. Good afternoon, everybody.
Good afternoon.
Okay.
Good afternoon. Thank you so much for connecting with us on time, and I really appreciate all of your presence today. So today is the day 2 of the 12th World Congress of Diabetes India, and I welcome you all virtually to Goa. And I'm quite happy and privileged to be chairing the first session. My co-chair is Dr. Rupam Chaudhary. He's here too. Hi,
Hello.
Dr. Rupam. He is a consultant diabetologist for Apollo Clinic in Guwahati. And this is me. I'm Dr. Dhruvi Hasnani. I'm a consultant diabetologist from Ahmedabad, from Rudraksh Institute of Medical Sciences. So without much ado, can I request Rupam sir to introduce our first speaker, Dr. Vijay Patni sir.
Sure. Welcome, Dr. Vijay Patni sir. This is a scientific extravaganza we are going through in these 3 days, and thanks to all the speakers and all eminent diabetologists who are joining us in this extravaganza. So I would like to invite Dr. Vijay Patni sir to deliver his talk.
So Dr. Vijay Patni sir is a consultant physician and cardiodiabetologist from Diabetes Wellness Clinic in Kolkata. He is also the founder of a very huge association called the Diabetes Research and Wellness Welfare Association. He has been a scientific chairperson to the 7th annual conference of DRWA 2019 and 2021 for Diabetes Update, and he has been a faculty and a scientist as well as an academician at multiple various national and international programs. So with that, if we have Dr. Rupam's permission, can we have Vijay Patni sir's slide, and can we request him to go on with the talk?
Yeah, sure.
Yeah.
Can you allow me to share my screen?
RX team?
Sir, in downside, there is a
Thank
green
you.
button. Yeah.
See the screen, please.
Yes.
Sir, it is not on slide. Yes. Okay.
Thank you. Thank you, chairpersons. Thank you, my co-speakers, for giving me this opportunity, and thank you, Diabetes India as well. And we will be speaking on a very important topic, adjuvant therapies for type 1 diabetes, because that looks like a future. It's a known fact that the insulin remains the cornerstone of managing type 1 diabetes, in spite of various modifications, inventions, and formulations, along with the delivery techniques and monitoring techniques, we still are lacking. Lacking in what? We are unable to achieve the targeted glycemic targets like HbA1c or time in range. Along with that, because of this, most of our patients, majority of them probably, are having long-term complications. And insulin being the cornerstone, we are unable to address most of the issues. So the whole focus has now shifted to think something else away from insulin, so that whatever we can add to the therapy, so that bring out or bring down the complications associated with type 1 diabetes. In not doing so, basically, there are probably 3 major principles which need to be followed. And the first one, I would say, there's an obvious need to act fast, and so that we can reduce or prevent the beta cell destruction. The second principle, obviously, is to program or reprogram whatever beta cells is left, so that it is of a great use. And third one is to address the complication associated with type 1 diabetes. So keeping that in mind, I would proceed now. So basically, we are all aware that about 1.25 million people in the United States have type 1 diabetes, and we too have a huge population. We have a huge population of diabetes. So if you contribute even 5% of those population as type 1 diabetes, that comes to a huge number. All patients with type 1 diabetes requires insulin, but the issues are to intensify insulin to reach the target, and that remains a challenge. This is basically the timeline of various therapeutic discoveries in type 1 diabetes and the future therapeutic development. As we all know, we are in the centenary year of insulin discovery, and thereafter we had huge number of modification in insulin. A huge number of modification insulin. Along with that, in the meanwhile, 2005, we got amylin analog, pramlintide approved. We had various immunomodulating drugs, cyclosporin and teplizumab. All these were there, but ultimately none of them have got the approval, excepting pramlintide, and probably we're looking towards sotagliflozin, which have already got approval in certain quarters. But then the future therapies, which one of my co-speaker will be speak on, the immunomodulating drugs or therapies, which might be the essential management tool which can address most of the issues with type 1 diabetes. So my agenda will be to speak first on the non-immunomodulatory molecules, and thereafter just touch upon some investigational agents and then the take-home message. So the first therapy, obviously insulin sensitizer, metformin, and all of you are aware that metformin is one such molecule which have some impact on insulin resistance and decrease the hepatic gluconeogenesis, but still has not been approved by type 1 diabetes, though it has made in various studies, has shown some kind of influence as far as the HbA1c reduction, weight loss, or even in decrease in the insulin dosage is concerned. 2 randomized controlled trials, which we are looking forward to removal, which is already published in Emerald as well. So what we saw in this particular systemic review of efficacy, this was basically when they gathered about 197 studies of which various trials, and then they looked into the efficacy part, and they could reduce that metformin was associated with reduction in insulin dose requirement, even in HbA1c, even in weight, and some small reduction in total cholesterol. So adding metformin to insulin therapy may reduce insulin requirements. This is what ADA says, and improve the metabolic control in overweight, obese patients and poorly controlled adolescents with type 1 diabetes. So this is what we are expecting that metformin to do, but still the approval is awaited and has not been advocated for use. And this is the removal trial, which was the cardiovascular metabolic effect of metformin. Unfortunately, it could not deliver that importance which it needed for metformin so that it could have been used for type 1 diabetes. And it suggested that it doesn't support the use of metformin to improve the glycemic control in adults with long-standing type 1 diabetes. But then it could be looked into whether it has some modulatory impact as far as cardiovascular risk is concerned. Next, we go into the thiazolidines, that is the glitazones, rosiglitazones, and paraglitazones. And it has been proved beyond doubt that this therapy probably is not going to work, in spite of the fact that it's the only molecule which have a huge impact on insulin resistance. But what we are concerned with, the insulin secretory part in type 1 diabetes, which has a major impact. It was seen with the rosiglitazone RCT, basically, where it showed that there was a definite decrease in the insulin dosage when this was combined with insulin, but there was no significant change in HbA1c, and obviously rosiglitazone is no more there. There is a package insert which says it should not be used in the treatment of type 1 diabetes. The third such molecule which is of importance, that is the pramlintide, is the amylin analog. Basically, type 1 diabetes patients are deficit in amylin. And this is the reason why this was tried, and it has somehow achieved little bit of impact, but not to that extent. It basically delays the gastric emptying, blunts the pancreatic secretion of the glucagon. These are all CNS modulated and enhances the satiety as well. So the major impact is on the postprandial sugars, and the side effects are profound. So because of the increase in number of injections to be given in a day to control the prandial sugar, along with the side effect profile, probably it is not able to address the major issues, though it has good efficacy of reduction of about 0.3 to 0.4% of HbA1c, and does induce weight loss and lower the insulin dosage. So it has been considered as adjunctive therapy approved, in particular in the US, in type 1 diabetes patients who have failed to achieve the glycemic goal. Next, we come to the alpha glucosidase inhibitors, acarbose. Now, acarbose was studied, and basically what they realized that it does reduce, as expected, the postprandial plasma glucose levels, but there was no significant effect of HbA1c, and the long-term benefit was not seen, though the safety and tolerability was not that a great issue. It was reasonably safe, but yes, the GI effects were much more. The next important therapy is the increasing base therapy, and all the eyes probably on this non-immunomodulatory drug group is this particular molecule, that is the GLP-1 receptor agonist. And the mechanism which helps in having an impact a little, not only on the insulin secretory impact, but it has its own other mechanism which can almost address 6 of the 8 pathophysiological mechanisms responsible for diabetes, but that's more in type 2 diabetes. So what we see out here, they do delay the gastric emptying, they suppress the postprandial glucagon in rise, increase the satiety, and facilitate weight loss. So it acts as an adjunct to the insulin. Could be a great molecule, but has not been approved by FDA yet. And this was the study, and where a total of 9 clinical trials was reported. It was considered in overweight or obese patient, though not at glycemic goal. The molecule used was liraglutide, and this was the only molecule which had the strongest evidence as far as this group of drug being used in type 1 diabetes. The effect on HbA1c was inconsistent, but reasonably it showed some impact. Along with that, it showed lowering of the dosage of insulin along with the postprandial blood sugar control. But the adverse events was in the population was intolerable, and mainly it was GI side effects. So this particular paper has actually looked into the meta-analysis of 3 RCTs, and they concluded that the HbA1c was reduced to about 0.3%, and both the basal as well as the bolus doses was reasonably reduced, along with a huge impact on the body weight. Though there was an increase in the risk of nausea, but did not increase vomiting. And there was a two such trial, adjunct trial, that was trial 1 and trial 2, which concluded that this is a molecule which has shown some promise and could be further studies are needed so that we can really include this molecule in the armamentarium of type 1 diabetes. And in that particular study, it was shown that it doesn't increase the DKA as well. So basically, what is more important is the mouse or the animal model where actually it showed that it increases the beta cell proliferation, increase in beta cell differentiation, decrease in the rate of beta cell apoptosis. This gives us a hope, basically, that this GLP-1 receptor agonist could be a molecule of future for type 1 diabetes, as and when it is approved and when large studies are done with it, so that we get a better outlook as far as this particular molecule is concerned. Now, DPP-4, it doesn't show much promise, has not been improved by FDA. There was various meta-analysis of various trials was done, but it doesn't have much of impact on HbA1c, neither it increased the fasting C-peptide level. So probably this molecule doesn't show much of a hope. SGLT2 inhibitor, because it is insulin independent glucose lowering agent. So this was one particular molecule which was thought about, and along with not only the blood glucose lowering impact, it has other impact like lowering the blood pressure, lowering the weight reduction property was there, but the limitation was the diabetic ketoacidosis. So presently, SGLT2 inhibitors are not recommended, but we have this particular molecule, which is the dual SGLT2 inhibition, sotagliflozin, which is approved in use of type 1 diabetes, though not universally. And these are the various trials which has undergone with SGLT2 in type 1 diabetes patient. It was the DEPIC trial, dapagliflozin, empagliflozin, East trial. East trial really showed some kind of I would say the conclusion was that if you do use a very low dose of empagliflozin to the tune of 2.5 milligram, probably the episodes of decay are taken care of. There were not so many patients, so many episodes of diabetic ketoacidosis. So that's a one good point. But Tandem has put sotagliflozin high above these two SGLT2 inhibitors, and this has been the present approved molecule in certain quarters. But the one important thing is that this should be done under surveillance, under vigilance, and one should be aware of ketoacidosis, and then only this molecule should be used, though I know this is being used off-label in certain quarters. So important points of this particular talk is most patients with type 1 diabetes on exogenous insulin injection do not achieve the glycemic goals. Exogenous insulin treatment has limitation, including insulin-related weight gain and recurrent hypoglycemia. Almost all patients with type 1 diabetes have inappropriately high glucagon level, which contribute to hyperglycemia, and reduced insulin sensitivity increases the insulin dose requirement. And these are the various, I think, the conclusion on various molecules which are already discussed, and the only promising molecule of which of the approved molecules happens to be a myelin agonist. And along with that, we are looking forward to GLP-1 receptor agonists and the dual SGLT2 and SGLT1 inhibitors. So the dual blockade SGLT2 inhibitors would probably, SGLT2 inhibitors might be one such molecular group which can come in a long way, because there are other molecules apart from sotagliflozin which are looked into. So according to ADA, the GLP-1 agonist, DPP-4 and SGLT2 are maybe the potential therapies, but do require large clinical trials. US FDA have clearly said the metformin, SGLT2, GLP-1, DPP-4 are not FDA approved for the treatment of type 1 diabetes in the United States. Now, this I'm just going to touch because the whole talk will be taken over by my co-speaker. The immune-focused therapy, probably they are the future, though they have not yet shown that much of a conclusion as far as the as a great kind of adjuvant therapy for type 1 diabetes. But if you look at the pathophysiology, there are predisposing factors over and above. If a trigger is there like infection, these unhealthy beta cells which are there in this group of population they actually undergo auto-antigen recognition, which will lead to beta cell destruction, what we call assist suicide. So this particular beta cell destruction will lead to all the metabolic derangement and complications, and ultimately to increase mortality. The conventional theory was there. The major reason behind this type 1 diabetes was dysfunctional immune system. That is the imbalance between autoreactive T effector cells and T regulatory cells. So the various molecules which can act at these various levels can be of benefit in future as an adjuvant therapy for type 1 diabetes. If you look at the beta cell areas, or at the local action at the beta cells, probably the antigenic immunization or tolerization with oral insulin or peptide could be one such therapy. The stress relief, which we have seen with GLP-1 receptor agonist and verapamil, or the stimulating remaining cell mass, that is the GLP-1 receptor agonist. As I addressed, which are the three major principles, one or two principles are implied here. And then the systemic approach to actually look into the dysfunctional immune system, whether it's targeted immunomodulation with cytokine blockade, or immune suppression, or T regulatory cell expansion. These all can be of importance if further studies are done down the line. But present scenario, which we have the non-immunomodulatory drugs which can address not only the metabolic derangement as well as the complications. And they probably should be looked into, particularly focus should have been on the GLP-1 receptor agonists and dual SGLT2 blockade. That could give us an insight into the particular additional therapies which we can employ in type 1 diabetes along with insulin. And obviously the curative treatment on the horizon happens to be stem cell therapy, and we hope that will be taken care of very soon. But unfortunately, that is also going to be an issue of autoimmune destruction in those patients who receive stem cell therapy as well, unless a proper immunomodulation is done in those cases as well. I think I will leave it here rather than going into the further into the immune focused therapies, because my co-speaker will be dwelling on that, and I don't want it to be a repetition. So to take home message from my side would be insulin still remains at the cornerstones. Pramlintide has been approved, but there are issues with it. Very difficult to use them in day-to-day practice. Metformin, debatable, but has shown benefits. Pioglitazone and rosiglitazone probably out of tune. And GLP-1 agonist, DPP-4, SGLT2 inhibitors need to be looked into with larger clinical trial, could be a potential therapy for type 1 diabetes. And sotagliflozin is the first approved oral medication for type 1 diabetes to reach the market. And obviously the investigational agents or the futuristic or the immunotherapy based molecules looks to be the future in type 1 diabetes. Thank you. I'll stop sharing. Yes, please.
Thank you, Vijay sir, for your excellent deliberation. It is unfortunate that despite all those basal bolus therapies we give to our type 1 patients, more than 50% of our patients does not reach their glycemic target or optimum HbA1c. So one question, sir, I mean, have you come across any DKA cases or any metabolic acidosis with the use of SGLT2 off-label, of course, in your patients?
No, I have not used SGLT2 inhibitors in type 1 diabetes patient, but with the use of SGLT2 in type 2 diabetes, I have come across euglycemic DKA in certain group of patients.
Dr. Dhruvi, if we have any questions?
I think, I'm sorry, I'll have to prompt you guys here that we have a separate discussion segment at the end of the session. And if you all agree, let us dedicate that time to discussion at that point of time.
Nice.
And let us move ahead to our next speaker, Dr. Barkay Laszlo. Okay, it's the other way around. All right, it's Dr. Laszlo Barkay, and he's a professor of pediatrics at Safarek University in Kosais, if I'm pronouncing it right. And he is the Theoretical Health Sciences Professor and Head of Institute for the Theoretical Health Sciences, University of Moscow, and he's been the past president for Hungarian Diabetes Association. I'm sorry if I have had, mispronounced something. Over to you, Dr. Barkay.
Okay. Thank you very much. I'll try to share my slides with you. Just a moment. Okay. Can you see my slides?
Yes, sir.
Okay. Thank you very much. It's my great pleasure. Sorry. Is it okay to see?
Yes.
Good. So thank you very much, first of all, for my kind invitation from the organizers of Diabetes India, especially to my friend Banshi Shabu. And I'm really happy to share my thoughts in this audience. So let me start with this big trial. This is a type 1 diabetes exchange program in the United States, and clearly showed that during the past years, there is an increasing rate of use of new technologies, and that means the pump and CGM systems. But as you can see on the lower panel on the left, the global glycemic control of the patients did not improve during this period. If we look at the 2016 to 18 period and compare the results to the 2010 to 12, the glycemic control expressed by A1C was poorer in the later years as compared to the former. And actually, the problem is that especially in youth, children, adolescents, and young adults showed the poorest results. The good news can be seen on the right side. Those patients who used pump and CGM together had the best A1C levels in all age categories. So
Can I interrupt you a second? Could you put this on slide mode, please?
Sorry?
Could you put it on a slideshow mode, please? The slides are in a simple slide mode. If you can put it in the slideshow.
Yes, I'm not able to clear. You know, there are the pictures from the camera on the right side.
Okay.
How can I?
Could you just try discontinue sharing once and try sharing it once again?
Okay.
Yeah, that could be a simplest answer.
Just a moment. Okay.
RX team, then we could really use some help right now.
Stop share. Okay, now. I'm sorry.
Sir, do it on slideshow and then share screen.
So can you see now? Not.
Not yet, sir.
Okay. Now is it better?
Still not in the slideshow mode. Could you try doing that?
Can you see now?
We can see your slides, but they are still not in the slideshow mode.
Yes.
Sir, there is a below button
Yeah.
Zoom out, and besides the zoom out and zoom in right downside, sir. Yes, downside.
Right down.
Yes. Besides the zoom out and zoom in. Yes. Press the button, sir.
Now is it okay or not?
Yes, sir.
Can I continue?
Yes, please, sir.
Okay, so I would like to talk about how can we replace islet function and how to check clinical target achievements. So we have good delivery systems nowadays and good monitoring systems. For delivery of insulin, we use pens and pumps, and for monitoring the capillary glucose measurement or the interstitial glucose. The pump and interstitial glucose devices are able to provide a so-called automated insulin delivery. Of course, this should be in conjunction with data management. Continuous subcutaneous insulin infusion and real-time glucose monitoring is really a good choice and gave a big advantage regarding optimal therapy adjustments. However, we have limitation because using these devices, using these methodologies, these are time-consuming for reviewing data. So what is the possibility? We have to close or put closer these two devices, a connection between the pump and the CGM, and on the right side can be seen the closed loop system sensing the glucose level and using a modulation, and insulin delivery is driven, and the glucose control is possibly improved. The brain of the system is, of course, the control algorithm. Nowadays, on the clinical practice, on the market, we have the so-called open loop system, which is a sensor augmented pump, which is totally dependent on user input. However, there are three very good functions. The threshold suspend function, which means that insulin can be suspended when glucose level is dropping. The predictive glucose, low glucose suspend means that insulin will be stopped when the glucose decline is predicted. The high glucose minimizer means that the insulin delivery will be increased or activated when glucose level is increasing or predicted to increase. The hybrid closed loop system, more advanced technology using continuous basal rate adjustment in response to glycemic trends, but this still requires user inputs like carbohydrate intake or so on. And the future would be the fully closed loop system, the artificial pancreas, which could be not dependent, absolutely independent on user inputs. One assumption is that the bihormonal artificial pancreas, which uses not just insulin, but an additional hormone, most commonly glucagon. We have to mention the do-it-yourself devices, which are community developed devices, and these communities are applying these systems. We have to state that these systems are not approved by the authorities. How this hybrid closed loop system is working, as you can see, the patient should input the carbohydrate intake. Meanwhile, the glucose level is measured. Actually, the lower panel shows that using a continuous glucose continuous insulin delivery. Sometimes the patient needs to give bolus insulin. So, however, as this big randomized trial in children with type 1 diabetes showed that the hybrid closed loop system is working much better as compared to the older one, the sensor augmented pump. Looking at the slide showing that this 4 months trial, the glucose level was much longer time, significantly longer time in the target range using hybrid closed loop system as compared to the sensor augmented pump. So the problem with these systems is that either the monitoring or insulin delivery you currently uses the subcutaneous tissue. And this is non-physiological. We would like to use the intravascular compartment to monitor the glucose and to deliver the insulin in this area. That's why there is a big research drive towards the implantable artificial pancreas, which is a big issue. Just an example, using a spectroscopy method to measure the blood glucose in the microvessels using the nail bed, which is quite rich of capillaries. This could be used for non-invasive and quite accurate measurement of intravascular blood glucose level. However, this is understandably far from the clinical practice. Another approach, how can we implant insulin pump? This is one assumption published in the Science Robotics recently. An implantable pump could be placed into retroperitoneal tissue, and the capsule swollen by the patient contains the insulin, and the capsule can be docked at the pump level and deliver the insulin content into the pump, and the insulin will be finally delivered to the peritoneal cavity. I have not to emphasize that this is still far from the clinical practice. If we have a new systems, of course, we need new indicators as well. It's absolutely well known that if we have 3 patients exactly with the same A1C level, there could be a big difference or big differences between the glycemic control regarding the swings, the glycemic variability. If we use just self-monitoring capillary blood glucose measurements, we will not able to capture these swings. If we use the CGM, we can realize that how big is the glycemic control, the glycemic variability. Some recommendations came out from the literature. This is one of the latest one. This is the international consensus. And this consensus pointed out that the clinical utilization of CGM results are still suboptimal. We have a huge number of data, and we have to handle them. And this is really difficult to understand what can we do with them. It's time consuming. In some countries, there are reimbursement problems with using CGM, and there is some kind of lack of standardization of data and lack of visualization. Okay, this recommendation highlighted the use of a simple parameter, simple method to check the glycemic control from CGM data. And this is now has been introduced into the clinical practice, the time in range parameter, which means that how long time of the glucose level spent in the target range. Target range is recommended 3.9 to 10 millimole per liter. Above this range, hyperglycemic, and below the range, hypoglycemic ranges. The better the control. If the time in range is longer or bigger or higher, and the better the control if the hyperglycemic or hypoglycemic time and measurements are smaller. Another parameters, the glucose management indicator. From this big number of CGM data, we can have an estimation. We can make an estimation of central laboratory A1C level, because there is a quite strong and significant correlation we can use to estimate the A1C level from CGM data. Nowadays, the recommended parameters, of course, the average glucose level is understandably, and the so-called GMI, which is the estimated A1C level, should be below 7%, and glycemic variability, which is the percent of coefficient of variation of the glucose, is less than 36%, and time in range, it's better if it is over 70%. However, these parameters usefulness will be shown if the clinical indicators could be improved by the use of these parameters like hypoglycemia or late complications, cognitive function, or quality of life. Another recommendation is that the standardized reports and ambulatory glucose profile should be provided for the patients and for the doctors as well to visualize and interpret data. And nowadays, most of the companies are using and accepting these recommendations. Finally, these new parameters. How can we be sure that these markers are valid with regard to late complications? Could these parameters surrogate markers for complications? This summary, this recent paper summarized this concept from some literature research data and showed that the increase of the time in range will result in a decrease in microalbuminuria frequency and retinopathy rate. So it seems to be that these new parameters are working and hopefully will be really useful in the future perspective of our patients. So in conclusions, dear colleagues, I would like to emphasize that current technologies improve type 1 diabetes management, but the biggest barriers are the non-physiological glucose monitoring and insulin delivery. The new indicators of glucose metrics should be considered nowadays in the clinical practice, and standardized report on ambulatory glucose profile is needed to understand the results. And further research will be established the long-term benefits of emerging technologies and new indicators of glycemic control. And let me to finish my talk and thank you for your attention with this slide, with this picture, when our old friend Shaukat Shadikot, who was actually the founder of Diabetes India, he was still with us at that time, but now we are really missing him from Diabetes India. Thank you very much.
Thank you, Dr. Barkay. It was an excellent presentation. thanks for your insight on this topic. So Dr. Ruby, I think next speaker is ready. We have Dr. Stephen Green from UK.
RX team, can we please have his introduction slide? Thank you. Dr. Rupam?
Yeah, we have our next speaker, Dr. Stephen. He is from UK, and he's a consultant diabetologist for children, adolescents, and young adults at London. He's president of International Society for Pediatric and Adolescent Diabetes, also known as ISPAD. And his tenure was from 2012 to 2016, and he's currently a director of Scottish Children Research Network. So I would like to invite Dr. Stephen for his deliberation.
Okay, thank you. So just before we start, can I check, can you hear me okay? Yeah?
Yes,
and
we can. Yes.
I've had some problems with my sound on my computer, so sorry about that. Right, so I'm going to try and share my screen now. And okay, there we go, and we'll put on that. Right, okay, so I was very grateful for Dr. Patney for setting me up there. It was very good. I could have gone off and had a cup of coffee, because you've given the lecture, which is fine. But I'm going to actually approach this slightly differently. I'm not an immunologist. That's number one. Absolutely not an immunologist. I'm not even sure I understand a lot of immunology. And secondly, although I have been involved in the prevention studies over the years as a participant and actually instigated one of them, I'm not currently involved in any prevention studies. So I'm actually coming at this from a pediatrician involved with families and young people with diabetes. And in a sense, the way I've approached it is because one of the commoner questions that is being asked all the time now when people come along to the clinic when they've first been diagnosed is, can you cure diabetes? It's perhaps been a common question that's always been there in patients' mind, but there's more and more information coming out, particularly through internet sites, patient associations, charities, etc. And so parents come along with a lot of questions around that whole idea that they should be able to do something to prevent or ameliorate the diabetes. And that's what I'm going to concentrate on in this talk. I'm also going to concentrate on, I just need to change the view here a minute. Oops, sorry. How do I change the? Oh, I'll leave it. I'm also going to concentrate on immunotherapy, biological therapy. I'm not going to say anything of any detail about stem cell therapy or islet cell transplants, which you could argue comes under immunotherapy, but I'm going to, as I say, strictly concentrating onto the biological sort of approach for immunotherapy. And there's all sorts of things that have been thought of and being used. I mean, this is where my lack of immunology training comes in, how all of these work, how they're set up, how they're established is really something for the expert. It's a minefield of areas in which to do. But fair to say that virtually all of these have been looked at in the approach to treating diabetes. And I think it's fair to say over the last 30, 40 years, most of them, virtually all of them, have turned out to be ineffective. So many of us who've been around for a while remember the initial excitement over cyclosporin as a immunosuppressant, azathioprine, then moving on to nicotinamide, and these drugs were thought to be very exciting at the time and really proved nothing. And then we've come more into the biological ages and particularly the monoclonal antibodies. So I'm going to talk a little bit about those in depth at the moment. What's gone wrong here? Oh, there we are. Now, this is my simplistic view of the autoimmunity of type 1 diabetes. The point I want to make about here is that we still haven't identified if there is an antigen which sets the whole process off. People are constantly looking for this. Still interest in virus stimulation. Is it dietary? Is it an environmental stimulus? We don't know. So we don't know whether there is actually an antigen which sets the whole thing off. What we do know that there is some genetic component to this with the MHC compatibility, HLA system, which triggers, combined with an antigen, triggers this process, which then very rapidly turns on itself through the T cell damage and the effector white cells, and eventually leads to this vicious circle of destruction of the beta cell. And the autoantibodies are a probable consequence of all of this destruction and leading to the apoptosis and necrosis of the beta cell. So there's all various ways in which you can try and alter this process. The point though about that process is in this graph, and I'm going to spend most of the time in the next 10 minutes or 5 minutes, 5 to 10 minutes, talking about the disease progression and how you can alter it. So I think this is the current acceptable scheme of how type 1 diabetes presents. And in a sense, what we've got is, as clinicians, we're here at the bottom end of the program, where you've got symptomatic type 1 diabetes. And what you've got is you've got beta cell autoimmunity, because you've got lots of antibodies around. You've got beta cell loss. So in some of the very few studies that have been done, you can show that there's a really significant insulinitis and a loss of beta cell presenting cells. There's hyperglycemia and symptoms are present. And this is called stage 3. And that's the clinical presentation of type 1 diabetes. Stage 2 is the stage earlier, which is where you've got antibodies present and you've got some beta cell loss and you've got a little bit of dysglycemia. I think that's the term which is being used more and more. But basically you've got probably expressed in that, which is that you've got a poor response to an oral glucose tolerance test, but you haven't really got any symptoms. You haven't got the weight loss, you haven't got the ketosis, and the child is very well. So this is what used to be called the prodromal phase, the stage 2 that you get many months. And we know from many studies, sort of like the very old box study in the UK, that this could be going on for not just months, but actually years, which is often quite a shock to parents. And then you've got stage 1, where really, again, no symptoms. You haven't got any suggestion that you've got abnormal glucose levels, but you have got beta cell loss and you have got the developing beta cell autoimmunity. And then there's this curiously labeled stage called pre-stage 1, where in fact you haven't got any of these factors other than some risk factors. And these are very poorly defined at the moment. You've got a family history of diabetes, and you may well have some presence of biomarkers such as the HLA gene system. But in a sense, that pre-stage 1 is one which is poorly defined at the present time. So let's just dissect these at the moment and in a sense go through them as to where these stages, what are the opportunities in these stages for immunotherapy, and what are the difficulties confronting people for immunotherapy. So in pre-stage 1, over here on this stage here, you've got the risk of diabetes. You've got the possible genetic susceptibility. But as I said, there are no antibodies present. you've possibly got first-degree relatives. Now, people quote up to 20%, but it's never any more than that. And I always, at this point, raise the issue that type 2 diabetes is possibly a more genetic linked disease than type 1. And you've got this varying progression to clinical type 1. So one of the points about this is that although you've got the schema at the top with that curve, for some people, this may be a very sharp decline. And for some people, it's a very, very long decline. So that's why you get type 1 diabetes presenting very rapidly in young children with this rapid progression to beta cell apoptosis and destruction, whereas in some people, it goes on for years and years and years. And we have no biomarker which actually predicts that varying progression to clinical type 1. To do any studies in this arena, you have to look at population screening. And as I say, it's difficult to pick these out, but even if you go on to the next stage, which we'll do in a second, population screening is going to pick out a very, very small number of at-risk patients. So there's the whole aspect of setting up population screening. How do you do it? And the costs of doing that, and the simplicity and the efficacy and the effectiveness of that. So we've got a real problem here that in a sense, stage 1 is a difficult stage to work with. The problem is that if theoretically, this is the stage at which immunotherapy is likely to be most successful, because you're going to be hitting the immune process before it's got into that really strong vicious cycle element of production of the antibodies and of the destruction of the cell. And it may be a simplistic thing of removing the antibody, if it is simple, or stopping the antibodies being attacked through the HLA system and the MRC system. So it's a real paradox that the area where we would like to work with is the most difficult to pick out the patients. You move on to stage 1 and stage 2. So here we've got stage 1 where you've got autoimmunity with normal glycemia, and stage 2 is autoimmunity with dysglycemia. You've got positive antibodies in both of them. You've got a high lifetime risk of type 1 diabetes, so it's important to recognize this. So once you get into these 2 stages, your progression to type 1 diabetes is very strong. But as I mentioned in both of them, it's a variable progression. And that's something that has to be taken into account when you look at trial data. You get antigen presentation, T cell activation, plasma cell formation, and pancreatic insulitis, and that leads to the dysglycemia, the inability to handle food properly, and high baseline blood glucoses. So this then raises another question in these 2 groups. What is immunotherapy for? Is it to actually stop the process, or is it aimed to risk to reduce or double the time of diagnosis by 50%? So in other words, are you looking at the absolute stopping of the diabetes or slowing its progression? Finally, you move on to stage 3, which is the clinical side. So here we've got clinical diabetes. We think that the beta cell mass loss is down to about 90% in these cases. Difficult to work that one out, but that's probably about right. And again, are we looking here at preservation of beta cell function and looking at things like C-peptide or possibly other biomarkers of the immune process? And how valuable is this if we do that? Are we aiming for a cure? That's probably unlikely at this stage. Or are we looking at amelioration of the diabetes? In other words, you make diabetes management easier. And finally, we've got to weigh up all of this against the clinical diabetes. Are we looking at prevention versus management? And as Dr. Patini and Dr. Laszlo pointed out, we've got developing very good treatments for clinical diabetes. You optimize the insulin therapy, you put people on continuous glucose monitors, you give them insulin pumps and closed loop systems, and possibly the missing factor to try and get this to work is really large amount of support in all sorts of ways, behavioral, social, etc. So we've got a situation where we've got to weigh up the immune therapy. How effective is it likely to be? What's our gain going to be? And how does it compare with the current sorts of therapy? Just a bit about clinical prevention trials, if you're going to set these up. I think the two difficulties are, first of all, you've got to extract the subjects from a population, and you're looking at small numbers in a very large population. And then you're moving on to clinical diabetes, where there is this high individual variation as to the expression of this immune process. So the rate of progression to clinical onset in prevention, stage and C-peptide loss after onset is very, very variable, and there is no identification of personalized biomarkers. Where are we with the studies? Well, I'd like you to concentrate first on the green box. No study has confirmed long-term reduction in clinical diabetes in phase 3 studies, even if C-peptide preservation was seen in phase 2 studies. And that's what you have to tell families. There's a lot of excitement. There was a lot of excitement originally about oral insulin tolerization, and that has really proved to be, once it moved from the preclinical stage 1 into the stage 2 studies, has really shown no effect. From the point of view of biologicals, I think the one that people have really got excited about recently is Lumzab, the anti-CD3 monoclonal, and it's gone through stages 1. It's been used in stages 1, 2, and 3, only though in phase 1 and 2 studies. Now, there was a big excitement at the end of last year. They got some really exciting data on C-peptide preservation in their studies. But again, it's a phase 2 study, and they have not moved on to phase 3. And there's some discussion about dosing around that at the present time, and where they will take that. It will be set up in the future, but it's going to take a long time to get the answer. And in a sense, although that's exciting, it's delayed the onset of diabetes by a considerable margin, by around 20%, and it's increased the C-peptide preservation. But we will have to be patient and wait for the proper studies to be conducted, and they're going to take a while, because you want to know, if you start somebody off on this, is it going to make any difference? They're also going to try and set up a study on stage 3 patients in relation to this. Whether it will be effective, we don't know, and we'll have to wait and see. The other one that's been around a bit is Diamid and Gad Alum vaccine. Again, that is not really looking very hopeful again as it moves into out of its proof of concept studies. And again, it's only being used in phase 2 patients, not in diabetes onset. Where it might be more interesting, and certain groups are looking at this now, is a combination therapies of different forms of immune therapy, or as Dr. Patni mentioned, combination therapies with biologics and beta cell preservation, such as the IGL-2 inhibitors. So that's really quite interesting, and there'll be some studies out over the next few years coming out of that. Just a point on who's organizing all this. Well, it's got to be through large national and international trials or organizations. And I've just put up a few of them. I'd be interested to know whether India has considered setting these up, given your population size. But you've got TrialNet, you've got the Immune Tolerance Network in the UK. In the USA, you've got Immune Tolerance Consortium in the UK, and you've got Inodia mostly throughout Europe. So these are exciting ventures trying to overcome the difficulties in setting up clinical trials in these various different therapeutics. So phase 3 trials, checkered history, questions the predictive value of animal models of phase 2 study. And I think there's a trend more to combination therapy and adjunct therapy. Immunotherapy, I think probably logistically and logically will be most effective in pre-stage 1 and stage 2. You've got to think about safety, you've got to have national screening programs, and you've got to identify the risk population. So that was a whiz through immune therapy from a clinician's perspective. Thanks for listening. I'd be interested in any comments. Thank you.
Thank you, Dr. Green. It was indeed very, very interesting and intriguing at the same time to understand about the immunotherapy when we talk about diabetes, management and treatment both, and prevention, of course, that's what you were talking about. Maybe once we are done with the last speaker of today's session, we'll take up a little discussion and interaction. Dr. Rupam, can we request you to introduce our next speaker, please?
Yeah, for the next talk, we have Ms. Jess Sethi. She is from Ahmedabad, and she'll be talking about the type 1 diabetic empowerment. So she will talk about how empathy and educating those type 1 diabetic really helps in their diabetes management. There are many things to talk about Jess, but then that information I have, she has been working since a decade with the type 1 diabetic patients, and it has been a great handholding and a lot of educational thing which is going on in type 1 diabetic patients with the help of Jess. So I would like to welcome Jess for her presentation now.
Thank you. Thank you so much. And a big thank you to the entire committee for the invite. It's always a pleasure and an honor to speak at Diabetes India. And yes, today I'm going to be sort of getting in a little bit of a patient perspective when it comes to type 1 diabetes. I am someone who's living with type 1 diabetes. I've been living with it for the past 13 years. And today I'm going to talk a little bit about the work we do around education and empathy and how it really facilitates empowerment for those with the condition. So I'm going to just share my screen. I hope you can see it.
Yes, dear.
Okay, perfect. Right. So yes, like I said, that this is going to be my topic for the day, type 1 diabetes empowerment, how it's mainly about education and of course with a little empathy. So I always like to say that the diagnosis of type 1 diabetes is like a sapling that is withering a storm. So like a little sapling that's growing and it's growing, it doesn't know what's hit it, and it's come in the middle of a storm. And the sapling is sort of bending and it's withering and it might have lost a few leaves. And what does it need to actually start going back into blooming? It requires a little stick to support it back up. It requires some rain and some sunshine, and it requires lots of love and attention. And that is the way that the sapling can actually bloom into a tree. And this is very similar to what we go through when we are diagnosed with type 1 diabetes. And a little bit of my story, right? So I was diagnosed when I was 13 years old. And at diagnosis, there is the feeling of shock and fear, confusion, anger, frustration, loneliness, and denial. And I feel anyone who gets diagnosed with a chronic condition like type 1 diabetes when they're so young goes through this array of emotion. And at this moment, what we really require, this is when that sapling is right in the middle of the storm. And what we require at this moment is honestly for just someone to say, you're going to be okay. But unfortunately, our healthcare system is designed in a way where at this crucial and vulnerable time, we are given a lot of just numbers and doses, and you have to do this and you have to do that, and we're given eventualities and worst case scenarios, and it makes the person living with the condition take a step back and actually be very afraid. So at this moment of diagnosis and in the initial few years, what is very important is education and empathy. And when I say education and empathy, I always try to get the balance between the science and the soul, the science and the sensitivity. And a lot of us were not, unfortunately, given that when we were diagnosed. We were just given a prescriptive list of things that we had to do. And while that was okay, there's a very big difference, I feel, about living with type 1 diabetes and staying alive with type 1 diabetes. And that's what I'm going to sort of, go into. So when I say education, it has to be person-centered. It is not just about the patient. And I always say that we really try and talk about seeing the person behind the patient. So that means that when you're talking about doses, you're also talking about how you can manage your life with those doses. When you're talking about carb counting, you're also talking about, hey, you can actually eat everything when you are a person with type 1. You just need to figure out how to match your carbs with your insulin. So that's what I mean when I say not just staying alive with type 1 diabetes, because the staying alive bit is actually quite easy. It's about taking your insulin on time and monitoring and doing your diet and your carb counting. But living with type 1 diabetes is about how do you try to fit type 1 diabetes into your schedule and not the other way around. It's not about fitting your life into type 1 diabetes. It's about fitting type 1 diabetes into your life. So that's the kind of bit. And a few of the offerings from the Diabetes Foundation, what we work from is really sort of getting into that person-centered bit. So it's about getting very normal comic books out and handbooks that people living with the condition and their caregivers can use and utilize to understand that it's going to be okay and how you can manage this condition in your daily life. When I talk about empathy, there's a lot of work that we do on peer support, because I truly believe that that is very crucial when you're diagnosed with a chronic condition, because when you are diagnosed, it also brings upon a very overwhelming sense of loneliness, that you're often the only one in school injecting, you're often the only one in your dance class who will be taking insulin. So you don't feel it, but it takes a while for you to realize that I'm the odd one out. And peer support really breaks that. It gives you the confidence when suddenly you meet someone just like you. You not only listen to them, you not only learn from them, but you feel like you're not the only one dealing with this condition. And that brings such a huge sense of confidence and such a huge sense of camaraderie. And that also really improves outcomes we've seen. So peer support is such an important thing. And I would recommend and request all the healthcare professionals who are listening to this talk to sort of open up the network for their patients to other patient organizations where they can meet others like them. Language matters. Again, a huge thing that we talk about is because when you're talking about type 1 diabetes, the language you use can actually can sort of help get better outcomes. So when we don't try to use words like non-compliant or non-adherent or a person suffering from diabetes, we try to normalize it. We try to make it seem a lot more supportive and empathetic. So we've done a lot of publications and you guys can check it out. But our offerings, like I said, from Diabetes is the Language Matters document. It's available on the website now. You can see it, and a lot of work on peer support. So if you have any patients and they want to reach out, please sort of let them do. But today, what I really want to speak about is the marriage of both education and empathy when it comes together. One of the projects I want to really speak about is something called Back to Basics. So I truly believe that if you do not know the basics of type 1 diabetes, the fundamentals, you really will not be able to get into all the advanced things that we talk about, like closed loop and artificial pancreas system. The fundamentals are so important, and often those are the ones that are lacking the most. So one of our projects is called B2B, Back to Basics. It's an education and support project by Diabetes. And you can schedule a session with people from our team and get that diabetes management knowledge, counseling, or just a fun chat. So who is in this B2B team? It is healthcare professionals, dietitians, certified diabetes educators, psychologists, caregivers. But the main bit over here is that these are all people who are actually living with the condition. So we started actually in lockdown because we understood that people were getting very anxious about their management. And over the last 2 years, we have scheduled over 750 B2B calls. I want to share a little data from the from the research we have done after the B2B calls and show you a bit of the clinical and quality of life improvements that we've seen post these sessions. So just in general insights, what we could figure out is that lived experience of trainers gives participants hope, courage, and confidence. People thought that there was better suggestions on device management. Participants find it easy to trust trainers as trainers have nothing to gain monetarily from B2B. Many feel that trainers' advices are more practical as they come from experience, and participants felt that they may understand things that a few doctors may not be able to relate to. And many found that they learned practical and technical theoretical things like ISF, ICR, carb counting, injection technique, and things like that from the sessions. So the participant profile is that maximum of our persons with diabetes that schedule these sessions come from low and middle income groups, and around 55% of them were not using any tech as well. You can see the income breakup over here. And their understanding of type 1 diabetes management pre-B2B sessions was, as you can see, over 70% had none to very minimal understanding about type 1 diabetes management. And I want to show you some of the pre and post data. So as you can see that pre-B2B and post-B2B, we got more people into the 6 to 7 HbA1c range. So you could see a cumulative drop in A1C post-B2B session. And it's not rocket science. It's basically because they understood how to manage their condition more. Also frequency of hypers pre and post B2B. People who are experiencing fewer hypers a day post the B2B sessions, again, because they were able to understand how to manage their conditions. So it's very easy to schedule a session for B2B. You just have to WhatsApp B2B to a helpline number. We just get your basic understanding, like, you know, your name, your preferred language, your preferred time slot, and we cross-reference you to a trainer who can help you out, sit with you, talk to you. Topics that are included in B2B are things like diabetes distress, basics, management, things like that. So we also do physical B2Bs that can help really, because I think the basic thing over here is getting somebody to sit with you for hours and talk to you and make you feel heard. So I always want to say that it's a collaborative effort between healthcare professionals and persons with diabetes, right? So we are not doctors. We will never prescribe the insulin. We don't understand that science. You do understand it. And we are never, ever going to compete with you. But what we want to do is assist you, because we understand, as people living with the condition, as patient advocates, we understand that the healthcare system is overburdened, right? So we want to be able to ease that burden. So you prescribe the insulin, you prescribe the science, you take care of the physiology bit, and let us take care of the entire education bit. That way, the person who is diagnosed with the condition gets the best of both worlds. Because I truly believe that it's not either or, it's not either a scientific consult or lived experience. It should be both and. It should be both. You survive and thrive with type 1 diabetes. And as patient advocates and as organizations, we want to be able to support the doctors and healthcare professionals to make it as easy as possible. Because I truly believe that we rise by lifting others. Thank you so much. And I'm happy to take questions as well.
Wonderful and amazing work you're doing over there, Jazz. And let's open the session for a couple of questions. I suppose Dr. Green wanted to ask a question to Dr. Patni in the start. And can we start with there, please?
Well, actually, right, okay. I was going to ask another question.
All right, okay.
Can I ask to Jazz? Fabulous presentation, thank you very much. And also to Barkai. And to Dr. Pathia, in a way. So the frustration is that the new technology is there. Theoretically and in clinical trials, it works much better. There's no doubt about that. But when you put it into the free living person with diabetes, out into the community, it doesn't work as well as we think it should do, and people stop using it and so on. Now, we went through this when we changed to multiple daily injection therapy, and over the period of 15, 20 years of just using multiple injection therapy, people began to realize that what Jazz was saying is actually a key to it. And in fact, it was already there in the DCCT, that if you don't support people with their treatment, they won't get the best of it. And I just wonder, from all of your experiences, both from a personal person with diabetes and so on, is the problem we've got at the moment with diabetes technology, we think the technology is all that you have to do, and we forget about the support side of it. And that's why we're not doing very well with it. I mean, it's an open-ended question and we could go on for years about this, but I just throw it open as that.
Yes.
Yeah, I mean,
sorry. Okay.
Sorry, go ahead.
Okay. The answer is yours, please. Okay, I give you.
Okay, thank you. No, I just want to give a little bit of personal experience over here. So I got onto an insulin pump many years ago, and then I started looping just 2 years ago. The amount of support I got from the looping community was far greater than what I got when I got onto a pump and a CGM earlier on, just because it was the we are not waiting patient movement. So I reached out to a lot of colleagues of mine who were looping as well, and I got a lot of support. And I think my sort of success with looping is far greater than it was just when I was on a pump. So I think what happens, at least over here, and I've seen this time and again, is we give people technology and ask them to figure it out themselves. We teach them just the basics, but having the support of how to integrate that into your life, how to actually work with it, how to troubleshoot with it, is not done enough. So, and I feel like that gives a misconception to people, saying that a pump is a cure, when it's really not, right? So it's about sort of making the most of it. And technology without education just doesn't work. It will not work, and people will have to resort back. So I think it has to be technology with getting people of lived experience to help out, train, mentor, guide, so much so that they can actually integrate it into their lives. That's what I feel, at least. And that's what, with my experience, has also proven to be true.
Yes, I totally agree with these comments, of course, of Stephen's comments and yours also. My personal experience as a medical professional is also the same. As the first step, probably we are failing to pick up properly those patients who are appropriate for the treatment, I think. And if we provide these new technologies for those patients who are not really motivated, who has a lack of education, the environment, socio-economic environment, and so on, family attitudes. So we will not able to get much better results using these pump and CGM as compared to the multiple daily dose insulin. So, and if we do in such a way, we will face with the problem that, okay, the patient is coming back to our office and saying that, hey, doctor, it's not working. The result is not better than previously. So I think this is also a huge barrier, not just the pathophysiology, not just the physiological approach, but these education, as you mentioned, and the motivation of the patients and best pick up, best prediction how these devices are working well. Yeah.
Excellent. Dr. Dhubi, I think we are running already late. So do you have any question in chat box? Or?
There aren't any questions in the chat box, but I think Dr. Green wants to make a comment.
I was just going to ask Dr. Pratik the question I was going to ask him when he was talking. Sorry, very briefly. I mean, yeah, you're right. We've got to think a little broader than insulin, haven't we? In terms of treating diabetes, is there an issue in India, particularly about insulin availability? Is that a problem? or is it something which you feel fairly reasonable about?
I don't think there's a problem right now. There's no more a problem as far as insulin availability is concerned. But I think what is more important, what Dr. Bakai said as well, and what Jess said, basically it is the hands-on or the practicality of education, which is more important. If you really have to use your whatever innovation you wish to use or the tech, it's more the practical aspect which goes into rather than the education background of that individual. I mean, this is what I feel. They may be illiterate, but they will be able to grasp the tech much more easier if the practical approach is there. And I think she is doing a great job, and that's how it should run.
Okay.
Well, we've had a wonderful session, and like Dr. Chaudhary has just suggested that we are a little late and out of our time. Can we have just one closing remark from each of our respectable speakers over here? Can we start with Dr. Patni?
Thank you, Dhruvi, first and foremost. And obviously, as my talk was on adjuvant therapy, and Stephen had given us a great view of the various stages and what therapy can be utilized on those stages. The only problem with the identifying of the stages is not going to help. Even if you identify whether you will be able to supplement the therapy then and there, that will be difficult. So acting fast and acting appropriately will be required. So identifying the pre-stage 1 will be very difficult. I think you will agree, Dr. Stephen.
Thank you, Dr. Patni. Dr. Laszlo, you want to give any remarks, one line or something?
Thank you very much. I was really happy to be here, and I enjoyed all of the speakers, all of the topics, and I learned a lot. Thank you very much. Thanks.
Thank you, Dr. Barkai. Dr. Green?
Well, thanks very much. Yeah, nice to meet people back in India again. Yeah, you sit here for an hour and a half and you start thinking about things, which is quite good. And so I'm beginning to think about different things now, which is really quite nice. And I really enjoyed the talks. Thank you very much. And regards to all the people in India that I know. Thank you. Bye-bye.
Okay. Jazz?
No, thank you so much. It was an honor to be here with such esteemed panelists, and just very big thank you for the invite as well.
Thank you so much. So thank you to my co-chairperson. Thank you to all our esteemed speakers. We really had a wonderful and a very fantastic presentations. Yes, Dr. Green.
One more thank you to the technical people. It's fantastic.
Yes, thank you.
Yeah, wonderful. Well done. Well organized. Fantastic.
Thank you so much. Thank you. We close this session and move over to the next one. And I think we have the next chairperson over here, Dr. Rupal Goklani. I hand over the stage to him.
Thank you, Dr. Dhruvi. So we have co-chairperson, Dr. Abhishek Arun from Lucknow. Are you here? Yes, great.
Yes.
So great, nice meeting you all. And without wasting much time, we'll move forward to our Indo-Italian symposium. And for first of our talk, we have Dr. Massimo Massi Benedetti. He is NATO Fellow at University of Newcastle, UK, a former professor of endocrinology at University of Perugia. He is president of HUB for International Health Research, HIRS, and he is member of National and International Professional and Non-Professional Diabetes Association in manuals. So over to you, Dr. Massimo, for your talk of registries, PROMs, and value-based medicine, the virtuous trio.
Thank you. Can you hear me correctly?
Yes, Doctor.
Okay. So first of all, let me thank the organizing committee for inviting me once again to be here, and in particular to Dr. Francis Sabo. And I would like to dedicate my presentation to my old good friend, the former president of the Diabetes India, Shaukat Sadikot. I have the privilege to be a good friend of him and to share a number of experience. So I just share my screen now. Here we are. Can you see it correctly? Hello? Hello?
No, we can't see your screen, Dr. Massimo.
Sorry.
Yeah, please reshare.
Yeah.
Yes, now it is visible.
Is it okay now?
Great.
Okay.
Yes, perfect. Thank you.
Okay. Now, my approach is referring to the musical, approach that we had in the metabolic environment in the past. We've, the threatening concept of the deadly quartet: diabetes, obesity, hypertension, and dyslipidemia. I mean, which was used, a little bit to threaten, and to stimulate people to be active. I would like to take a more, a different approach, more positive approach, talking about the virtuous trio, which is related to the value-based healthcare, the patient-reported outcome measure PROMS, and to the registries. And altogether, they can make the difference in the life of people with diabetes. So let's start from the first term, from the first component, which is the value-based healthcare. Just starting from a figure which is well known to all of us, which refer to the health expenditure throughout the world. And then there is a progressive increase of the cost, which are likely to undermine even the richest economies. But unfortunately, in most of the cases, this is not producing, the expected outcomes. So the concept of value-based healthcare is, is related to the shift of the focus from the volume of services, and we were used to consider, the quality of care according to the volume of services, to the value created for patient, which means that the fundamental goal and purpose of the healthcare is to improve the value for the involved people, for the patients, and according to an equation which link the health outcomes that matter to patient to the cost of delivering these outcomes. So they are strictly interconnected, and the value is the only goal that can unite the interest of all the system participants and is created in caring for patients' medical condition over the full cycle of care. And we need to be aware that the improvement of the outcome is the most powerful single lever for reducing the cost and improving the value. Then the lack of outcome measurement represents what truly matters most to patients is a global barrier to driving healthcare improvement. So we know that there are problems. The paucity of outcomes data beyond basic mortality measures. Available outcomes are hard to compare and not standardized. Outcomes are often not patient-focused, and there are large focus on process measure. So the result is a lack of information for patients and providers on whether what we do works, slow pace of change and inability to learn from others, and success is not defined from patient perspective, and we have the assumption that changing the processes improve the outcomes for the patient, and this is not always not the case. So there has been an evolution in the concept of delivery of care, and the patient has been put at the center, but not only the patient as a class, but also as an individual. So the patient-centered care and the personalized care, which refer to the needs of each single individual. And the healthcare system is delivering its information and its services to the patient. But this is not sufficient. There is the need for the person at the center to provide information that can be utilized by the system to improve the quality of care. And this information should have the similar and identical value of the information produced by the healthcare system. So there is the need, the patient-reported data, they complement, they do not of course substitute the physical, physiological, and biochemical data to improve patient care. And if they complement, they need to be defined as outcomes, which is any report of the status of a patient health condition that comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. So in order to have a value, they have to be measured. So this is the measurement, the prompts. And to measure, there is a number of issues to be taken in consideration. So there are instruments, scale, or single item to measure, which used to assess the PROCOMs as perceived by the patient, obtained by asking directly the patient to self-report. Definitely, there is the need for clearly defined methods and instruction for the administration for responding, and the standard format for data collection, and well-documented methods for scoring, analyzing, and interpret the results in the target patient population. So the prompts support patients to raise issues with clinicians. Completion prompts patients to engage in self-reflection, enables them to identify what is important to them, and develop a deeper understanding of how their condition has affected their life. So it's a number of positive effects of this, but also there are positive effects in the areas of the clinicians. They raise clinician awareness of patient problems, systematic and comprehensive assessment of patient perception of their symptoms, functioning, or of their health-related quality of life, led clinician to patient problems, and prompt discussion and subsequent care processes. So this is, there are positive aspects, and actually it's not easy to implement, these new methodologies, and there are facilitating, need to be aware there are facilitating factors, choosing prompts that clinicians feel are relevant to their patients, clinician receiving feedback on their patient score, organization providing sufficient training and support to staff on using prompts. So there are a number of facilitating effects, but on the other hand, there are some barriers. Clinicians believing they do not have the capacity to use them, clinicians perceiving their practice is being judged on changes in prompt score, organizations not having the resources to utilize prompts, and organization not incorporating prompts into existing workflow. So there is the need to structure the implementation of prompts, and this through a structured process. So we have to take into consideration the patient perspective, the provider perspective, and the perspective to collect this information, the registry perspective. So there is the need for a comprehensive set of potential outcomes, and these outcomes need to be prioritized according to relevance to patients. Of course, we cannot have all of them, and they need to have a minimum set of outcomes in order to define measures in terms of feasibility, validity, and reliability. So at the end of the story, we need to have a standard set of outcomes with the related measures. And this is, the activity that has been, promoted by the International Consortium for Health Outcome Measurement that was formed to promote the adoption of value-based healthcare. The ICHOM is non-profit organization which has been funded in 2012 through the Institute for Strategy and Competitiveness at the Harvard Business School, the Boston Consulting Group, and the Karolinska Institute, with the mission to unlock the potential of value-based healthcare by defining global standard sets of outcome measures that matter most to patients across a wide range of medical conditions and driving the adoption and reporting of these measures worldwide. So it's taking care of the upper part of the equation. So the ISO standard set provide a universal approach to the collection, putting together professional and expert and patient representative, considering a number, considering that the outcomes defined around the medical condition are focused on outcomes that matter to patients with the direct involvement of the patients, and the patient-reported outcomes are part of every standard set. So they become hard indicators at the same level, with the same ranking of those we are used to, and a minimum, but they need to be, considered as a minimum initial condition risk factors, facilitate a meaningful comparison, and also with the time points and sources to ensure comparability. So this has been done for a number of conditions, and diabetes in particular. And in terms of diabetes, the standard set has been defined, taking in consideration patient-reported outcomes for psychological well-being, diabetes distress and depression, together with other more conventional indicators for acute events, chronic complications, survival, the utilization and availability of health services, and of course, diabetes control. This has been defined by an international working group of 28 members of different extraction from 19 countries, including also people with diabetes. And the validation has been done through the formal structured involvement of the worldwide community. I have the privilege to be the chair of this group. So, and there are three categories of data: the patient-reported outcomes, provider-reported outcomes, in case it's variable. Patient-reported outcomes such as, for example, well-being and distress, patient-provider-reported outcomes related to hemoglobin, and case mix, those variables that are difficult or cannot be changed, such as age, and also an algorithm for the follow-up. This has been recently published, and with all the items, and of course with the related source. So they can be provided by healthcare professionals, by the carers, and also by the people with diabetes. And this journey towards the value-based healthcare and diabetes, the strategic. So there is the need to define standards, to measure outcomes, to benchmark the outcomes, collaborate to improve the value, establish outcomes transparency, develop value-based payment models, and the target is the value-based healthcare. Of course, you need, in particular for diabetes, the standard set for type 1 and type 2 diabetes. And this is something, so we need to collect the information. This registry, they feed, the registry. We need big data, and we need to be aware there are different registries for different targets: research, epidemiology, administrative projects, and in our case, for quality of care improvement, to serve, different beneficiaries, people with diabetes, or any disease, policymakers, healthcare provision makers, administrator, professional, research industry, and the general population. So but we need to be careful to have a couple of assumptions. Registries as a standalone activity have little value, if any, and the condition for successful implementation of registry is that the full integration in the process of healthcare delivery and the long-term maintenance secured if we improve the quality of healthcare. So there is, there are structure, the ideal structure for a diabetes register. They should be population-based, using multiple data sources, linked by a unique person identified to compile all agreed indicators. This is the argument which has been defined by the UBIO project, a EU-funded project. And in a nutshell, I would like to mention which are the main characteristics for the registry for diabetes care improvement. Each of these items should deserve a symposium per se. So they should be open source, able to evolve with the evolution of needs and technology, with no commercial exploitation, database resident in the international institutional setting, able to collect information from databases of different nature, automatic download of already existing data, and this allows for reducing the cost for maintenance. The privacy need to be taken into consideration and should be by design, legally compatible with cross-border with exchange, inbuilt statistical engine in order to provide timely information, adjustable for different specific purposes, real-time processing of information, consistency of information at local, national, and international level, customization of outcome according to various constituencies, and public domain web-based real-time availability of information. So the concept of registries has been evolved, and from a list of people for epidemiological purposes has been evolved into real-time backbone for healthcare delivery, meta-level instrument to time adjust policy and action to the benefit of specific patient population and according to real-life evidence. But there are also caveats. There is the trade-off between individual society benefit and privacy. So I would like then to give a couple of examples on how the integration of the three terms have already produced good results. This is the Scottish Care Information System, which gather information from different sources of different nature, and from the patient-reported data, mobile, wearable, home monitoring, and also prompts, and provide education on e-learning and provide education on diabetes. This has already produced significant improvement in outcomes and on quality of life of people with diabetes. The second example is the data-driven diabetes care system that is based on register. And we can see that the register is at the center of the system for quality assurance, risk stratification, personalized care, and patient empowerment, and linked to different sources, and has an input from professional, non-professional, and administrators, and deliver the care. So through this system has been already demonstrated that there has been a quite relevant statistical improvement of the quality of care that has been delivered in a number of sectors. And so we have to be aware that the outcome measurement drives valuable improvements for all stakeholders and activate, and these are the basis of the quality circle with feedback and learning, analysis of the variation, identifying the current best practices and change behavior. So starting from transparent, high quality outcome data, inclusive of those produced by the people, to generate value. And this value is not just for the people, the involved people, but also for clinicians, for hospital, payers, and life science. Thank you for your attention.
That was really wonderful talk, Dr. Mercy. And if we have any question, we can discuss it right now. If we have any question. Yeah, Dr. Amalia has a question. Yes, please go ahead.
Congratulations, Dr. Massi. This is very interesting, and this is a very hot topic right now. I was wondering if what is your opinion on also the awareness of the patient with diabetes of also all new comorbidities. We know that also not only the patient, but also the primary care physician, because sometimes they neglect what is also related to diabetes. Right now, there is a lot of attention, for example, of cognitive impairment related to diabetes, the fatty liver that I will talk later, osteoporosis. Usually these things are just associated with age, but we know now that there is an increased risk in diabetic patients and also to the treatment of some patients. And since some of the treatment are also associated with the improvement or the generation of some of the comorbidities, I think that will be very important in the future to integrate the information not only for the patients, but also for the physician. And the patient also, they search in the literature, sometimes they get the wrong information. So I think this will become very important in the future.
Yes, this is extremely relevant. And definitely in this case, it is the care of these comorbidities in a number of cases is neglected. So we tend to act into compartments, separate compartments. But the person with the condition is living all different clinical conditions, and they can refer through their the evaluation of their opinion on the outcome, which is related to diabetes, but not necessarily. They can produce, when you ask a person, how do you feel? And this should be the first question that when we are visiting a person, we should ask. They respond not only about diabetes. I feel, they do feel all of them on their skin, I would say. So, to have this type of information for the prompts, they can help very much in being aware of other conditions that in a number of cases they are
video on.
Thank you.
Thank you, ma'am.
So we have next speaker, Dr. Amalia Gesta-Delhi. For her, I'd hand over to Dr. Abhishek Arun.
Yeah, Dr. Amalia is a research director at the Cardiometabolic Risk Laboratory at the Institute of the Clinical Physiology of CNR of Pisa, Italy. And she received in 2014 the National Habilitation of Full Professor in Endocrinology and for the Associate Professor in Bioengineering. She has already more than 20 years of experience in leading national and international scientific projects. She is also collaborating with many institutions in Europe and US, and she is recently recognized amongst the top Italian women scientists of biomedical sciences. In 2011, she initiated and is currently the chair of ESD and NFLD study group. She is also a member of EASL and ESD EASO committee for the clinical practice guidelines for the management of NAFLD. And since 2013, she's the director of the European chapter of American College of Nutrition. She's published more than 200 articles in the national journals and a book chapters with global listed index with more than 14,000 citations. And she is also associate editor of the Journal of American College of Nutrition and reviewer for more than 25 international peer-reviewed journals. So over to you, ma'am.
Thank you very much for the kind introduction, and I'd like to thank also the organizer and Dr. Sabo for the invitation to be here. It's always a pleasure for me. So today I will talk of the impact of pancreas and liver crosstalk on insulin glucose metabolism, diabetes, and non-alcoholic fatty liver disease. And these are my disclosure. So we know that diabetes, it's really an important disease, and also that it's not that the prevalence and the incidence is not stopping. Actually, it's increasing, and we expect an increase into the, let me see if I can put the marker, the laser pointer, here it is. So we will have an increase, expected increase of 51%. Due to many reasons, the type of diet, sedentarity, but also we have genetic predisposition. It's also important that in the Asian country where the increase is expected to be 74%, so much higher than the average world increase. And also it's important because it's associated to obesity and also to other metabolic diseases like a non-alcoholic fatty liver disease that we were talking about just a few minutes ago. So NAFLD, the fatty liver disease that is starting with accumulation of fat in the liver, is now the most prevalent metabolic disease because the prevalence is 1 into 4 person in the general population. And you can see here there are continents where it's even higher, like in South America or in the Middle East. And NAFLD, it's important also because it's associated with a 2.2-fold increased risk of developing diabetes. And the prevalence of NAFLD in diabetes is doubled compared to the general population, so it's 55%. And the global prevalence of non-alcoholic steatohepatitis, that is already in a progression of a disease, it's about 37%. So 1 into 3 person subject with type 2 diabetes will have not only fatty liver, but also the steatohepatitis with fibrosis that could be advanced to cirrhosis in 17%. So this is also important because this disease is completely asymptomatic. So when we are talking before with Professor Massi Benedetti that the first things to ask a patient is, how do you feel? They cannot feel NAFLD. Usually, you know, the most reported feeling is fatigue. So it's something that is not even considered symptoms. And the prediction in 2045 will be that 388 million of subjects will have NAFLD and diabetes, and 261 million will have a NASH and diabetes. So I wanted here to go through the natural history of type 2 diabetes and showing you how it is related to fatty liver disease. So we know that insulin resistant is the major characteristic of a subject with diabetes, and there is a decline in sensitivity and development of insulin resistance, but it's actually diabetes and hyperglycemia develops only when our pancreas and the beta cells cannot secrete enough insulin to overcome this insulin resistance. So the hyperglycemia develops only when the pancreas that starts secreting more insulin, that at a certain point becomes exhausted and the amount of insulin goes down. And at the end, you really need also insulin as a treatment in order to treat hyperglycemia. And the liver plays a central role in the maintaining glucose and lipid homeostasis because not only the liver is the major organ that is also produce endogenous glucose and is producing gluconeogenesis and is also producing lipoproteins. So it's important also for our vessel and the comorbidity of diabetes. And the lipids are mainly, the lipids that are coming to the liver either from the meal or from the lipolysis, they are coming to the liver, they are made as a triglyceride, reesterified to triglyceride, as triglycerides are exported as a lipoprotein, initially as VLDL, and then the VLDL becomes LDL, and then we have finally the HDL to go back with the cholesterol. But when this amount of fat is too much, the triglyceride cannot be exported and the liver becomes steatotic. And from steatosis, we go to inflammation and eventually to the scars, that is the fibrosis, and the activation of extra cells that are not only hepatocytes in the liver, but there are also Kupffer cell hepatic stellate cells that are involved with inflammation and in fibrosis. So now, NAFLD is associated, as we said, with a 2.2-fold increase. So the progression of NAFLD is also, how is this associated with the progression of the risk of diabetes? As I told you, starting with steatosis, is going to steatosis, inflammation, and that is NASH. And then after NASH, we have a starting or during NASH, and there is initiation of a fibrosis. That is a mechanism that is sort of a repair mechanism. And we know also the insulin, the excess insulin that is so common in insulin resistant state and is also metabolized by the liver. It's also a pro-collagen synthesis. So it's also increasing the process of fibrosis. That could, at the beginning, could be a good mechanism, but then when it's becoming too much and there is a progression to different levels, the liver can even become cirrhotic, and this is very bad because it's a higher risk of hepatocellular carcinoma, and right now NAFLD is the major cause for liver transplantation. But we have good news, because the remission of type 2 diabetes is also associated with the decrease of fat in liver and pancreas, because also pancreas can accumulate fat. But this is only if the beta cell can be recovered. That means that if the beta cells are still active, then by diet, in this case, this is the famous study from a direct study that was led by Roy Taylor in Newcastle, when you have a decrease in beta cell in the liver, in fat and pancreatic fat due to the diet hypocaloric, then you can have a recovery and even a remission of diabetes. So diabetes, as I said, it's a balance between insulin secretion and insulin action. And this is measured as a disposition index. So as the subject was becoming more insulin resistant, so we go on this side, there is a higher need for insulin secretion. But then, as I said before, when there is not enough insulin secreted, the subject from normal glucose tolerance becomes in IGT, impaired glucose tolerance, or diabetic. So is NASH risk for type 2 diabetes due to the reduced beta cell function? Because we know that NASH is an NAFLD associated with insulin resistance. So this was the first question that we asked ourselves, and I will show you some of the data that we have published. So we use the oral glucose tolerance test, because the oral glucose tolerance test with the measurement of not only glucose, but also insulin and C-peptide allow us to measure the glucose excursion and indexes for insulin sensitivity, that is mainly muscle, and also insulin secretion, and calculate this disposition index. So first I wanted to show you some data in a subject with biopsy-proven NASH, where they are all non-diabetic, but this is important because when we divided the subject according to the level of steatosis, these are the 3 levels of steatosis, steatosis 1 and 2, and the most severe 3. And we also divided the subject among those with a BMI below 30 or above 30. We observed that it was very unexpected, actually, that the curves were really superimposable regarding the glucose excursion. And these were, as I said, all non-diabetic, only few of them, they had the IGT. But the insulin was much higher. The lowest one was the non-obese with the lower steatosis, and that are the less insulin resistant, and all the other one had a high insulin. Then we did, So then we did the same subject, where instead divided according to the level of fibrosis and obesity. So those with low fibrosis less than 2, so fibrosis 0 and 1, they had a lower glucose excursion compared to those with higher fibrosis. But the curves were really very similar as when the subject were, these are the same subject, are not different subjects. So you see here that having fibrosis is associated with a higher glucose excursion. It was very, very unexpected, because why scars in the liver should be, but not steatosis, should be associated with an increased glucose excursion. So we went on and we look at the the insulin response, measuring the increase, the relative increase in insulin to glucose. And we saw no difference among the groups, 0-1 of fibrosis or fibrosis 2 that is intermediate to this one that is pre-cirrhosis and cirrhosis, fibrosis 3 and 4. But then we found that this subject with higher fibrosis had a reduced OGS, that is the index of peripheral insulin sensitivity. So actually, this is all explained by muscle insulin resistance. So those with high fibrosis, they also have muscle insulin resistance. So is something related to this or not? So we look, if OGS or insulin sensitivity and secretion, where also we could find these things about the fibrosis also in other liver disease. And we look also subject with the hepatitis C virus with genotype 3 that is associated with steatosis as well, or hepatitis or genotype 1 and 2 versus NAFLD. And you see all these subjects where not really obese, they were of course overweight. And as expected, the one on NAFLD were a little bit higher weight and a higher BMI. But look at the curve here. So these are the normal glucose tolerance without liver disease and with insulin sensitivity. And all the subjects with chronic hepatitis C, insulin resistance without liver disease or NAFLD, they have similar glucose, but actually those with the NAFLD have a much higher insulin levels. And while the other one had a very similar insulin levels. So when we look at the OGS and the insulin secretion response, so this is insulin sensitivity and this is the insulin response, we found that the insulin sensitivity was much lower than the reference group that is the yellow one in those with NAFLD, was very similar or a little bit higher in one with hepatitis C. So the hepatitis C did not have insulin resistance. So having liver disease doesn't mean having insulin resistance, but having NAFLD is associated to insulin resistance. But those with hepatitis C, they had a reduced insulin response, while the one with NAFLD tended to have higher insulin response than the NGT. So the disposition index show that the NAFLD, so that is also the risk of type 2 diabetes, was not diminished, but was actually increased in those that remain normal glucose tolerance. And there was decrease only when they were becoming IGT. Instead, in insulin resistance without liver disease or the chronic hepatitis C, there was already a reduction in the disposition index. And here you can see it by looking at the hyperbolic curve that actually compared to the NGT sensitive that are here, the NGT NAFLD, they are actually on a better condition according to the disposition index compared to the reference group. So impaired beta cell function increase insulin resistance favored, we know, the development of hyperglycemia, but NAFLD per se is not associated always with a decreased disposition index, because you can see here the results. But when we look at the fibrosis, and so we look at the chronic hepatitis C and the NAFLD, you can see that insulin sensitivity was similar in, and actually much higher in chronic hepatitis C, and tending instead, again, also in this group, to be lower with the high fibrosis. And also with a decrease in NAS score that is the sum of inflammation, ballooning, and the steatosis. And the insulin response was instead, as I show you here, that was not also associated to the liver fibrosis in none of the group. So liver fibrosis, we know, is important because it's the most important predictor for liver-related mortality. But actually, we cannot say that, but we also have to say that it is also probably associated, is a marker, if not a determinant of type 2 diabetes. So in the liver pancreas crosstalk, another important part is that the liver is also the site that is clearing the great part of the insulin that is secreted by the pancreas in the portal vein. So on the first pass, we know that there is 60 to 70% insulin degradation. Then the insulin goes in the hepatic vein, it is going back to the circulation to go to the different organs, and then is recirculating back to the hepatic artery. So in total, we can say that the liver is the organ that mainly metabolizes insulin by not only internalizing and activating the receptors, but also by degrading it because it's more than enough the amount of insulin that is secreted by the pancreas. And the disruption in this also in the liver pancreas crosstalk is a major risk factor for type 2 diabetes. So here we can say that the insulin clearance from the epidemiology, and we can see here with the NAFLD and diagnosis and progression, insulin clearance is decreasing much in a lower rate compared to insulin sensitivity, but is also contributing to the fasting hyperglycemia. So how do we measure insulin clearance? We measure it using some the C-peptide and some modeling. I'm not going to go into this, but what we found is that the insulin clearance was inversely associated with insulin resistance in the adipose tissue, in the liver, and in the muscle, and much more with the liver in the muscle than in the liver or in the adipose tissue. And another important thing is how insulin secretion and clearance is modulated during the response to an OGTT. So, for example, here you see the non-obese subject. In black, they are the NGT. In square is the IGT, and triangle, they are the type 2 diabetes. You see that in response to the OGTT, you have an increase in insulin secretion because, of course, there is an increase in glucose. You need to decrease the glucose, and the glucose is much higher in the IGT that requires more insulin, while the diabetic have a defect in the secretion. The obese, they secrete more insulin because they are more insulin resistant. So you see here that they have a higher insulin secretion, but again, the diabetic have a reduced and impaired insulin secretion. The insulin concentration are therefore similar to the insulin secretion that are derived from C-peptide, while this one is a measurement post-liver. But the question is, how is the clearance? So how is this is pre-hepatic insulin secretion. So this is the effect of the post-hepatic insulin secretion. We want to look how is the clearance of the liver. So how the liver is behaving. Sorry, I did something up here. So this is the insulin clearance, and this is the hepatic insulin extraction. So you see that the diabetic, they did not change their clearance, so there is no effect, while the NGT and IGT, they reduce the clearance. That means that this is despite a higher insulin extraction, but this is allowing more insulin to go to the periphery, because it's like the liver is opening the gate to let more insulin, less insulin percent of insulin into the liver and more insulin into the periphery. So how is insulin secretion and clearance in NAFLD? We know that patients with NAFLD have higher insulin, and this is because of high insulin secretion and reduced insulin clearance. I'll show you the results. These are some of the data presented by, published by the group of Professor Klein, that show that the lean NAFLD had an hepatic extraction of 70% considering the amount of insulin that from the pancreas is secreted. The obese NAFLD, they have a similar hepatic extraction, but of course it is much more because there is more insulin here. And the lean non-NAFLD, these are the obese non-NAFLD, and these are the obese NAFLD. The obese NAFLD have a reduced clearance, so they have much more insulin in the periphery because not only they secrete more insulin, but also they clear less. So this is why they have a more increase. And also they also have a saturation of the hepatic extraction. So we wanted to show the progression, and we studied 340 subjects that had liver biopsy. And so we had not only the different degrees of tolerance, but also different degrees of liver fibrosis and NASH. And we wanted to look if there was the abnormalities. And here are the curves. Probably you are more familiar with the curve that with the biopsy. So you can see here the NGT, they had no NAFL in blue and NASH in red. They have the similar glucose excursion, although the NAFL and NASH had a little bit higher glucose and higher insulin. Same things for the IGT, and all the IGT had a higher glucose as expected than the NGT. And in the type 2 diabetes, the NASH had the much higher glucose excursion, and also but the insulin in this case was reduced, but not as much as in the other group I showed you before. So when we look at the insulin concentration, also regarding the NASH with different fibrosis, you see here that the insulin concentration in each group are much higher in those that they have a NASH fibrosis 2-4. So this is quite interesting. Also, the pre-hepatic insulin rate was also much higher. And the insulin clearance instead is much lower. So look at this. As we expected, there was a decrease in insulin clearance, but this was in this group of subjects with biopsy-proven NAFL or NASH. The decrease in mean insulin clearance during the OGTT was more related to the amount of fat in the liver and to severity of liver disease than to the real glucose tolerance, because you see NGT, AGT, and type 2 diabetes without NAFL, they have a similar clearance, and they have similar mean insulin that is much lower, and they have a similar insulin secretion rate. Of course, you know, when you become diabetic, you have also much likely is there more subject with NAFL and NASH than in the other group. But this is very striking, because this means that the liver disease in diabetes has been neglected, and instead it's important not only because of the liver disease of the fat metabolism, but also for the glucose and insulin metabolism. And when we look at the clearance with
Dr. Amalia, sorry to interrupt, but we have, yes, great, thank you.
I'm finishing, this is the last slide. So you see here again that there is a decrease in clearance with NASH fibrosis, and also the OGS, that is the insulin sensitivity, is much lower in those with fibrosis, as well as the disposition index that goes down from NGT to IGT to diabetes, but much more in the NASH with the fibrosis. So in conclusion, the liver fibrosis stage is not only the most important predictor of liver-related mortality, but also associated with a worse metabolic profile, even at mild stage. And with this, I'm concluding also because insulin is probably acting also not only hepatocyte, but also on the Kupffer and hepatic stellate cells. And I think these are the next challenges for the next years. So I'd like to acknowledge our sponsors and the grants at the European Union. Thank you very much for your attention.
Thank you, ma'am.
Excellent deliberation, wonderful. So if time permits, we'll have discussion later, but we'll have next talk right now. So we have next speaker, Dr. Samar Banerjee. We'll be talking on thin fat Indian sarcopenia, a typical Asian Indian phenotype. Dr. Professor Samar Banerjee is Professor, Department of Medicine and Specialist Diabetes Clinic at Vivekananda Institute of Medical Science, Kolkata. He's past president of RSSDI DIPSI, Indian Society of Hypertension. He's president, Association of Clinical Diabetology, editor-in-chief for Diabetes, a Journal of Clinical Diabetology, author of 9 books on diabetes. He is one of the experts in diabetes with super specialization in GDM. He has glorious tenure in Neel Ratna Sarkar Medical College, Kolkata. He is rendering praiseworthy experience to medical students in Vivekananda Institute of Medical Science. He is one of the founder member of Diabetes in Pregnancy Study Group India, that is DIPSI. He held a nose of prestigious positions like Chairman of Association of Physicians of India and most recently the President of RSSDI. Over to you, sir.
Please allow me to share the screen. Please allow me to share the screen.
Yes, sir. I'm asking. Yeah.
Share your screen, sir.
They are showing you cannot start screen share.
Sir, there is a below the green button. Press the button.
That I have done, but they are showing that you are not allowed. That is okay.
Yes.
Okay, I'm trying.
Do it on presentation mode, sir.
Is it okay?
Yes, sir. Yes, you can go.
Is it okay?
Yes, it is visible properly. Thank you, and you are audible as well.
Okay. Thanks to the organ, I am going to discuss some points on thin fat Indians, sarcopenia, a typical Asian Indian phenotype. I just like to place before you that there is a complex interplay between the genetic and environmental factors contributing to increased visceral adiposity, and that is determined by the genetic foundation, the culture, the exercise habit, the diet, the lifestyle, and the evolutionary history, and all determines the nature of the subcutaneous fat and visceral fat. You have just listened to my previous speaker on the fat. This is a very important and very commonly seen picture. This is Yukin, very famous diabetologist from Germany, and this is our beloved Yagnik from Pune. Both of them had 22.3 BMI, but the body fat in Yukin, German, is 9.1%, and for Yagnik is 21.2. So I just like to place before you that Indian are considered as obese lean persons because of their high intra-abdominal fat. As the risk of sarcopenia increases with type 2 diabetes patient, older adults with sarcopenia may have also an increased risk of developing type 2. In Korea, individuals with the lowest skeletal muscle mass relative to body weight quartiles had a twofold greater risk of developing type 2 compared with individuals in the highest title. One data has shown association of modules of co-expressed lipodystrophy gene with diabetes-related intermediate phenotype traits that suggest their role in pathophysiology of diabetes. So lipodystrophy and diabetes are interrelated. There is genetic and environmental factors contributing to visceral adiposity in Asian population also. What is sarcopenia? Age-related decline in muscle mass and function. From 35 onwards, everyone is having sarcopenia, but diabetes are more responsible for both a cause and consequence of type 2. Type 2 is manifested by insulin resistance, increased advanced glycation end products, increased pro-inflammatory phenotype, and oxidative stress, and may lead to micro and macrovascular complications. All these changes can interfere with normal cellular functioning and cause cell death, leading to losses in skeletal muscle mass, strength and function, and finally the development of sarcopenia. Again, low muscle mass and function due to sarcopenia can lead to poorer glucose disposal and decreased metabolic rate and physical activity, all of which may play roles. Older adults with sarcopenia at increased risk for developing type 2 diabetes. What is the incidence? 10 to 40% in healthy men and women aged 60, whether diabetic, they are all non-diabetic. Older type 2, increased risk of sarcopenia. In Japanese, Chinese adult, older people, type 2, 15% had sarcopenia. In type 2, threefold higher odds of having low skeletal mass. Health ABC study with older women with type 2 diabetes, greater losses in thigh muscle over 5 years compared with non-diabetic. Sarcopenia, this is an Indian study where 12.5% in male diabetics, and 5.4% in female diabetics in Bangalore. The English longitudinal study of aging involved 3,404 older adults and demonstrated that diabetes predicted low hand gift rate, which is a marker for sarcopenia, 8 years later than in men, but not in women. And this is a very important picture which shows that how it occurs. With aging and obesity, there is low metabolic rate, low physical activity, low sexual hormones, and this leads to visceral and ectopic fat accumulation, which all leads to insulin resistance. So there is adipocyte hypertrophy, hyperplasia, accumulation of immune system, and there is also mitochondrial dysfunction, increased oxidative stress, and anabolic action of IGF-1 on the muscle. All these lead to a sarcopenic obesity. And there are the molecule cellular different aspects. The sedentary behavior, the decrease in motor units number, immunosenescence, immune alteration, I'll come later on, increased inflammation, mitochondrial dysfunction, and malnutrition. And as a chronic disease, they all lead to this sarcopenia. And the vicious cycle goes on. The decreased physical activity, inflammation and oxidative stress, diminished myostatin, which are concerned with the muscle activity, insulin resistance or hormonal change, that all lead to either sarcopenia and obesity or both together. And obesity can lead to sarcopenia, and sarcopenia can lead to obesity also. And finally, resulting in manifestations of dyslipidemia, type 2 diabetes, cardiovascular disease, hypertension, and frailty. Sarcopenia can lead to clinical and functional complications. What are they? Impaired ability to perform daily activities. So there may be mobility disorders, poor quality of life, malnutrition, increased risk of falls, and finally lead to increased risk of mortality. These are the different complications: reduced pulmonary reserve, impaired pulmonary vasodilation, vascular recruitment, ventilation, perfusion, mismatch. There are chances of developing of the peripheral vascular dysfunction, anemia, iron deficiency, obesity, poor nutritional status, impaired autonomic regulation. There are cardiac problems like systolic dysfunction, functional mitral regurgitation, ventricular diastolic dysfunction, left atrial dysfunction, chronotropic incompetence, and ventricular arterial uncoupling. There is different structural abnormality, autonomic changes, and finally skeletal muscle dysfunction. There is an interplay between the diabetes and sarcopenia mechanism, as because the skeletal muscle accounts for 80% of the glucose clearance during euglycemic and hyperinsulinic condition. Deficit in muscle mass may lead to the metabolic abnormality because glucose absorption during hyperglycemia and disposal during hypoglycemia is much less. Type 2 diabetes in turn may lead to vicious pathological sarco, and that is because of insulin resistance, inflammation, oxidative stress, advanced glycation end products, and vascular complication. The effect of blood glucose regulation on sarcopenia parameters in obese and diabetic patients was studied by Ojutik et al. And they have shown in a patient with mean duration of diabetes for more than 16.2 years, in the better control group blood sugar, sarcopenia parameters such as gait speed, muscle mass, and hand grip strength improved. However, only the change in the muscle mass was found to be statistically significant, but no significant change in the parameters of sarcopenia in the patient group with higher A1C more than 8. That means better blood sugar control found between the muscle mass and A1C. This study demonstrated that lower A1C report has got positive effects on muscle mass even in diabetic and sarcopenic obesity. Insulin resistance may lead to impaired vasodilatation of the vessel, increased oxidative stress, chronic inflammation, and all leading to higher concentration of NEFA, vasoconstrictor, cellular adhesion molecules, and other mediators. While sarcopenia negatively affects insulin sensitivity and increases insulin resistance, this resistance aggravates sarcopenia by increasing the loss of skeletal muscle. The different factors I will discuss one by one. Insulin resistance, MRO study, men more than 65 years without type 2, but in the high quartile for insulin resistance, at twofold higher odds of losing more than 5% of total lean mass over the approximately 5 years. Nahan study, gait speed was seen to be decreased across increased quartiles of insulin resistance in non-diabetics, older but not in women. In one study, 968 elderly Italian insulin resistance was negatively associated with hand grip strength and normalized to BMI in women but not in men. These observations reveal that insulin resistance is a predictor of poor muscle health irrespective of diabetic status. Glycemic condition in older Korean more than 65, poor glycemic control was correlated with poor lower limb muscle quality and performance. Baltimore longitudinal study of aging, knee extensor strength was seen to be lower across increasing quartiles of A1C. That means more and more A1C higher, poor and poorer knee extensor strength. Patient cannot walk properly, cannot stand up from the floor. Probably the loss of muscle strength and mass in individuals with poor glycemic control likely occurs due to increased protein degradation. Inflammation, low-grade chronic inflammation is present in type 2, and that also acts on the muscle homeostasis. The waist circumference, which indicates the interleukin 6 and TNF alpha activity, is negatively associated with muscle strength, quality, and performance. But it is not clear whether these negative associations are driven in part by increased inflammation. But interleukin 6 is also produced by myocytes during exercise, and transient increase in IL-6 help in nutrient mobilization and muscle hypertrophy. Opposite to this, IL-6 causes muscle atrophy localized to the tibial anterior in rats regardless of systemic inflammation. Framingham heart study demonstrated that IL-6 predicted 2-year lean mass loss in women. So the issue about the IL-6 is doubtful whether it is damaging or improving. Park et al. Documented that older adults with type 2 had greater losses in leg muscle mass and strength over 3 years compared to non-diabetic control, and these associations were related to interleukin 6 and TNF alpha values. Other than negative association with muscle mass, inflammatory markers are also negatively associated with muscle strength. Visser et al. Reported that hand grip strength was 1.1 and 2.4 kg lower with increase of interleukin 6. TNF alpha also is negatively associated with grip strength, and other studies has also shown relation of the CRP and other inflammatory markers to be related to sarcopenia. Patients with type 2 diabetes and sarcopenia had higher mortality irrespective of age, sex, and diabetes, and the effects of sarcopenia on overall survival was larger in those with lower adapted diabetes complications severity index in male patient, younger diabetics, female, and older with diabetes. Obesity, multi-parametric MRI reveals significantly elevated liver fat hyperinflammation in participants with type 2 despite normal liver biochemistry, and this corroborates with the significantly lower measures of skeletal muscle and hair fibers. So this indicates sarcopenia is associated with also non-alcoholic fatty liver disease. Oxidative stress is another important factor associated with type 2 diabetes, and both in development of sarcopenia, and study has shown poor lower limb muscle quality and physical performance with increased oxidative stress. In 107 pre and post-menopausal women, increased oxidative state was associated with skeletal muscle index adjusted for height, and oxidative also impairs satellite cell differentiation, damaged DNA, so muscle production is hampered. Mitochondrial dysfunction is another factor. Older individuals appear to have up to 50% lower oxidative capacity because of mitochondrial dysfunction, and you know that higher advanced glycation end products means more and more chances of the muscle loss, and this is proved in different study also. Advanced glycation end product associated muscle weakness arises through increased protein cross-linking within the muscle. This interferes with contractility and also increasing inflammation and oxidative stress. And studies with skin autofluorescence has proved higher advanced glycation index in end products are associated with lower muscle mass. Microvascular complication, very important, is neuropathy. They impair muscle contractility, resulting in poor muscle strength and muscle. And neuropathy had lower knee extension strength relative to body weight, and has shown that poor peripheral nerve function was independently associated with poor physical performance outcome. Type 2 diabetes also had poorer physical performance when compared with controls in patients who had neuropathy. Interestingly, retinopathy, probably as a part of the microvascular involvement, and which also indicates microangiopathy in muscle, are also associated in different studies. Presence of advanced retinopathy with presence of sarcopenia also. Diabetic nephropathy, type 2 diabetes, diabetic nephropathy had 2.5-fold higher incidence of sarcopenia. Sarcopenia increases with severity of CKD. In CKD patient not on dialysis, GFR was positively associated with the lean mass. So lower GFR, lower lean mass, lower appendicular skeletal muscle and appendicular lean mass also. Sarcopenia and obesity showed a synergistic impact on the increased risk of albuminuria also. And the pathophysiology behind the relation of sarcopenia and CKD, increased inflammation, protein loss, reduced vitamin D, mitochondrial dysfunction, and metabolic acidosis arising from CKD. Macrovascular, it is probable that hypertension can damage myocyte, but this loss of muscle also can lead to hypertension. And study in cases of DB rights has shown that reduced systolic and diastolic blood pressure and mean arterial pressure, regardless of adiposity and body weight. The positive effects of blood pressure were thought to be due to improve renal function resulting from metabolic improvement. Peripheral artery disease associated with lower hip extension and knee flexion strength in older and older adults had slower gait speed and reduced blood flow from peripheral artery disease leads to ischemia and muscle loss. Out of the hormonal changes, reduced androgen and estrogen decreases muscle mass and strength, and decreased IGF-1 is associated with muscle growth, impairment, and low muscle mass in healthy people in patients with type 2. Intramuscular adiposity and type 2, these are details I'm not going. The IMAT consists of non-contractile tissue, and the fat infiltration into the skeletal muscle affects the elastic property of the skeletal muscle. So even the muscle bulk is there, it do not work properly. Relation with the cardiovascular outcome, sarcopenic obesity is associated with increased cardiovascular disease. In the British Regional Heart Study, sarcopenic obesity showed a significantly higher risk of mortality compared to non-sarcopenic obese person, non-obese person with cardiovascular outcome. And a meta-analysis has shown 24% increase in risk of all-cause mortality compared to patients in sarcopenia out of cardiovascular disease. Beta cell function, sarcopenia was an independent risk factor contributing to the development of diabetes in an elderly person. An elderly onset diabetic patient show more preserved beta cell function, but nevertheless were insulin resistant and development of the sarcopenia. Now I am going to the commonly used glucose lowering medication, how they are helping or damaging. Out of the commonly used glucose lowering medicine, some improve muscle bulk and some damage. Metformin stimulates AMPK activity, which inhibits the mechanistic type of rapamycin or mTOR activity, and which is a key growth factor of muscle. Assists in mobilization of M2 macrophages, which could have anti-inflammatory properties in skeletal muscle. Profound effects on skeletal muscle through activation of AMPK, like improvements in structural integrity, oxidative metabolism, resiliency to muscle damage, and macrophage polarization. It enhances mitochondrial respiration in skeletal muscle of AMPK deficient mice after just 2 weeks of treatment. Gait speed is improved by metformin. This is most likely due to administration of metformin may improve insulin resistance and the suppression of the advanced glycation products, and also suppression of inflammation. So for all probabilities, metformin is improving the sarcopenia. Pioglitazone improves energy metabolism of the muscle cells and reduces the intramyocellular lipid content, improve fatty acid metabolism in polycystic ovary, increases mitochondrial biogenesis and ribosomal protein biogenesis in skeletal muscle, improves the effect of resistance training on muscle. MRO study revealed that men with diabetes treated metformin alone and metformin plus azolidine for 7 years, followed 3.5 years. Follow-up had an attenuated loss of total lean mass and acute lean mass, and this shows that pioglitazone and metformin sensitizers are better for sarcopenia. DPP-4 inhibitor results are consistent with the hypothesis that DPP-4 inhibitor use might have a positive effect on the loss of muscle mass and its function. GLP-1 analog, liraglutide, induces loss of fat and increased skeletal muscle. However, one study reported a significant fat mass loss and also skeletal muscle. SGLT inhibitor, different studies have shown in the long term, they not only lower the intramuscular fat, but they may lower the muscle mass also. But one study has shown that it improved the hand grip strength in both women and men treated with SGLT for 10 years. Sulfonylurea can cause muscle atrophy in a very small proportion of cases, and this skeletal muscle by reducing the protein content in the muscle in mice as follows: ripaglinide, more than glibenclamide, more than glimepiride, more than tolbutamide, and nataglimide. So out of the sulfonylurea, glimepiride is safer, and in vitro data indicate that sulfonylurea, particularly glibenclamide glinides, should be used with extreme caution in presence of the sarcopenia. Insulin, there is an alteration in the response of muscle anabolism to the insulin. Insulin possesses anabolic effect on the muscle and protein metabolism, improve muscle bulk, and is a growth factor for the muscle. Insulin increases collagen synthesis. And Timmerman showed that endothelial dependent vasodilatation and the consequent increase in nutritive flow and the mammalian target of mTOR activity are all improved. So for all probability, insulin will help in sarcopenia. Is there any specific therapy? The answer is no. Transdermal testosterone gel has been tried. In some cases, produces virilizing activity. For that reason, selective androgen receptor modulators that only bind with androgen receptors with the skeletal muscle has a lower virilizing effect are more acceptable. Many treatments under clinical trials are recommended, like activin type 2B receptor antagonist and myostatin blockers. Actually, myostatin negatively regulates myogenesis. The RAS blockers, by suppressing the NF-kappa beta activation and by inhibiting the inflammatory markers, they also improve the sarcopenic state, and by improving the cardiac output and hemodynamic parameters and endothelial function, they also improve muscle blood supply and metabolism. Physical activity always better, and it shows that greatest reduction is A1C are observed with individuals undertaking combined resistance and aerobic exercise. So this is recommended. Resistance training in the most effective strategy, and combined resistance and aerobic training led to 21% improvement in physical performance. And this is the most predominant, highly acceptable resistance and combined aerobic training. Protein intake, it should be higher, 1.2 to 1.6 kg. And they have shown, the health obesity study has shown improvement in cases of muscle bulk. Animal protein is better than plant protein in terms of sarcopenia requirement. Protein-rich diet, 1.3 grams per day achieved through lean red meat was safe and effective. Long-term excess leucine may help for prevention of treatment of sarcopenia. Vitamin D supplementation is helpful when vitamin D level is below 30.
Dr. Samar,
Yes,
sorry to interrupt, but we are
just
running out of time. Please finish it.
Omega-3 fatty acid is also of some help. In the conclusion, I like to place that aging and diabetes are both risk factors for functional impairment from sarcopenia. Between type 2 and sarcopenia, as one condition may increase the risk of developing the other. Several factors like insulin resistance, inflammation, advanced glycation end products, increased oxidative stress, vascular complications, all are present in diabetes. They act on the sarcopenia. Exercise remains the primary and most effective treatment, particularly combined with aerobic and anaerobic. Resistance exercise are much better. We need further research to better understand, treat, and prevent comorbid sarcopenia and type 2 diabetes. I am ready to declare that the sarcopenia object is very much neglected in cases of diabetes that are the causes of increased mortality and morbidity. We also need early detection of sarcopenia and frailty in older adults with diabetes as a routine clinical practice to facilitate early multimodal infection. So I thank all the listeners for listening to this. And this chapter is coming in my upcoming book, which will be released in June, available in Amazon, on neurodiabetes. Thank you for your patient hearing, and thank you for giving me the chance. Thank you again.
Thank you very much, Dr. Sama Banerjee, for wonderful deliberation. And as we are running short of time, we'll take just one take-home message or concluding remarks. So from each. First, with Dr. Amelia.
Yes, I'd like to thank you for the invitation. I think it's been a very interesting session, and even if we went a little bit too long, and it was a pleasure for me to be here again, and I wish you the best for the rest of the Congress.
Great, thank you, thank you. Do we have Dr. Masi? I guess he's...
Yeah.
You can have your concluding remarks. Yeah.
It has been a pleasure, as usual, to attend the Diabetes India meeting, and I look forward for the next editions.
Thank you, Dr. Masi. Dr. Sama Banerjee.
I just missed to interact with all the delegates, but my message for the topic is the sarcopenia is very much a neglected topic, but it is producing so many complications. Every diabetologist should take care of assessing the sarcopenia and ask the patient for the muscle weakness. Take care. Thank you.
Thank you, sir. Yeah. And for next session, over to the chairpersons, Dr. Vipul and Dr. Dishank. Over to you.
Thank you so much, Dr. Rutul. It was indeed wonderful session. Now let's move to our dia talk from America session. And for that, there are two chairpersons, one myself, Dr. Vipul Chawda from RIMS Ahmedabad, and my co-chair is Dr. Dishank Patel, MD from Vadodara, from Glucowell Diabetic Center. So as we are running short of time, let's straightforward start our first talk, and our first speaker is none other than Dr. Narsingh Verma sir, who actually requires no introduction because he is a teacher and mentor for many doctors, including me. He's a MBBS, MD, FACP, FRCP from London as well as Edinburgh, FIMSA, FAMS, FICN, FIACM, and a fellow RSSDI. He is fellow of Diabetes India, professor and head of Department of Physiology, officiating head and Department of Family Medicine, former head Department of Transfusion Medicine, and Dean of Student Welfare, KGMU, Lucknow. His area of interest is chronobiology and metabolic disease. He has more than 225 original publications in peer-reviewed index journal and award. He has 14 international and 38 national awards in the field of cardiovascular as well as metabolic disease. He is a life member of 14 international and 29 national scientific bodies, and he holds a very much prestigious position in various scientific bodies. So without wasting much time, let's start sir's talk. And sir is physically present here as well as he has given his recorded talk. So I will request RX team to start Dr. Narsingh Verma sir's talk. And if sir want to say something before the talk, we can have sir on air. Please start the talk.
First of all, I would like to thank the organizers of Diabetes India for inviting me and giving me this very important topic, that is understanding pathophysiology of glucagon in diabetes. And I would like to thank especially Dr. Bansi Sabu for giving me this opportunity to talk about the topic, which is very, very important and pertinent. I will be talking about glucagon. So first, in early 1920s, the Kimball and John Merlin identified pancreatic extracts, and he found that it is responsible for blood sugar increase rather than increase. And later on, it was termed as glucagon. Glucagon is a 29 amino acid peptide hormone, and it is a counter to insulin and stimulated hepatic glucose production. And also it increases plasma glucose level by both mechanisms, that is glycogenolysis and neoglucogenesis. Glucagon also stimulates ketogenesis, thus working in tandem with insulin to maintain a normal fuel balance. That is why probably nowadays we are talking more about glucagon because of this particular action. Insulin, we know, acts as a glucose depositing and anabolic hormone, and counter to that, glucagon is a glucose mobilizing and catabolic hormone if we compare with the insulin. Most important thing is that we know that beta cells are responsible for secretion of insulin and amylin, while the alpha cells are responsible for secretion of glucagon. We also know that at the time of birth, the beta cells are more in number, around 60% of this total cell of islet of Langerhans are beta cell, and the rest are, most of them are alpha cell, and very few belong to other varieties. So this insulin-glucagon ratio becomes very important because we know that both alpha and beta cells are formed by same precursor. That is why today's concept is that probably alpha and beta cell have same progenitor cell, so the alpha cell and beta cell are interconvertible. Insulin-glucagon molar ratio is more important rather than the beta and alpha cell ratio, because it is the ratio in plasma, it is more important than the individual concentration. So it may not be that important that how much insulin one is having and how much glucagon is having. Probably it is the ratio of insulin and glucagon is more important. Normally the Ig ratio, which is called as insulin-glucagon ratio, following a balanced diet is approximately 3, meaning by that 3 is insulin and 1 is the glucagon. So following overnight fasting, it decreases to 1. So in normal person without any disease, the Ig ratio keeps on changing. It varies from 3 to 1. So after diet, it is maximum 3, and in fasting condition, it is 1. When person goes to prolonged fasting, more than 24 hours, or even more than that, the ratio may be as low as 0.4, because in that condition, hardly any insulin is secreted, only basal secretion of insulin is there, and glucagon keeps on increasing. Following glucose infusion, the ratio may rise up to 30. When glucose is given, then that stimulates insulin secretion, and this Ig ratio goes up to 30. In diabetes, inappropriate Ig ratio influences metabolic status. So, in other terms, in diabetes, we should also focus the Ig ratio, which is a very important factor. What is happening by glucagon? Glucagon secreted by the pro-glucagon molecule as a pro-hormone like the insulin, and it is converted into glucagon by pro-hormone convertase 2. And this pro-hormone convertase 2 is rarely deficient, so it is easily converting the glucagon into pro-glucagon into glucagon. By portal circulation, like the insulin, glucagon reaches to the liver first, and first receiving organ is the liver, similar to insulin. And this in liver, it produces glycogenolysis, gluconeogenesis, fatty acid oxidation, and ketogenesis. These are the 4 important functions glucagon produces in the liver. And their order is also same. That is, first action is glycogenolysis. And we know that the liver glycogen, whichever store is there, is depleted within 12 to 15 hours, and now no glycogen is left in the liver. We also know that the muscle glycogen is only for that particular muscle, while the liver glycogen is for whole of the body. And this glycogenolysis produces more glucose, that is hepatic output of glucose. When glycogen stores are depleted, then gluconeogenesis starts, and fatty acid oxidation and ketogenesis follows. Epinephrine and other counter-regulatory hormones provide gluconeogenic precursors like lactate, amino acids, glycerol to liver for raising blood sugar. So they do have their function, but they will provide the gluconeogenic precursors like lactate, amino acid, glycerol, etc. But the main function is done by glucagon. So factors which regulate glucagon secretion are so many, and the secretion of glucagon is increased by hypoglycemia, and the carbohydrate and meal stress decreases the glucagon secretion. Protein meal increases glucagon secretion, while isoleucine decreases glucagon secretion. Most of the amino acids increase glucagon secretion, while non-esterified fatty acids decrease the glucagon secretion. Some fatty acids may also increase it, but ketones definitely decrease glucagon secretion. Parasympathetic nerves, when the parasympathetic stimulation is there, the glucagon secretion will be more, while the gamma-aminobutyric acid, GABA decreases glucagon secretion. Sympathetic nerves also increase glucagon secretion, while the ATPs decrease glucagon secretion. Whenever there are more ATPs already present, then the glucagon will be decreased. The pituitary adrenal cycloactivating polypeptide, this increases glucagon secretion, but the zinc decreases glucagon secretion. Cold exposure have been seen to increase glucagon secretion. So glucagon will be more in temperate countries in relation to tropical countries. Hormones which have the impact on glucagon secretion, the adrenaline or epinephrine increases glucagon secretion, and cholecystokinin increases glucagon secretion, gastrin-releasing peptide, ghrelin, GIP, oxytocin, vasoactive intestinal peptide, and vasopressin, they all increase glucagon secretion. And amylin, glucagon-like peptide, GLP-1, insulin, leptin, secretin, and somatostatin, they all decrease glucagon secretion. So this was the hormonal actions, various hormones which have action on the glucagon secretion. What is the mechanism of action of glucagon? Glucagon acts by the glucagon receptor, and you see the glucagon receptor serpentile structure, and this receptor, when the glucagon combines with this receptor, a lot of activities take place. And this is regulated by inositol and triphosphate INSP3 pathway, and that increases calcium ions, and that again is responsible for glycolysis, glycogenesis, gluconeogenesis, and increasing glucose. This is also potentiated by lot of activities, and again it is by adenyl cyclase CMP pathway, and inside cytoplasm it increases the pKa, and that increases PGC1 and the G6 phase, and it's responsible for most of the action of glucagon, which are glycolysis, glycogenolysis, and the gluconeogenesis. The glycolysis and glycogenesis is decreased, while the glycogenolysis and gluconeogenesis increases. So that is responsible for hepatic output of glucose. This is the pancreatic islet structure, which facilitate pancreatic signaling. Because this structure is unique, you see exocrine pancreatic glands are outside, and they are acinar cells, and they secrete pancreatic juice, and they have no role in the endocrine role, and they are exocrine process. But we know that endo-exo connection do exist, and endocrine functions are affected by exocrine functions, and vice versa. The alpha cells, you say they are lined, related close to exocrine pancreas, and you see beta cells are little inner inside, delta cells are also inside, and you see that F cells are also there. So what happened that the various hormones, which are secreted by the same cell, they do have the action on the same cell, and we know this is called an autocrine effect. And when the beta cell secretes something, and which is having action on alpha cell, this is called as paracrine effect. So both paracrine and autocrine effects are responsible, meaning by that the release of glucagon has action on the alpha cell and vice versa. Similarly, the beta cell release, that is the release of the insulin and amylin, will have impact on the release of glucagon, and vice versa. That is, glucagon release will have impact on the amylin and insulin secretion. So we know that these paracrine, autocrine, neurocrine, endocrine, exocrine effects are responsible for most of the action which we see in a tandem manner. Centrifugal pattern of blood flow in pancreatic islet to facilitate paracrine regulation of blood glucose. This is possible by centrifugal pattern. Blood enters from center and drains outwards. So this blood flow pattern allows secreted hormones to regulate other cells within the islet. This is possible by centrifugal pattern. You see here the regulation of blood glucose by insulin and glucagon in a healthy individual is possible. That is in hyperglycemic condition. Pancreatic cells, beta cell release insulin, and these insulin stimulate glucose uptake by cells, and they also produce glycogen synthesis in liver. And in the liver and the other cells, including the fat cells, the plasma glucose return to normal levels because the muscles now can utilize glucose. The adipose tissue can synthesize more fat, and the glucose can synthesize more glycogen in presence of insulin. So blood glucose returns to normal. And then what happens in the fasting condition, or when the person is developing hypoglycemia, then alpha cell secretes glucagon, and this glucagon produces glycogenolysis, and it also inhibits the glucolysis, and the neoglucogenesis do occur, and that maintains plasma blood glucose to normal level, and this is the action of the glucagon. Alpha cell glucagon secretion dependent on beta cell insulin secretion that I have already talked about, and pathophysiology type 1 and advanced type 2 diabetes happens that when there is no insulin, so glucagon increases, and when even insulin is there, then the glucagon increases. This is the special thing, and even after the fasting condition, glucagon secretion should go out, but even in prandial condition, glucagon continues to increase, and glucagon increase is one pathophysiology which is central in pathophysiologies of type 2 diabetes. We know that in type 2 diabetes, the more pathophysiologies are known, but this one pathophysiology which is part and parcel of the ominous octet that has shown that increased glucagon level is a very important pathophysiology. The aberrant secretion of glucagon resulting in elevated glucagon concentration in both the fasting state and after meal are important. In altered alpha to beta cell ratio may be a contributing factor in type 2 diabetes pathogenesis. The relative hyperglucogonemia of diabetes resulting from an altered alpha to beta cell ratio might be a consequence of beta cell dedifferentiation to glucagon producing islet cell, which I talked earlier that both cells are from same progenitor cell, and due to that more alpha cells are being formed, and that is evident that after 10 years of type 2 diabetes, the alpha cell increase in the number and the beta cell goes down, and the condition reverse. Now 60% of the islet of Langerhans are alpha cell and only 40% beta cell. Glucagon also plays a role in lipid metabolism, influencing food intake, affects body weight, promotes autophagy, and has pleiotropic effect on the cardiovascular system. We know because of these pleiotropic effects, the glucagon is being discussed during these days, and we know that it has impact on lipid metabolism, food intake, and body weight. The high insulin, when we talk about insulin-glucagon interaction, the high insulin-glucagon ratio promotes biosynthesis of proteins, inhibits glucose production, and reduces the release of free fatty acids. So, a low insulin-glucagon ratio helps the body access stored nutrients, increase hepatic glucose production from glycogen and amino acids, and promotes the breakdown of adipose tissue into free fatty acid and glycerol. It is called as the physiological fulcrum. This insulin-glucagon interaction is called as a physiological fulcrum, balancing the two opposite ends of the metabolic spectrum to conserve energy if possible, but provide it when needed. So both are required. Sometimes we need that energy should be conserved, and sometimes we need that energy should be provided. So that is possible only by flipping off the switch and making the insulin-glucagon interaction in a different ways. Now I will talk about effect of various drugs on the glucagon levels. You see, we are using a lot of OHAs in the type 2 diabetes management, and metformin also acts by inhibition of glucagon, induced stimulation of gluconeogenesis. So one of the action of metformin is by inhibiting glucagon, which we are achieving by GLP-1. So the combination of GLP-1 RA drugs with metformin can be a synergistic combination because both will have synergism. Metformin also acts to antagonize glucagon by affecting the cyclic exogenous insulin and was shown to decrease plasma glucagon levels in the patient with type 2 diabetes. So it was seen that metformin has two actions which are in favor with the management of type 2 diabetes involving glucagon. Exogenous insulin was shown to decrease plasma glucagon levels in patients with type 2 diabetes. So that is why the exogenous insulin is somehow helpful in decreasing the plasma glucagon levels. Sulfonylurea and pioglitazone have not been shown having any potential effect on glucagon levels. Experimentally, few studies have shown, but finally, we have not found enough studies which can claim that glucagon levels are affected by sulfonylurea and pioglitazone. Amylin mimetic decrease postprandial glucagon levels. We don't have these drugs in my country, but those drugs which countries are having this drug did decrease postprandial glucagon levels, similar having the paracrine effect. The GLP-1RA DB4 inhibitors decrease postprandial glucagon levels, thus increase insulin glucagon ratio, and that is why they are helpful and in the management of type 2 diabetes. SGLT2 inhibitors produce increased fasting glucagon and postprandial glucagon levels and decrease insulin glucagon ratio. That is one thing which is being discussed with SGLT2 inhibitors, and that is why when we combine SGLT2 inhibitors with DB4 inhibitors, then we say that probably this action is negated by DB4 inhibitors. Glucagon in hypoglycemia and hyperglycemia in diabetes. Type 1 and advanced type 2 diabetes mellitus, there is beta cell failure, and that is responsible for absolute endogenous insulin deficiency. And when there is absolute endogenous insulin deficiency, abnormal glucagon secretion is involved in pathogenesis of both hypoglycemia and hyperglycemia in diabetes. So glucagon behaves differently when insulin is available and when it is not available. Relevance of glucagon to hyperglycemia in diabetes finally leading to DKA. Insulin deficiency, infections like pneumonia, UTI, cellulitis, inflammations like pancreatitis, cholecystitis, intoxications like alcohol, cocaine, infarctions, acute MI, CVA, iatrogenic corticosteroid surgery. These 6 I are responsible to produce these conditions, and where the demand of insulin increases, and here the glucagon becomes very important and in the prevalence of the DKA. The role of insulin and a counter-regulatory hormone like glucagon in pathogenesis of DKA. When insulin is decreased, free fatty acids rise, acetyl coenzyme may rise, ketone bodies rise, and these ketone bodies we know glucose is also increased. They produce hyperkalemia, hyperosmolar condition, and acidosis. And the ketone bodies are responsible for at least 2 symptoms. They are vomiting and kusumal breathing, which is pathognomy of DKA. Another story coming there is increased stress levels, and when the simple nervous system is not responding to that, and catecholamine levels and glucagon rise, and the glycogenolysis occurs, gluconeogenesis from amino acid, lactic acid, glycerol, and increased glucose levels are seen, and the osmotic diuresis is there, and that is producing dehydration. So all the 3 dehydration, ketone bodies rise, hyperkalemia, hyperosmolar condition, acidosis are explained by this interaction of glucagon insulin. So when glucose level goes down, the pancreatic islets, beta cell failure, there's decreased insulin, and alpha cell secrete more glucagon, and the glucagon is more, and it prevents hypoglycemia. So in conclusion, we can say that glucagon dysregulation contributes substantially to the pathophysiology of diabetes, and utilizing hypoglycemic therapies which target glucagon can help improve glycemic control. Certain agents currently used to treat diabetes may exert some of their hypoglycemic effects by restraining glucagon secretion or inhibiting glucagon action. For example, mechanism of metformin may involve inhibiting glucagon signaling in hepatocytes, whereas GLP-1 receptor agonists and DPP-4 inhibitors have been shown to reduce glucagon excursions in patients with diabetes. Optimizing diabetes therapy in the future will require skill targeting of alpha cell dysfunction balanced with insulin replacement therapy. So that will be the crux of knowing glucagon better. Thank you. Thank you very much. These were my references. Thank you. Thank you. Thank you very much.
It was indeed interesting as well as a useful talk, sir, and we always learn something from you. Insulin is a main thing in the management and pathophysiology of diabetes, but glucagon is equally important, and we have to look into the pathophysiology of glucagon to understand the pathophysiology and acute and chronic complications of diabetics. Thank you so much, sir. Sir, would you like to make any comment right now?
I think you have already said that it is the high time that we should be not only targeting the beta cell, we should also think about alpha cell. And it is the synergistic effect of beta and alpha cell, which is responsible for normal glucose and lipid metabolism. That is why newer and newer therapies are targeting alpha cell function as well.
Thank you, sir. So now I would like Dr. Disang to introduce our next speaker.
Thank you very much, Dr. Vipul. So with this wonderful lecture, now I am inviting our next speaker, Dr. Adi Mehta. He is a faculty and he is attending staff of Endocrine and Metabolic Institute, Cleveland Clinic from 1993 to present. He is also Associate Professor of Department of Endocrinology and Internal Medicine since 1982 to 1993. And he is a member of American Association of Clinical Endocrinologists, the Endocrine Society, and the American Diabetic Association. With this short introduction, I would like to invite Dr. Adi Mehta for his session. He is going to speak on halting the progression of chronic kidney disease, a myth or reality.
Alex team, we have recorded video, or sir is going to present?
No, sir, it's a live session.
Okay. Dr. Mehta, sir, you are not visible as well as audible. There is some technical glitch, I guess. Can we have any contact with him from RX team?
Yes, sir. So I messaged to. Yeah. Okay.
Yeah, he is no.
I think he is there.
Yes, sir.
Hello. Dr. Adi Mehta. Am I audible to you? I think he's not.
Yeah, he is not responding. There is some
Yeah.
technical or internet glitch there. So until he gets his connection, can we move to the next talk? Because Dr. Sen is also here.
Yeah. RX team, can you confirm? Can we move to our next talk?
Okay, sir.
Okay, so
Please give the introductory
of
slide of Mr. Sen.
Yeah.
Yeah, Dr. Desang, please introduce.
Thank you. So because of the technical glitch from Dr. Adi Mehta, now we are moving ahead toward the next session taken by Dr. Sabyasachi Sen. He is the professor of medicine from the George Washington University with a demonstrated history of working in the higher education industry. He is skilled in the clinical research, medical education. He has a strong professional graduated from the Royal College of Physicians in UK and Ireland. He is basically graduated from the India, and after that he has moved to UK, and he is certified by the RCP London as MRCP, and he has also many awards and fellowship in his name. He is also the fellowship of endocrinology from 2005 to 2009. He is also the faculty of Tufts University assistant professor in 2013. So with this brief introduction, I think I would like to invite Dr. Sabyasachi Sen. He is going to speak on precision medicine, a hype or hope.
Thank you. I hope all of you can hear me.
Yes, sir. You are clearly visible and audible.
Awesome. Let me try to share my slides. Okay. You can see my slide, I hope, right?
Yeah, it's visible, sir. You can go ahead.
Okay. So thank you for inviting me to give this talk. I know my introduction slide looked very busy, but basically I'm a professor at George Washington University in Washington, DC, and I work on stem cells and precision medicine in diabetes. So without further ado, so essentially we are going to talk about how we can use a prediction model for clinical decision making using gut microbiome. So precision medicine is essentially when a person, for example, is fairly new, but for an example, a person, let's say, needs a blood transfusion and he is trying to match the blood type to the recipient to reduce the risk of complications. So in other words, how can we predict a transfusion that is not going to go wrong and just catered to an individual person, and what would work best for that particular person? And right now, our medicine is not so-called geared towards an individual person. It's based on large data sets, which does not always preclude to a singular person and their disease, mortality, and morbidity. So essentially, the prime components of precision medicine right now is how does lifestyle and environment influence a person's disease. So that's why it's important as a so-called preventive medicine step. So the goals of precision medicine are to predict, prevent, and treat a disease. And it's actually very important for a metabolic disease, which, as you know, goes on for a significant period of time and then manifests at a later stage. For example, diabetes is we call the iceberg phenomena, right? So precision medicine is an emerging approach to a disease treatment, including various components such as the genes, environment, and lifestyle of each person. So it actually is beyond what we call just genes or epigenetics. It also includes lifestyle and, for example, diet, exercise, etc. So here is a schema which talks about how we integrate all these different information pieces. So we have information inflow coming from direct volunteers, and then we integrate their data into a data set, right? And then we upload it to a cloud with the identification taken out. And we try to get all the data from different biological samples in order to also have influence from the clinicians and then get an output from the information flow out. Now, I know this is not very clear right now, but let me explain a bit more. So the various data sources at the moment we have is a self-reported measures such as diet, activity, so on. Then you have the vitals that you would get done in a physician's office. And then comes the so-called coding of various diseases that a person has. So that, and that's why coding for a particular disease is so very important. And now every healthcare system in the United States would insist about appropriate coding, because that's how you build a data set. Then comes the so-called different biospecimens, for example, blood, fat, stem cells from blood and fat, and ultimately stool microbiome, right? So you have to, if you think about it, you have to identify which is your primary outcome and where do you put your most of your statistical prediction on. So if you talk about genes, epigenetics or environment, and one's lifestyle, this stool microbiome almost involves all these components or has a reflection from all these components. So this has been talked about precision medicine way back in our meeting at diabetes or ADA in 2020, when it was talked about as precision diagnostics. In other words, taking into epidemiological evaluation, probability, and diagnostic testing. So precision diagnostics is number 1 point. I'm just introducing some terms right now. Then comes the precision therapeutics. In other words, you take into account what interventions can you possibly do. Let's say prediabetes, which, as you know, in the United States, we have 80 million people with prediabetes, and I'm sure, which is about 1/4 of the population. And I'm sure the statistics won't be that different in India either. So you have various therapeutic interventions, starting from lifestyle to therapy. And then you have prognostics, which includes various complications of the disease, such as cerebrovascular retinopathy, cardiovascular, and so on. So you have to actually integrate, as you have been listening to different talks, that what medications work for different complications. And clearly, there's not a singular answer to that. In certain conditions, such as nephropathy, SGLT2 may be better. In cardiovascular, you might have a GLP-1 working better, but how do you integrate one person's lifestyle, food items, to all of these interventions? So as you can imagine, it's a huge data set that we have to integrate to individualize and decide what medication would work for that particular person. So the path to precision diabetes medication involves a lot of data collection and integration. And then ideally, it should have a format where a clinician can input these data and get a science-based prediction. Right now, as a clinician, when all of us sit in front of a patient, it's based on certain parameters of large-scale clinical trials, which may not have anything to do with that particular person sitting in front of you. So we need so it almost becomes an eeny, meeny, miny, mo business. So instead of that, you need some form of science, and that's what the precision medicine or prediction medicine is trying to do, to individualize therapy. So here comes the gut microbiome. Why do we think gut microbiome may be a novel diagnostic tool towards precision medicine? Because the gut microbiome essentially is a collection of various organisms in the ecosystem, right? It's a collection of genes in the microbiomes and influences from the environment, meaning influence from the diet, from the lifestyle, and so on. So it has certain components, particularly metagenomics, which is the genomics part of the microbiome. To that, you can add so-called metabolomics, which you can get from the, let's say, serum, right? So essentially, you are trying to integrate metagenomics, transcriptomics, and metabolomics. I know these words are bombastic, but let's kind of bring it down to so-called genomics from a stool flora, metabolomics from serum, and you're trying to integrate all of this along with the history of the patient. So the gut microbiome, environment and host interaction is actually important, and we have recognized this several decades back. But the microbiome is the primary filter for a large environmental exposure such as food, right? So essentially, we are what we eat. It's the largest endocrine organ, which is the gut, and possibly the most efficient metabolic machinery. It generates various useful metabolites, also toxic products, which are detoxified by the bacteria in a physiological state. So it's in a constant flux. In fact, it's every day that that flux or the biome changes based on what you have done or what you're about to eat. So the gut microbiome and the health, it integrates, it controls the digestive function, it generates the metabolic products, degrades dietary oxalates, and so on and so forth. And of course, it has an influence on your drug metabolism. So all of these, if you think about it, is way more individualized than what you can get from serum or urine per se. So this was actually recognized by our predecessors in medicine way back before Christ, that the death sits in the bowels and bad digestion is the root of all evils. So it's essentially revisiting what we knew for 2000 years. Qualitative and quantitative changes in the gut flora and its distribution could change, and gut dysbiosis is actually important topic. So why dysbiosis in metabolic disease? It has an influence on the gut from various components. I'm not going to talk of individually all of this, but I think all of you know most of this to begin with. So let's talk about very basic topics, for example, that is already in textbooks right now. So some of the endocrinologists in the United States have certified in so-called obesity medicine. As you know, this is primarily a diet-based issue along with lifestyle. So this is almost part and parcel of that course, which means if you have a higher ratio of firmicutes to bacteroides, your chance of getting cardiovascular disease is way higher. So this is something we know. And this took us several years to consolidate this data, right? So how can we build on very simple data that we have here to better prediction to, let's say, a particular diet, such as Mediterranean diet, ketogenic diet, and so on and so forth. We also know about from 10 years back that various items, for example, red meat, carnitine, etc., promotes atherosclerosis. Now, this wasn't actually linked to firmicutes and bacteroides, but it actually was linked to certain flora within the gut, right? Then we also have so-called microbiome therapy, where we can treat a specific microbiome and restore the dysfunction. So, such as prebiotics are non-digestible food items that are used to restore a particular flora, which can subsequently change your metabolism. And then we have so-called microbiome engineering, where you have a signal transduction from an environment, signal, then you propagate that, and you can engineer a specific microbiome to improve your metabolic health per se. So let's come to our study, what we are trying to do, because I don't want to take you too further into microbiome, which is a whole different topic itself. I'm sure somebody has covered it in these sessions. But what we are trying to do is to try to identify what lifestyle would work for veterans. So this is a US federal government mandated study. We have, as you know, a significant amount of patients, 88 million Americans have prediabetes. And how can we predict whether a certain food item, for example, low-calorie ketogenic diet, can change the gut microbiome, and is it even worthwhile for certain number of people? So what we plan to do is to use a machine learning database application and to discern signals from the gut microbiome, utilizing gut genomics, serum metabolomics, and even urine microbiomes and urine flora. And we are going to target primarily A1C of 5.7 to 6.4, because diabetes prevention program and other studies have shown that lifestyle changes do help. But obviously not everybody. And that's why we are trying to individualize who would benefit. And as you can imagine, when a patient walks in with prediabetes, we often tell them go and do lifestyle intervention. But that means they have lost 2 years of their life in this process. And then the next time they come to you, if they haven't responded, they're full-fledged diabetic or very close to it. So you have actually lost not only time, but their precious health. And this goes on and on. It doesn't just stop from prediabetes to diabetes. It goes on even when they have diabetes. So our secondary objective is to corroborate all these data from gut microbiome along with other studies that we know have been shown to have strong biomarkers such as serum-based, serum endothelial inflammatory markers, appetite controlling hormones, renal function, and so on. So as you can imagine, all these are linked, but we have not yet developed a database which is primarily based on prediabetes subjects. And our study hypothesis essentially is to use the gut microbiome and the metadata used from this study with a short intervention of 3 months to see what changes in a short ketogenic intervention, diet intervention. Now, ketogenic diet is actually interesting in the sense that within 1 month, it can change the gut microbiome. So 3 months actually is quite enough to show those changes. So we are going to put it in a database that we have developed along with the federal government. This has several $1 billion have gone into it. And our aim is to ultimately apply this predict mode machine for clinical use. And our projected time is about 3 years down the road. So we have a clinician like me with a lab along with bioinformatics, which is also from one of my colleagues at GW, who is Dr. Mazumdar, who is actually a graduate from Calcutta as well, but he has done significant amount of work on database development in medicine. As I said, we are going to develop these various steps. I'm not going to read through it, but our future considerations is to go into not just prediabetes, but other disease models as well. We have already published some data on COVID and projection of COVID from our databases. So we are also trying to identify the appropriate patients, not just veterans, but beyond veterans, getting the fetal microbiome data, statistics, and response. The good thing about why this is based in the VA system is because the VA system is integrated throughout the country. And we have data from all the VAs across the 50 states. So that's why the statistics is actually enormous on all these patients. There is obviously a huge amount of advantage in doing using the database that we have, along with the microgenomics that we are going to apply. And of course, as I said, the potential is quite large going forward. So in summary, we have a human host and gut microbiome that is interdependent. It's inflammation-based and CVD-based. We have already some data on it. And in summary, we would like to emphasize that utilizing the gut microbiome metagenomics along with the metabolomics to develop a prediction model to determine how an intervention as simple as ketogenic diet can be effective without wasting time, fund, and metabolic health. Thank you so much. And these are my fundings, my group, and I'm happy to take any question. And I've tried to keep it within the time limit.
Yeah, definitely, sir. You have finished on time. And first of all, thank you very much for such a wonderful session on the precision medicine. And I would like to congratulate you for such a wonderful study that you are carrying out in this area. And definitely, we would like to know the results in the future, that how it can help to predict the persons who will be helpful for the ketogenic diet. And I'm sure that many more studies may be coming in the future in this regard in the precision medicine. Because we are running short of time, I think I'd like to keep the discussion at the end. And now I would like to invite Dr. Adi Mehta to carry his session. Sir, first of all, we are very much sorry that we have to keep your session last because of the technical glitch. And now I officially invite you for your session. You are going to talk on the halting the progression of chronic kidney disease, myth or reality. Sir, please.
RX team, please share the
You are not audible, sir. Your voice is not coming. RX team, can you help Dr. Adi Mehta? Because I can see the unmute symbol is there on his screen, but still his voice is not coming.
Yes, sir. Now you are visible. Sir, your voice is not coming.
Hello. Sir, there is a left side in below button, mute, and in these, the sentence is same as system microphone. So please click on this. Yeah. Hello. You're not audible, sir.
I think sir has not joined using the Wi-Fi or cellular data. Audio is not joined. He's just present with the video. Can anybody call him from RX team?
Yes, sure.
Sir is showing some numbers on the screen.
RX team, what's the problem? Why the sir is not able to join?
Sir, you have on a screen unmute, mute button, sir, in a left hand under corner, sir. Yes, sir. Sir, upper arrow है ना, उस पे click कीजिए, sir.
Hello. Yes. Click on this button, sir.
CMS system
And click on CMS system.
Audio option.
Audio option, sir. Audio option is not. Yes. No. Sir,
Connect.
hello. Sir, can you connect the earphone or headphone something? Try this. You can try to connect the headphones, sir. Maybe the help. Hello. Sir, can you rejoin the Zoom?
No, sir, you are still not audible. Sir, please speak something. I think RX team, we can do one thing. If he can join by mobile and you can run the slides from him.
Okay, sure.
If you have slides, PPT of Dr. Adi Mehta, you can run from
Sir,
here and from the mobile.
Sir, please share your PPT in mail. Sir, I sent our mail ID. So please send the PPT.
Sir, we can do one thing. If you can send the PPT by email right now, then they will run the PPT from here. And then if you can join with your mobile using faculty link, then we will be able to run your session. That is the only option now, I think.
Sir, may I know what exactly problem you're facing while you're sharing your screen? Okay, we are not able to hear you. Okay. We are not able to hear you. And I guess you're not connected to your audio, if I'm not wrong.
Yes.
No, you're connected to your audio also. Okay, so do you have earphones? Do you have earphones with you? Try connecting your earphones once. No, still we are not able to hear you.
Not audible, sir.
Okay, can you check the settings of your Zoom where there is a mute unmute button? Just next to that there is a small arrow. Just click on that and try selecting options. I mean, directly from device and all that. Just try changing the settings. No. No, we are not still able to hear you. Yeah, can you speak?
Hello, Dr. Dishank.
So while you fix this, can we move on to the next lecture, please?
Yeah, I think that will be fine because we are running short of the time. So maybe
Yes,
you can start the next session.
move on the next session.
I invite Dr. Raghu Satyanarayan, who is here, and Dr. Arun Shankar, who are the chairpersons of the next session. So I hand over the session to them till the time the Mehta can join.
Hello, good evening, everyone.
Good evening, sir.
Yeah, good evening. Yeah.
Good evening, sir.
Yeah, good evening. Yeah.
I think you can start the first introduction.
Yeah. Can I have the slide, please? It's my great pleasure to introduce Cynthia Munoz, who is the President, Healthcare and Education at the American Diabetes Association. And she has an appointment as an Assistant Professor of Clinical Pediatrics at the USC Keck School of Medicine. She is also the President of the AADA's Community Leadership Board in Los Angeles. She's here to deliver. Next slide, please. She's here to deliver a talk now. Over to Dr. Cynthia Munoz, please. Yeah.
Hello, good morning. Hopefully you can hear me.
Yeah. Please go ahead.
Wonderful. Just one note, I am the immediate past president for healthcare and education with the American Diabetes Association. Always a pleasure to be here. And now let's see if I can connect my slides. All right. Okay, looks like we are set up there. This morning here, and so I would like to talk about what I call the P word, mental health stigma and awareness. Our world continues to fight against a global pandemic, and of course, one second here. All right, I'm sorry about that. My screen is back. Okay, our world continues to fight against a global pandemic, diabetes. The number of people affected continues to rise despite our efforts to eliminate it. Our world, of course, is also continuing to combat the COVID-19 pandemic. And here we see the numbers that continue to grow for people affected by diabetes, as well as the burden on the cost and living for people. Many have been faced by the loss of unemployment and financial struggles, decreased access to healthcare and education, shortages of food and supplies, and a lack of social support. It is not surprising that this has increased anxiety, depression, substance use, and exacerbated other pre-existing mental health issues for many. This is alarming for people with diabetes, especially as there was already a significant higher risk for depressive symptoms compared to the general population. And these depressive symptoms, we know, are associated with higher A1C, increased short-term complications, and increased risk and progression of complications that in turn can further exacerbate mental health issues. Individuals have reported significantly lower health-related quality of life and more mental health challenges than before the pandemic. And this impact has been greater for children. People with diabetes who experience higher levels of worry about COVID-19 could be more vulnerable for diabetes distress, hyperglycemia, depression, and anxiety. And awareness for the emotional well-being and support has been more important than ever. Let's take a look at one basic need: food. Adults who experience a disruption of food intake or eating patterns due to the lack of money, excuse me, and other resources may be at an increased risk for a variety of negative health outcomes and health disparities, such as increased risk for obesity. Food insecure households have a higher percentage of adverse childhood experiences, including many that you see on this slide: mental illness, addiction, domestic violence. Food insecurity is also associated with poorer mental health and specific psychosocial stressors across global regions, independent of socioeconomic status. This includes negative mood, anxiety, some reports of increased risk of schizophrenia, and negative emotional status. People experience all of these emotions, and it's reasonable that it has an impact on all aspects of life, including one's diabetes management. And so here we see diabetes in the center. We have various aspects of life. Life has been impacted by an overlaying pandemic, which has exacerbated for many stress, anxiety, depression. How many among us, including our patients, are feeling lonely, lost, angry, defeated, trapped, unhappy, and yes, depressed. Social media reminds us about the mental health impact on people with diabetes. As healthcare professionals, we are not immune to this impact, which I like to talk about, not just how we can take care of our patients, but also about the importance of caring for ourselves and for each other as healthcare professionals. Mental health conditions are among the leading causes of non-fatal disease burden in India. Since 1990, the contribution of mental health conditions to the total disease burden in India has almost doubled. And so we see that there are studies that have taken a closer look at mental health in various countries across the globe. Here, I researched some of the research that focuses on mental health in India, and find that the statistics are not unlike the statistics in many other countries. If we take a closer look, we see that India has one of the highest rates of suicide in the world. I wish I could say that the rates were lower in even the country that I live in, the United States, but that is not the case. The United States rates are higher. Continuing to take a look at the rates in India, however, we see that more than 220,000 people die by suicide every year. And some statistics report that an astounding 1 student per hour dies by suicide. In 2017, President Ramnath Kovind said that India was facing a possible mental health epidemic, and efforts were made to take a closer look and better understand the needs for all people. Again, it is not a surprise that the mounting mental health burden has had a negative impact on diabetes management and outcomes. What's even more concerning is the fact that access to mental health treatment is negatively impacted by stigma and limited or absent mental health resources. When we do not address the mental health of our patients, we risk undermining the well-being of the very people we serve, including our most underserved communities. This contributes to poor outcomes and higher risk for diabetes-related complications. We must take action. And this means that we must talk about the P word. We cannot avoid talking about the P word. And we certainly cannot afford questioning the existence of mental, emotional, or psychological issues. With this slide, I am reminded about the importance of words and how words matter. We have so many different terms that we use when we talk about the mental health or the emotional well-being of people. And used within a context, we sometimes are unintentionally exacerbating and or negatively impacting the very mental status or emotional status of others. Mental health conditions are often perceived with a sense of judgment, and there is a stigma associated with those having mental health issues. Stigma stems from lack of knowledge as well as negative attitudes and behaviors. According to Dr. Das, who is a senior consultant psychiatrist, president of the Indian Association of Private Psychiatry State Branch, and national co-chairperson of School Mental Health Division of the Indian Psychiatric Society, people with mental health conditions are amongst the least likely of any group with a long-term health condition or disability to find work, be in a steady long-term relationship, live in decent housing, and be socially included in mainstream society. When we add mental health conditions as an additional layer to the lives of people affected by diabetes, we can only imagine the impact and the effect that it has in each of these areas of life. Sometimes culturally, we look at people and we think about a continuum of a person being what we might refer to as quote unquote crazy or mad. And on the other side or the other end of the spectrum, normal. But we don't see the in between. We don't see that there are many challenges that people face. And this is really important. I'll touch on this in just a moment when we talk about myths. Diabetes can have a negative impact on one's desirability, in addition to the negative impact on desirability that mental health issues can have. And when I talk about the negative impact on one's desirability, it is the impression or perception that something is wrong or that there is something defective about the individual. As I was talking with some of my colleagues, we had a discussion and the question came up. For some, there was concern that the next generation, would be at risk for this lower level of desirability. Because what if there was a perception for a person with diabetes that the next generation would inherit diabetes? The question came up, could this be worse for females? For example, higher dowries could be demanded because in-laws would need to take over expenses. There was a broad discussion about this and many different opinions on this. And ultimately, the discussion circled back around to stigma and the impact that it can have not only on help seeking, but also on how we as health professionals can identify and provide resources or for support for the individuals who are experiencing a great variety of mental health issues. Simply having open and honest conversation about this can make a significant difference. It is key to start by building trust with our patients so that we can empower them to share these experiences with us. Not only can it be an uncomfortable conversation for us as healthcare professionals to start, it is also a difficult conversation for patients to participate in, to acknowledge to admit that there are challenges for fear of how they will be perceived. And so trust becomes incredibly important, as does talking about mental health issues by taking into consideration the context and the cultural nuances for the individual, and also being open to saying things like, you know, sometimes people report that they feel unwell, that they feel more tired, that they feel less motivation. Sometimes people report feeling unwell emotionally. This is not necessarily a defect. This might tell us that you have things that are happening in your life and you are not feeling well. What can we do to help? And so let's talk a little bit about what we can do. Really, it is starting with the basics. We can talk about it and promote awareness about mental health and related cultural beliefs. In doing so, it is key to address myths such as mental health issues are solely comprised of severe mental disorders. They are not. A guru can cure diabetes with herbs. Unfortunately, this is not the case. Another myth, type 1 diabetes is a condition in the Western world. Kids in India don't get diabetes. Unfortunately, this is also not true. How can we tap into these beliefs that people may have that then impact their diabetes management and what they are willing to do because they have very real fears and concerns and beliefs related to diabetes and what it is and what it's not? One of the questions that I am often asked is, how do we really know if someone is feeling unwell emotionally? How do we really know if someone is experiencing, for example, depression? How do we know that they are not manipulating? And the answer that I give may not sit well with everyone, but my response is quite simple, and it is just ask them. If someone says that they are feeling unwell emotionally, if someone says they are feeling depressed or depression, while we may look at our lives or our life experiences and wonder, what in the world does this person have to feel depressed about? We have to remember that everybody's life experience and the way that each one of us perceives the world is unique to each person. And so one of us may have great strengths and may have thrived even with negative experiences having happened in our lifetimes. We cannot assume that everyone carries the same strengths. We cannot assume that everyone will deal with the same situations in the same way. We are unique. So if someone says they are feeling unwell emotionally, we must at basic level, take that as fact and proceed with trying to identify what can be done to support this individual. There are two things that we can start doing today with each diabetes patient. One, our standards of care with the American Diabetes Association calls for screening for depression once a year. If that is not something that is currently happening in your office or your clinic, that is a discussion that can happen and that can start. Number two, include more mental health professionals as members of the routine care team. Having a mental health professional as part of your routine care team can make a big difference, putting a face to the name of the profession so that people are more likely to see that as mental health professionals, we do not just talk with and work with people who have severe mental health issues. Yes, that is also an important part of the work that mental health professionals do, but we also talk with people living their lives who also experience struggles and who feel unwell emotionally at times. And for our patients with diabetes, this is a critical form of support that we must extend to them to improve their diabetes and health outcomes. As we go forward, we must remember that all people deserve optimal whole person care. All people must have access to the tools they need to optimally manage their health, and this includes mental health and emotional support. Talking about mental health is a start. Mental health has been a taboo, and the time has come for us to accept it. It is just as important as physical health, and they are closely tied and interdependent. And I'm hopeful that by bringing this topic up with you today, that it will spark some thought and some conversation as we move forward in the care of our patients with diabetes. Thank you so much.
Hello. Thank you so much, Dr. Cynthia, for your brilliant presentation. It was really lucid and you covered everything, right from the Indian words called pagal and psychologic, and you really covered wonderfully well. And we should definitely delve into the patient's history meticulously so that, we get to know the problems, crux of the problems, and we address them. So that's the way we go about. Thank you so much. Brilliant. Thank you. So now there is some change in the program. Actually, Dr. Adi Mehta could not deliver because there was some audio issues. So the next speaker will be Dr. Adi Mehta from United States. He is the faculty.
Am I not speaking next?
No, sorry, sir. Actually, because Dr. Adi Mehta couldn't log in and there was some audio issues. So I've been requested by Dr. Bansi Sabu to take in Dr. Adi Mehta, sir. Please kindly.
So when do I speak?
The next one will be yours, sir.
In about 20 minutes? Okay, because later than that, I can't do it.
No, sir. It will definitely be done because Dr. Adi Mehta couldn't log in because of the audio issues.
Somebody should have told me. Nobody told me. It's okay.
Sir, even I came to know about it. I just got a WhatsApp message, and so I'm
and
sorry
just to
for
clarify
that.
and jump in,
can you hear
I'm
me?
happy to,
Hello.
Happy to,
can you hear me?
Hi, Dr. Mehta.
Hi. Can you hear me?
Yeah, sir.
If the next speaker wants to go ahead, I'll wait the 20 minutes and go after him. I don't mind
sir.
that.
Okay, nice of you, sir. So we can introduce Dr. Vivian Fonseca.
And can you clarify about my presentation as well? Harpreet Bajaj here. So I'm okay to wait after Dr. Adi Mehta. Hi,
that'd be great.
I'm sorry to push you, but unfortunately I'm on call and I will have to go. That's okay, Vivian. I know how busy you are.
So nice of you, sir. RS team, please share the introductory slide of Dr. Vivian
Fonseca, yeah. So here is Dr. Vivian Fonseca. Sorry for all the inconveniences because of the audio issue, sir. Sir is a professor of medicine and pharmacology, is the assistant dean of clinical research, is the Tulane Alumni Chair in Diabetes. He is the chief section of endocrinology, the Tulane University of Health Sciences Center, is the past president, Science and Medicine American Diabetes Association. And he's here, Dr. Vivian Fonseca is here to deliver a talk on a novel risk engine to predict diabetes complications. Over to Dr. Vivian, sir.
Thank you very much. Sorry, Adi. I really appreciate letting me go ahead. So it's a great pleasure to be with you guys today. I have been to Diabetes India in person before, but it's good to be here virtually. Let me share my screen, and in the interest of time, I will try to do this quickly. 1 minute. I'm having some difficulty with sharing the screen. Okay, I think I got it now. Can you see it?
Yes, sir.
Yes,
Okay.
sir.
So
Please
let
go
me
ahead.
move ahead. Just for disclosure, what I'm talking about, the Bravo Risk Engine, was developed by myself along with some of my colleagues at Tulane, and we have an ownership interest. So a few years ago, the ADA suggested that we have individualized goals, and in fact now moved on to individualized treatment to manage hypoglycemia. And there are a wide range of criteria that we have to use. Depending on different circumstances that you know well, we have to choose a goal. And this has become very challenging for people. As a result, many people don't know what their goals are. They don't know what to advise people with their goals. And it's often used as an excuse not to intensify treatment. So we need to do better than that. Similarly, in response to some very good clinical trial data that I'm sure you have discussed at this meeting and you've heard well before, the ADA put forward an attempt at precision medicine for pharmacological treatment. So you have to ask the question, does your patient have CKD or not, which is relatively easy? Do they have heart failure or not, which is also for overt heart failure is easy, but is not that common, as I will point out. And then you have the question, does ASCVD predominate? And for people who have a prior event, that's easy, but for most people, it is not. And most people may seem to be at risk. We use the term diabetes as a cardiovascular risk equivalent, but that's not true anymore. And it's very hard for many to pick who's going to get ASCVD in the future. And again, the next item is there compelling need to minimize hypoglycemia? I think that includes everybody. So what do we do? And then the cost is also a factor. So we need to be more precise. It's, again, been very hard to implement this in practice. So let's look at why. So if you look at the prevalence of various comorbidities in diabetes, this is in the United States, people with CVD and CKD are about 8 to 9% of the pie. People with CVD without CKD, about 13%. People with CKD and no CVD, surprisingly to me, was 15%, but I think many of these people have subclinical CVD. But 63% have no clear CKD or CVD, particularly in primary care. So how do we choose therapy based on these? These people were not included in most of the clinical trials on which we are basing our guideline. And when we talk about cardiovascular risk equivalents, we are trying to have one glove to fit everybody. And I think that's wrong. And to start, a very compelling review by Naveen Sattar a few years ago pointed out that risk varies. Risk varies based on the most important determinants are age and duration of diabetes. So if you are older or have diabetes for a long time, your risks are much, much higher than a younger person who has recently been diagnosed. Even after events, risk varies. So say you have an ischemic event. In the first year, your risk is very high. In the second year, your risk drops. And then subsequently, you have stable disease, it drops even further. And when you start talking about people with only risk factors, you include a large proportion of the population with hypertension and some dyslipidemia, but their risk of events is actually much, much lower. So how can we recommend treatment to be the same for all these people? In fact, when you look at the clinical trial results, the placebo groups tell us a lot. They tell us what the natural history is in that population. And here you see wide variation. In post-MI patients, the annual rate is very, very high, much higher than most of us see in practice. In people with risk factors, like in Rewind, it's very low, and it's not surprising. It took many years of treatment to show prevention in that particular group. And among all this, we also have some confusion about, what does glycemic control matter? And I think it does. It certainly reduces microvascular disease, and we seem to be forgetting about that as we tailor most of our therapies towards CVD. And there too, we're not doing a good job of managing blood pressure and lipids. We tried to look at the data around that time. This is several years ago, but it was only recently published, about taking 124,000 people in the VA and seeing what are the optimal goals to prevent microvascular disease. And it turned out to be an A1C of 6.8, LDL 110, not far from the ADA goals. This is very similar for macrovascular disease. But there were differences. The different goals varied depending on age and racial subgroups. So we felt that we can't make this recommendation. We're making the same mistake as the individualization guidance from the ADA. And we asked the question, can we be more accurate in individual risk prediction? Can this lead to better individualization? And would we target a treatment in a way that will improve outcomes? And this has been tried before. You take population data, you develop calculations, and you develop what is called a risk engine. It's an algorithm that takes a large population and tries to improve things. And today we have a lot of good tools. We have tools like machine learning, etc., that have really changed things. The older risk engines we use, as I will point out, have several limitations, may not apply to all populations. But now we have high tech to help us, and we can use apps and integrate it with electronic medical records. So here are some examples of the older risk engines. ASCVD is used a lot, but it's based on a group of people going to cardiologists and their baseline data. But data changes every year. You start somebody on a statin, their risk drops. So the following year, you need to update that, and that's not done in this risk engine. Another model that used by the CDC in the past was the Markov model that went by laws of chance. And if you have a 2% rate, you take out 2% of people randomly from your population and then apply the same equations to the rest. And that has limitations. Very famous is the Framingham risk score that uses very easy clinical parameters. And I really like that about Framingham. But the problem with Framingham is that it's based on the population in Framingham, not even in the rest of the United States, leave aside the rest of the world. And risk is very arbitrarily defined. And when other people have tried to use Framingham, like in the EPIC Norfolk, it turned out that it's a very poor predictor and overestimated risk. UK PDS has some advantages in their model. They have long follow-up, but it's a small group of people with newly diagnosed diabetes in the UK. Does it apply to the rest of the people around the world? Or I focused on the US here, but it's a global problem. I don't think so. And I'll show you an example. We used the UK PDS to calculate risk in the Accord trial to determine our power calculation. And it turned out that the observed rates for most things were actually far lower, including MI, stroke, etc., than what UK PDS had predicted. On the other hand, some things like CHF and kidney disease were much higher. Blindness was much higher. So UK PDS really doesn't apply to a US population. How would it apply to countries like India, etc.? So around that time, Dr. Shi and I had been working together for many years, and we had a PhD student who's now faculty, Hui Xiao, who came up with risk predictions, and we've developed this tool that I will tell you about, and the name is Bravo, based on these terms. So we have taken the whole Accord population, patient level data, we've been given that by NIH, and we've used microsimulation at patient level. And we've looked at the things that predict microvascular events, as well as cardiac events. We've used key biomarkers. We've also developed quality of life, and we've got data on that, and health utilizations. And we've now modified it globally. So I'll tell you how we did that. So we put in characteristics of the patient, and we want to look at outcomes. And we had this data over a 5-10 year period in a cord and accordion. So here is a summary of what goes in. Time varying factors, so we keep updating it at least once a year on risk factors. We take demographics, most of which don't change, but some things like age and socioeconomic status can change. We take in different regions, but not in a accord, but we've now added that on. And we look at complications, and here two things change. So if you develop kidney disease, for example, your risk of heart attacks changes. If you develop neuropathy, your risk of mortality changes. So that all has to be taken care of in separate occasions. So we have 17 equations running on the computer simultaneously, constantly updating itself. And we refresh this data at least once a year. And there's difference from other risk engines. It predicts not just cardiovascular, but also microvascular complications that other risk engines don't. It has good estimates of impact of treatment on risk, costs of treatment, etc. Each event is a discrete time event, and few other important differences. We are the only risk engine that takes body weight and BMI into the calculation. Hypoglycemia, that increases the risk of future hospitalization, also is in the equation. We've globalized this now, and we've also added things like utilization of healthcare and costs and quality adjusted life years. So the first thing you do when you develop a risk predictor is you look at internally. You make the calculation and you see, did it predict in accord itself? And you can see here that it predicted it reasonably well. Here is what the actual events were. This is what we had predicted, except that once you go over 80 years old, there are some errors. And that's not surprising because people at that age die of other things that we were not measuring. We also looked at all the other outcomes, and it was the same. Very good prediction. And when we've taken data from 18 large randomized diabetes trials conducted in 2000, and we've updated our data with patient characteristics from across the world, including India. And we think regional variation is a very important determinant of outcomes. And you see that in the differences in the different trials that are available. Some of this is not patient level data, it's aggregate published data, but some trials like Harmony, etc., they've actually given us the patient data. So here is the prediction, what we had predicted for each of these many trials, and here's what was actually observed in rate per 100 patients per year. And you can see a very reasonably good prediction for MI, stroke, CHF, revascularization, mortality, etc. So here is using the NHANES, the US population. We did a prediction initially, and then we calibrated it further against that population. This is very important. You have to change your equations based on the population. And then here you see what was actually observed, and you see how close we come to the prediction for mortality in NHANES. We entered a global challenge for risk engines, and we were given data from Canvas trial and EMPA-REG trial and asked to predict outcomes. And every model has errors, but our errors were less than any of the others. So we were given the award 2 years ago for this. So how are we going to use this? So one is risk stratification. Wouldn't it be nice if we could take all our patients and divide them into low risk people who we pay less attention to and high risk patients who need more time and we pay more attention to them? And then we could maybe start developing, and we're working on this now, take all the treatments that are available and try to assign them and tell the patient tell the patient and the physician at the point of care, this is what your risk is, this is what going to happen to you, and maybe this treatment is what you need. We're not there yet, but we're working on it. And then we can start looking at the costs of it and which populations would benefit at a reasonable cost for a particular intervention. And then finally, we all have programs, and we apply different new strategies for changing our management, and we can evaluate what the impact of that program would be. So I'm going to give you examples of each of these strategies. And this is from a paper just published in JAMA, where we looked at the impact of various risk factors on life expectancy using this risk engine. So you can see here backwards, as your BMI goes from 24, 25 up to about 40, 41, your life expectancy actually drops. And the same thing happens with systolic blood pressure, happens with LDL, it happens for a whole range of other abnormalities, but it's not always linear. So as your A1C drops below 6.4 and down to 5.9, you don't gain any added benefit in increasing your life expectancy, because rates are not increased at that level. So this is what I showed you earlier, and it was published in that JAMA paper. We also did a few other things with this. This is a projection, a simulation of what would happen if we took people with these risk factors in the 4th quartile and intervene to bring them to the 1st quartile. For take A1C, if you went from the 4th quartile to the 1st quartile, you would increase that patient's life expectancy by almost 4 years. If you went from the 4th quartile to a 3rd quartile, which is a small change, it is about 3.5 years, a little under 3.5 years. And the same with reduction in BMI had a big impact. Blood pressure had a reasonable impact, but a bit smaller. And to my surprise, LDL didn't change that much, and that's because most of the people taking with high LDL in NHANES were already taking a statin. So there's not much difference between the quartiles. So the impact of adding further therapy was much smaller. It also allowed us to develop a heat map. This is actually something we could actually use in clinical practice. It's based on BMI, systolic blood pressure, different from men and women, and age. So you look at life expectancy for a woman age 51 with a BMI of 25, it's 30 years. In contrast, at the other extreme, for a man age 71 years whose A1C is 10% and BMI is 35, his life expectancy is only 5%. So this is useful to tell people what is your risk, and maybe you can actually extrapolate that for them, and I'll show you how we do it electronically later on. You can say, if I moved your A1C down, I will improve your life expectancy by 3 years. If I moved your BMI down, it would change. And that might help in convincing your patient to change things. I talked about program evaluation and intervention. And with the American Diabetes Association, we worked on the INSIGHT program, where we electronically captured data from our primary care physicians at Tulane and at Parkland Hospital in Dallas. We sent them a report of which patients were doing well and which patients were doing badly. And we didn't do anything else. They themselves, on getting the report, intervened, and 6 months later, all their risk factors were better. And then we calculated with that what their benefits would be, which would include a reduction in mortality, a reduction in hospitalization for heart failure, in kidney disease, blindness, neuropathy, etc. So this is a powerful tool for evaluating an intervention that you might do. We also wanted to see how can we explain the results of some of the cardiovascular outcome trials. And we published this in Diabetes Care, taking the SGLT2 inhibitor trials. And for each of the outcomes, say MI or angina or heart failure or mortality, there are different impacts of different risk factors. So for example, for mortality, reducing BMI makes a big difference. For reducing MI, or you have a greater impact of A1C lowering. And note that LDL is worsened with SGLT2 inhibitors, but that is overcome by the benefits on the other risk factors. And these simple risk factors, if reduction down to the goals, would really reduce the differences you would have seen with the SGLT2 inhibitor trials. And here's what we had predicted as the things in EMPA-REG, CANVAS, and DECLARE. And here's what was observed both in the placebo group and in the treatment group. And you can see a very close prediction of what would happen. Note the difference in absolute rates. In EMPA-REG with high risk post-MI patients, the rate for cardiovascular events such as and mortality is much higher than it was in DECLARE, where half the patient or 2/3 of the patients had not had a prior event. So that too really matters, and it matters in relation to cost effectiveness. We recently had the US government take a decision that in Medicare, no patient would have to pay more than $35 a month for insulin, which has become a hot button issue here. And what we felt was they didn't reduce the total cost of insulin. So the total cost of the system remains very high. And we concluded that this was not cost effective. And we are actually working very closely with a number of policymakers on trying to come up with what should be a cost-effective cost of insulin. But this applies not just to insulin. So let me give you an example of SGLT2 inhibitors. We know that they reduce the risk of heart failure hospitalization by 40%. And if you take a population at very high risk, 50% risk of heart failure, say people with prior heart failure in a cardiology clinic, you reduce that to 30%, you've actually gained a number of years of quality adjusted life years. And it's really very useful in that population. On the other hand, you go to a population in primary care with recently diagnosed diabetes, and their risk of heart failure is only 1%. And even if you reduce it to 0%, you have to treat 100 patients to get this benefit, which is very small in absolute terms. So it may not be cost effective. In fact, we've worked out cost effectiveness using this model. And if you look at the 10-year risk of CVD, it's got to be over 15% for GLP-1 receptor agonists to be cost effective, at least at US prices. So you may have lower prices, so it might be better. The same with SGLT2 inhibitors. We've compared it with using sulfonylurea, and I'm not recommending widely sulfonylurea use. I'm just talking about cost effectiveness between a cheap drug and a more expensive drug on lifetime benefits on CVD risk and mortality. And you find that there's a great variation in the population. Some people at this end of the spectrum greatly benefit from using SGLT2 inhibitors over sulfonylureas, whereas other people at this side may not get that much benefit and it may not be worth the cost. Another thing we have done is to simulate a trial. This is the first time this has been done. We used a fixed ratio combination of lixisenatide with glargine because we know the cardiovascular events rates on both of these. We know what the benefits and risks are. And we simulated what would happen versus standard of care of combining the two, insulin plus GLP-1. And here when you're modeling, you have to use different scenarios. One is an optimistic scenario that you get benefit and it stays there for 5 years. And the other is a more realistic, conservative scenario that you get a benefit. And then as you saw in the GRAY trial, the benefit gradually declines over a 5-year period. And you see that the benefits would be different from the two, but with both, it is statistically significant. You get better reduction in A1C with less hypoglycemia and so less weight gain. So you will get greater benefits on cardiovascular events and microvascular events as projected by this risk engine. So can we individualize treatment? The way I envision it in the future is the patient walks into the clinic and you get either on the side of the electronic record, a red dot or a yellow dot or a green dot telling you your patient's risk, as well as suggesting what kind of risk the patient has and what would be the optimal treatment based on the many clinical trials that we have. And you can have a transparent platform for shared decision making. We've taken it one step further. We've created an app that's been beta tested with Apple. You can look at the website, bravoforhealth.com. Look at the demo on the app. You can enter duration of diabetes, various risk factors, and within a few seconds, it'll tell you what your 5-year risk of stroke, heart failure, MI, angina, revascularization, kidney failure, a whole bunch of things. So I think in the interest of time, I'm going to stop there and take some questions from you.
So brilliant talk, sir. Wonderful. Very nicely explained. Bravo should be the way we go about in India also. And because the older risk factors used to be for 10-year risk, but it has to be a lifetime risk. And as you mentioned that this keeps on changing. So we got to keep on reassessing the risk of the patient
Yes,
also.
you cannot do it mentally when you've got 5-10 minutes with your patient. You cannot calculate it. So you got to have it done for you. And what we are working on is let the computer grab it from the EMR and put it on the side in a pop-up. And actually that is possible. We're testing it out right now.
So from the goals, we shift to individualized treatment. And as you rightly mentioned about the red, yellow, and the green one, so the patient looks for himself. And the focus should be on BMI and A1C as according to this Bravo risk score.
No, everything. They're all, it's like the steno trial approach. That's what, that's what we would like to put it. You have to take care of everything. If you look at the guideline right now, it says choose a GLP-1 or an SGLT2. That or already is confusing you and your patient.
No, sir, but rightly said that when we are focusing on BMI, we've got GLP-1s and we've got SGLT2s, we've got canagliflozin 300 milligrams. And if you combine these two, you get modest to very, very good weight benefits.
You get weight loss, but then you have to get into, is it cost effective? That combination in the United States costs almost $2,000 a month.
Right.
And if you have a low risk patient, it's not cost effective.
It's not worth it. It's not worth it.
Yeah, your patient will feel better, but would they pay out of pocket for that? Now I know that some of the drugs are cheaper in India, but it's still the income of your patient is less.
Yeah, sir. Expensive. So wonderful talk, sir. Once again, sorry for all the inconvenience caused to you.
I'm sorry to have rushed you. But
no, sir. And it was really unfortunate because he couldn't. There was some audio issues with him, sir. And thank you once again, sir. Sincerely appreciate it. Thank you. Thank you. So now I would like to request Dr. Adi Mehta to deliver his talk on CKD, and he's going to talk on CKD and diabetes. Sir, and Dr. Adi Mehta is the faculty. This slide, please. He's the attending staff Endocrine Metabolism Institute, Cleveland Clinic from 1993 till the present date. He's also the associate professor of the Department of Endocrinology, Internal Medicine, 1982 to 1993. He's the member of the American Association of Clinical Endocrinologists, the Endocrine Society, and the American Diabetes Association. So sorry, Dr. Adi Mehta, sir, for all the inconveniences, sir. So over to you, sir, for your talk. Please, sir.
Thank you very much. I have to say that this has been very kind of you. I am honored that you asked me to give this talk, and I'm humbled that you would actually wait to listen to me. I'm not sure I'd listen to myself most of the time. But having said that, thank you. I just listened to about 4 different talks, and they've been erudite, tremendous, clinical, and academic. And what I'm going to concentrate on is a little bit more physiology and a little bit more probably practical, and I hope that that will do the trick. So I'm going to be talking about kidney function. But before we talk about protecting kidney function, we need to be able to say, do we actually know what we're talking about? So we accept a creatinine value from a little piece of paper that says that the creatinine is either normal, or there's a little high next to it, or there's a little low next to it. And all of us accept that as gospel. Is it gospel? Same thing with the EGFR. It is mandated that the EGFR be part of the report. And yet, do we know what we see? Everything. So let me just talk to you about that in a minute. So when we look at the creatinine concentrations, they are specifically and very clearly affected by muscle mass, age, gender, ethnicity, whether you got liver cirrhosis, or you got thyroid function disorders, are you on high dose steroids? How many of us pay attention to those factors when we look at a creatinine number? Then you go on to the concept of the GFR. And what you see here is GFR is circadian variations. Diabetes affects it early on differently than it does it later on. Pregnancy. One of the things that I always ask my fellows, so you see a GFR of 70. What does that really mean? Well, that tells you that that kidney, that's the maximum function it can do. If you therefore protect that kidney, take the load off the kidney, what's the first thing you're going to see? A drop in the eGFR. And everyone going to say, oh my God, you caused azotemia. No, you didn't. You were taking the stress off the kidney. In India, if you have someone who's not a vegetarian, who now suddenly gets religion and becomes a vegetarian, how much of an eGFR drop can you expect as a normal phenomenon? About 20%. Does that mean you caused azotemia? No, because if you give him a protein load, they immediately go back up again. So I think it's important for us to understand that the eGFR is a manifestation of the workload of the kidney. And if you're stressing the kidney, that's the maximum work it can do. But if you take the stress away, it's going to be better. So keep that in mind as we go forward. Also, we need to look at age. If you look at our eGFRs, we're going to say that everyone over 70 is CKD3. Do you really believe that? That's ridiculous. The fact of the matter is, if all of us live to be 120, all of us would be on dialysis. And that's not going to happen because you've been pulmonary failure by 115 and probably have diabetes by 110. And that's not because you got it. That's just a part of the aging process. So keep all those factors in mind. In fact, there is a move forward to say maybe eGFR should be age stratified once you get past about 60, 65, or 70. And I think that's important because we start to use a whole lot of resources on people who may not have disease. And I think that's important to keep in mind. So what about diabetic nephropathy? Well, diabetic nephropathy manifests differently between type 1 and type 2. In type 1, you start off with a hyperfiltration, but no problems with your kidneys. And there's a null time of approximately 5, 7, 10 years before you start to show significant effect on the kidney. On the other hand, in type 2 diabetes, a lot of the time, the diabetes has already, or the manifestations that cause the diabetes, the hypertension, the insulin resistance, have already started affecting the kidney, so that you're starting at a totally different point in terms of nephropathy. And everyone of you knows this particular picture. You get the hyperfiltration early, then you have a period of time when your eGFR is completely normal. At that time, slowly over time, you start to develop microalbuminuria. I'm told that that's not something you want to talk about anymore. You want to call it all albuminuria, and that's fair enough. It's albuminuria. There's nothing micro about it, but it starts smaller concentrations and takes off. And then it reaches a point where at the same time as you got a maximal amount of protein excretion, you're going to start seeing a decline in your eGFR, and you're starting stage 4 of the disease. So if you look at staging, majority of the staging is based on the, not so much the eGFR as much as it is based on the protein excretion. And as you can see, protein excretion tends to limit or tell you exactly where you might be. Please remember, microalbuminuria is also age dependent. So yes, if you have diabetes, you have a high amount of microalbuminuria across the age span. But if you have hypertension, the same thing, less possibly. But if you have got no, you still get some microalbuminuria once you get to my age. And therefore, I don't worry about it. The fact of the matter is my kidneys are paying the price for being 70 years old. And I think it's important to sort of keep that perspective, especially given the talk that Vivian just gave you, telling us we need to be able to think about people within the context of where they are in terms of risk and age. Now, proteinuria always predicts mortality. And you can see here that basically, if you don't have proteinuria, your mortality tends to be much significantly lower than if you have proteinuria, whether you're a male or a female. And so when you look at proteinuria, one of the things that we have to understand is if you have proteinuria, the rate of progression to CKD is significant. If you're able to decrease proteinuria, you are able to slow down the decrease in kidney function. So proteinuria becomes a very significant target in terms of what we can do to try and protect the kidney. Now, this is the Kidney Association's comprehensive rest management. And what you see is in the lower blue part of the pyramid is all the motherhood things we talk about. Control your weight, control your smoking, control your blood pressure, control your glucose, control your cholesterol. That's the motherhood. Then we talk about the specific measures we can take to protect the kidney, and that becomes the peak of the pyramid. So all of you know this. I don't need to at all tell you this. You improve control, you take away long-term risk in terms of microangiopathy and neuropathy, nephropathy, and diabetic retinopathy in DCCT, which is a type 1 study, or in UKPDS, which is a type 2 study, showed the same phenomena. The better the control, the better off you are. So I don't need to belabor the point, but it's not only the hemoglobin A1C, it is also the variation of glucose. So here you see out of the DCCT, they looked at the seven point tests they were doing throughout the years. And what they showed was the lower the glycemic variability, the higher, the less the amount of glycemic variability, the less proteinuria you have. So it's not only the hemoglobin A1C, but it is also the glucose variability in the level of the kidney. So this is a paper that is, in my opinion, a signal paper. This is on hypertension. I'm sorry.
Sir, sorry to interrupt you, sir. Sir, can you make these slides bigger, the full screen? So probably you had not done it full screen. So we are seeing it all small on the main screen, sir. If you can kindly do it.
That's the best I can do. I don't know.
No, sir. At the bottom, there will be one filter like thing. And if you can just make it large, it will immediately become the full screen, sir.
There we go.
Yeah, sir. Yeah, there you go.
Okay, so this paper is a signal paper. This is Hans Parving in 1985-86. He basically took a group of people with type 1 diabetes, followed them over a period of a year or two to notice what sort of deterioration there was in their kidney function, and what was their blood pressure, and what was their proteinuria. Then he aggressively controlled the blood pressure and was able to show that there was an immediate response in the mean arterial blood pressure. That's what he was treating. You decrease the rate of loss of kidney function and you stopped albuminuria. What everyone forgets about this paper was this was before the RAS. This was done with beta blockers and hydrochlorothiazide, controlling blood pressure, irrespective of the agent, gives you benefit. And it's across the board. As you decrease the proteinuria, you will decrease the tendency to end-stage renal failure. What about cholesterol? Well, cholesterol is an interesting phenomenon. Even the kidney people say, oh, you got to treat the cholesterol. Well, here's a study looking at actually treating cholesterol. It has no effect on kidney function. It does not protect kidney function. It does not affect proteinuria. So then why do we stress that? Well, let me take a look. Let me look at a more direct result. This is a study done comparing rosuvastatin and atorvastatin. And surprise, atorvastatin showed a decrease in proteinuria. Rosuvastatin didn't. So this is not a statin or LDL effect. This is a drug effect. That's not what we're talking about. So why bother treating statins in individuals at risk for renal failure? Because what kills you at the end of the day, if you have renal failure, you're more likely to die from a cardiovascular death than you are from the kidney failure. And therefore, treating LDL aggressively in these people actually does cut down risk. And that's why you have to do appropriate LDL therapy. So we've talked about improving outcomes in diabetic nephropathy. We've talked about prevention of cardiovascular events. The actual topic is prevention of end-stage renal disease. And so when you look at the drivers of diabetic kidney disease, the major drivers are going to be inflammation, hemodynamic regulation, and hyperglycemia. And if you think of it in those three areas, you will very quickly think about ways that you can affect each one of those, target those areas to give you benefit. This is the nephron. This is the endocrinologist view of the nephron. There's an efferent vessel that brings the blood into the glomerulus. there's an efferent vessel that takes the blood out of the glomerulus, and the pressure in the glomerulus is the difference between the efferent and the afferent pressure. The lower the difference, the lower the stress on the glomerulus. What happens in diabetes? Well, if you get hypoglycemic, if afferent vessel, the vessel bringing the blood in, dilates, it's vasodilated. The efferent vessel remains the same. The pressure difference between the efferent and the afferent now is higher, and there's a higher glomerular pressure. So when you start to talk about controlling glucose, you're obviously trying to take away the vasodilatation at the afferent vessel. Maybe you might be able to think about how do you relax the efferent vessel? And that was the first studies. ACE inhibitors basically relax the efferent vessel. And when you looked at what happened when you put people on ACE inhibitors early on, you see here that there's a very significant improvement in terms of doubling of serum creatinine, end-stage renal disease, and overall nephropathy. There's a statistically significant benefit. Is that surprising? No, that was what we started on this whole process. That's why ACE inhibitors, or to put it more cleanly, the whole RAS system agents became the basis of all therapy in terms of treating kidney disease. And if you look at 11 randomized trials and meta-analysis, what you find that ACE inhibition decreased the combined risk of CKD and development of end-stage renal disease by 30%, independent of blood pressure. And I think it's important to keep that in mind. And just so that I don't feel that I'm pushing only ACE, the ARB studies showed the same benefit. And I want you to look at the benefit. The benefit is somewhere between about 18 to about 32%. That's the risk reduction you are seeing, a relative risk reduction you're seeing. And so the next step is, how can you make that better? Well, we have another agent that works at the afferent vessel, which is the SGLT2. The SGLT2, because it causes the increased secretion of sodium, chloride, and glucose and water, the macular densa sees a different concentration and therefore starts to constrict the afferent vessel. Now, the pressure difference between the efferent and the afferent drops, which is why every time you put someone with a eGFR of 70 or 60, you will see a decrease in the eGFR. And everyone accepts up to a 30% drop in eGFR as being a protective element, not necessarily an azotemic event. And I think it's important to sort of think about it and realize that that's going to happen. And there is a significant correlation and cohesiveness between ACE and ARB and SGLT therapies. They basically work at the level of the heart. I'm not going to talk about that, but at the level of the kidney, they cause the vasodilatation. The change in the sodium is going to cause changes in local angiotensin and aldosterone mechanisms, and you're going to have beneficial effects on taking the stress off the heart, of the kidney, I'm sorry. And if you look at the landmark studies with the SGLT2s, and I know they've been discussed in this symposium, I don't want to belabor the point. The point is that it's clearly that there is a significant improvement across the board in every renal outcome that you see. Okay? And you can choose whichever favorite study you've got, it gives you the same benefit. It gets to be boring. So now we've got affecting the efferent vessel, the afferent vessel. What about the glomerulus itself? Well, the glomerulus is facing a totally different hormoning milieu. Diabetes, and especially the changes in fluid mechanisms that are induced in diabetes, causes the release of aldosterone. Aldosterone has very specific effects on the brain, but most importantly on blood vessels. And even more importantly, it induces inflammation and fibrosis. One of the reasons that all of you know from treating CONS, primary hyperaldosteronism, if you have a short duration of primary hyperaldosteronism, you fix the tumor, you don't have blood pressure problems. If the aldosterone problem was a long-standing one, you do still need blood pressure treatment because there's fibrosis of the blood vessels that have been facing this high level of aldosterone. And so yes, Aldosterone's major function is renal sodium absorption, but it causes inflammation, fibrosis, mesangial cell proliferation, and podocyte injury in the kidney. It actually affects the glomerular tract, and therefore it is going to cause a significant amount of distress in terms of kidney dysfunction. And when you look at the severity of albuminuria, predicts the amount of TGF beta that you see, which is a measure of fibrosis in these situations. Now there are steroidal mineralocorticoreceptor and non-steroidals. And I don't need to belabor this point. I'm sure I saw someone talk about the mineraloreceptors in this symposium earlier, this thing. So I don't want to belabor this point too much. So I'll move away from that and then go to what is really the ongoing studies, which is Figueroa DKD and Fidelio DKD. And these two studies were studies looking specifically at cardiovascular risk, but had the added secondary outcomes in terms of kidneys, and they showed clear benefit. Really, the most important thing we need to understand about all of these studies, whether you look at the SGLT2 studies or you look at the mineralocorticoreceptor blocker studies, what is the quote that stayed in the methods? That every patient was treated with the primary good standard of care. So in the SGLT2 studies, almost all those people were already on a RAS combination. In the Figueroa Fidelio studies, there was RAS, there was the mineralocorticoid receptor, and a small percentage also were on SGLT2s. And what you saw here was approximately a 50% risk reduction, relative risk reduction. So as you start to target those three aspects of the kidney that causes the problem, you are truly going to be able to decrease the long-term risk to the kidneys and slow down the progression, if not stop the progression of disease. And then there's the oddball, the GLP-1 agonists. GLP-1 agonists in post-hoc analysis have been shown to have beneficial effects on the kidney. And that's one of the reasons why there are some postulates as to why this works. And it's quite obvious that it works through some molecular mechanisms and inflammatory mechanisms, as well as through the glucagon responses, as the glucagon talked about earlier. So that in effect, you've got a significant number of targets that clearly work to protect the kidney. And so, as you know, the major studies, LEADER, SUSTAIN, AWARD, and REVINE showed benefit in terms of the kidney by about 15 to 25%. So there was relative risk reduction of 20 to 20. And that's one of the reasons why there is the FLOW study that is presently being done, specifically looking at the individuals with CKD to see whether you can make a change. So yes, there is a reason why this becomes a very important target. And I don't want to get away from this whole incretin process. One of the things that's happened in the world, and maybe not so much in India, but certainly in the US, is now we consider DPP-4 the poor relative of the GLP-1s. And we've forgotten that, yes, it's a poor relative in terms of potency, but it acts on the incretin system. And therefore, that effect is going to be present. And the fact that we don't see it in 5 years is not correct. The reason why we do studies for 5 years is because the principal investigator doesn't know whether he will live beyond 5 years. What we need to do is look at the amortization over a lifetime. And yes, if you look at that, you start to see that there is the same incretin response that you see with GLP-1s shared with SGLT2s that you see with DPP-4s. And when you look at the results, yes, there is a drop in microalbuminuria, and these are the studies that were done with sexagliptin and linagliptin. So there is an effect on microalbuminuria if you believe microalbuminuria or albuminuria is a risk factor for progression. And so across all the major drugs that are available in the US, there's been shown a very positive response in terms of renal protective effects of the DPP-4s. The poor relatives who are still working along very quietly in the background, doing the job. This is something that's very important for India, because in India, these drugs are truly comparatively cheaper and can be more universally used. If we don't pay attention to them, we listen to the propaganda that says it hasn't got potency, we lose an opportunity for fantastic treatments. So the cornerstone to consider diabetic kidney disease is, yes, you do the motherhood, fix the glucose, fix the blood pressure, get the weight loss, stop the smoking. Then you use ACE and ARB, and use an SGLT2, and you use an aldosterone receptor blocker, and maybe a GLP-1. And suddenly, we've got the ability to target the very areas that cause the progression of kidney disease. And remember, 40% of people with diabetes will develop kidney disease, and the largest number of people on dialysis in the US are people with diabetes. This is truly a long-term saving economic thrust. So yes, I think the Kidney Disease Association has clearly said, you treat exactly the way we said, treat the glucose, treat the blood pressure, treat the kidney specifically, and treat the stat lipids so that you can get to goals away from kidney disease, cardiovascular disease. And so if you look at the clinical practice guidelines, you've got H1C targets, blood pressure, sodium restriction, protein intake, physical activity, and then the specific medications, ACE inhibitors, SGLT2s, GLP-1s, MPAs. I think it's important for us because please remember, by the time a patient sees a nephrologist, it's too late. We have to be the early nephrologists. We have to be the people to try and protect this. And so in my opinion, it's very crucial we think of this in terms of the targets, and we specifically target to get what we're looking at. So I'd like to stop there. Thank you very much for your time. I am truly, truly humbled by the fact that you gave me this opportunity. And I wish that I hope that I have done something worthwhile. Thank you.
So thank you very much, sir. It was a brilliant talk, and you emphasized the need for aggressive treatment, getting SGLT2, ACE, ARBs, GLP-1s, and the MRAs, particularly Renal. And so wonderfully said. Everything, it was a brilliant talk, sir. Thank you. Thank you. Much. We got to be aggressive, right, sir? Over to Arun Shankar. I think he can take the proceedings forward.
Thank you, sir. At the outset, let me congratulate dear Dr. Banshi Sabu sir and the entire team of Diabetes India 2022 for the huge successful event going on still. So without wasting time, I would like to invite our next speaker. And the topic is very, very important because Dr. Harpreet Bajaj, the next speaker, he will be talking on once weekly basal insulin, why, how, what, and when to start. Dr. Harpreet Singh Bajaj is the endocrinologist and director of late phase research at LMC Healthcare. He started his endocrinology practice with LMC Brampton in 2009 after completing his clinical fellowship at Cleveland Clinic. Dr. Bajaj's medical education was at Maulana Azad Medical College, New Delhi, following which he attained a Master's of Public Health Epidemiology at State University of New York. Dr. Bajaj, a research associate at Mount Sinai Hospital, Toronto, and an adjunct lecturer at McMaster University, is the principal investigator for the Canadian Diabetes Prevention Program, a virtual one-year health and wellness coaching program funded by Public Health Agency of Canada. He volunteers with numerous community public health organizations as well as media programs with the intent of raising public awareness on diabetes prevention and treatment with a specific focus on South Asian origin population in Canada. He is the founder of Stop Diabetes Foundation, a registered charitable organization working to reduce the burden of diabetes in Peel region of Ontario. Dr. Bajaj serves Diabetes Canada on the executive board of the Professional Section Executive and as vice chair of Clinical Practice Guidelines. So we are eager to listen more about once weekly basal insulin from you. Over to you.
Harpreet, I'd like to thank you for letting me have some of your time. It's very kind of you. I've known Harpreet for a long time. He hates my guts, so it's always nice to bug him. Thanks a lot, Harpreet.
I love, if I could say, I love each and everything about Dr. Mehta, and whatever I've done in my professional life is because of you, sir. So, of course, I trained under him in my endocrinology fellowship at Cleveland Clinic. That's where we met. And the 2 years that I got to spend with him and learn about, of course, how to treat patients, how to talk to patients, the things that he brought in his lecture today, including, start from physiology. If you understand physiology, then you can go to pathophysiology and take clinical pearls from it. But if you don't understand the physiology, you're nowhere basically. And that's what he taught today as well. So very educational. And thank you so much, Dr. Mehta. And it was a pleasure hearing you after so long. You have grayed hair and maybe a little less hair. I'm also a little gray more than I used to. So it's all part of life, right? Thank you. All right, I'll just start my presentation here. The presentation is going to be focused on once weekly basal insulins. We're going to touch on some of these issues about why, how do we do it, but more importantly, when can we expect it, is going to be, I guess, the clinical question that everybody might have in their heads as well. So let me start that. In terms of disclosures, I don't speak for any pharmaceutical companies anymore. I do research which is supported by pharmaceutical companies. But in terms of speaking, I should also say that a similar talk is going to be presented at a symposium at the ADA conference coming up in about 10 days. So if you're at ADA or attending virtually ADA in 10 days, please look for the Monday symposium starting at 8 a.m. New Orleans time, when I'll be speaking on a similar topic, but maybe in more depth as such. Okay, so start back from history though, before we go to the future. If we could start back at the 100-year history of insulin, which is also the theme of Diabetes India conference this year, right? Great theme because it is something to be celebrated. 100-year history of insulin also needs to remember the Canada origin of insulin, and I'm happy to share these pictures right here from Toronto itself, where insulin was discovered first, and then, of course, Nobel Prize was given, and Marjorie, the dog who received that first insulin shot as well. So that's the history, and of course, over the last 100 years, insulin molecule, in terms of mechanism of action, duration of its half-life, as well as administration, has undergone a lot of innovation, which is where we are at today, where we no longer need to give insulin every few hours like we used to when it was started, but we have longer insulins up to 40 hours or so half-life with administration, which is once a day for a basal insulin. But is that good enough? If you ask a person who needs insulin, we're talking about type 2 people, people with type 2 diabetes. Of course, type 1 diabetes, they need insulin, and that's the only treatment. But in type 2 diabetes, people who need insulin, they often delay the insulin because once a day is still too much for them, and they don't want to do it for that. We know from GLP-1s that once weekly GLP-1s or from bisphosphonates, once weekly bisphosphonates are much easier to take than taking a once a day medication. And if it's an injectable, that clinical inertia is even more. So the future of basal insulin innovation is going to be a once weekly insulin analog with a longer half-life. And then hopefully we'll see less clinical inertia and also better adherence to the insulin. So people who take daily insulin often miss the insulin. They think, oh, I can skip one day here or there. And so hopefully we'll see less of that as well. I won't go too much into this table because there's too much information to be discussed and I don't have all the time. I'll just share some of the names of the molecules that are in the pipeline or were in the pipeline here on the first column. The ones in red, highlighted in red, are actually molecules that have been terminated. So they're no longer being developed. The bottom ones in green are the ones that have entered or are entering phase 3 trials. And of course, after phase 3 is when regulatory approval comes. So they'll be applying for regulation or to be available in various parts of the world. So what are these two at the bottom? One is a BIF insulin. I'll explain that in the next slide, what that is. It's made by Eli Lilly and Company. It's just entering phase 3 trials now. It's meant to be, at least in the phase 3 program, both for type 1 and type 2 diabetes. And it's a FC fusion protein is what it is. And I'll explain that in the next slide. There's also insulin icodec, which is a little farther along, and we may have that available even before BIF, maybe by a year and a half or so. This is developed by Novo Nordisk. It's a phase 3 program that is already underway and should be actually finishing within the next few months. We already have the first trial announcement from the phase 3 program that I'll share as well. This is also being developed both for type 1 and type 2 diabetes, and I'll explain the molecular structure when we get to icodec. But BIF first, what does BIF stand for? The short form is basal insulin FC. It's also this technical name, and the in or the name that will come out with is this FC-TORA alpha, which itself is an interesting name itself. So how is this molecule structured? So they have, and this is similar to dulaglutide in a way because they use FC portion of the immunoglobulin, and they fuse single chain insulin to this FC portion so that it works longer and has a longer half-life of about 17 days half-life. So that's a long half-life of this molecule. Now, I'm a clinician at heart, just like Dr. Mehta is. So I'll just jump to clinical data here and not talk about phase 1. But phase 2 program for this BIF insulin includes 3 trials, one in type 1, another in insulin naive people, and then another in insulin switching people from basal insulin switch to this BIF, comparing all 3 comparing to degludec. Now, the first 2 trials, we don't have data yet. It has not been presented. What has been presented but not published is the 3rd trial, the basal switch trial, which is here. So this was presented last year at the ADA. We don't have a publication yet. There are some details that are not available yet. But what we know is in this trial, there were 2 BIF arms which were targeting different glucose parameters. So slightly higher target range was there for BIF in the algorithm versus insulin degludec, for which there was a tighter glucose target. So with having said that, what they found was that the BIF molecules, the A1C lowering, as you can see in the bar graph as well as in the plot, is that the BIF hemoglobin A1C lowering was slightly lower, if you will, by about 0.1 percentage points on the hemoglobin A1C at about 6 to 7 months of therapy. But remember the long half-life. Remember that the targets were actually different for fasting glucose for BIF, which was slightly higher anyway. So that could explain potentially the hemoglobin A1C difference. And anyway, this was a small study, so there was no statistically significant differences that were found in this trial. What was somewhat interesting, but again could be explained by any of those other reasons that I said for hemoglobin A1C in this trial, was that the hypoglycemia rates were actually lower in the BIF, especially the BIF A1 algorithm versus degludec. Now, degludec, we know, is one of the best insulins when it comes to hypoglycemia prevention. So if this were to be true, that a weekly insulin comes with similar hemoglobin A1C lowering and with even a less hypoglycemia risk than degludec, then that will be golden. Of course, this needs to be looked at in the phase 3 program, which is just about getting started with this molecule. So for BIF, they have 5 QUINT trials, 2 in insulin naive people, 1 a basal insulin switch trial, 1 an MDI trial in type 2 diabetes, and then a final trial, QUINT-5, in type 1 diabetes as well. So that's the program that is just about to get started. So we don't have much details about those trials. So that's about BIF, the first green highlighted weekly insulin that I discussed. Let's move to icodec, the second one that has more data that has been published as well. So icodec, this is the structure. So there's 3 amino acid substitutions which increase basically the half-life. And then there's the fatty acid diacid chain that is attached by a spacer, which provides this molecule a reversible binding to albumin. And this is very similar to detamir insulin, or as we call it, brand name Levemir insulin that we had, that it binds to albumin and slowly releases. That's similar mechanism for icodec as well, that it slowly releases even more slowly than the detamir insulin, and provides a half-life which is longer than 7 days as such. So again, let's jump to the phase 2 clinical data itself. So there have been 3 trials in phase 2 that have already been published. These 3 trials have been published and presented. These were published by January last year. So it's been a year and a half since they were published. It was a large trial program with more than 600 participants in these trials. There are 2 trials in insulin naive people. So the one on the left and the one on the right are insulin naive trials. The one in the middle that I have on this slide was a switching trial from basal insulin to weekly icodec, using 2 approaches of a loading dose versus not loading dose. Loading dose being that the first dose that you switch is a double dose, and then you go back to the single dose and then titrate from there. The reason being that, of course, a long half-life of 7 days, so it takes 3 to 4 weeks to reach a steady state. So why not give a loading dose to address that 3 to 4 weeks of time that is taken for steady state, and then you'll have less hyperglycemia during switching. And that was what was seen in this trial, which was published by us in Diabetes Care last year. So I'm not going to show you data on that trial. I'm going to show you data first on the first trial on the left. That is the pivotal first phase 2 trial, which was published in the New England Journal of Medicine. I had the pleasure of being one of the co-authors on this. So what this trial did, and in a double-blind, double-dummy fashion, so the highest amount of evidence that you can think of, level of evidence, with a randomized, double-blind, double-dummy trial, what they looked at was insulin icodec versus glargine U100 in a double-blind fashion. The target glucose in this trial for both the icodec and the glargine was the same, which was very, very tight. So 70 to 108 milligrams per deciliter was the target for that. And some people say maybe that's too aggressive for a weekly insulin, but that's the trial, and that was the right start for the trial as well. And the algorithm was +2 +4 or -2 -4 for glargine, which is what we use clinically, and multiplied by 7, so +14 or +28, and -14 -28 for icodec. So basically borrowing the algorithm from glargine to put on icodec was what was tried in this. And what it showed was quite interesting. So hemoglobin A1C actually reduced a little more, 0.2% more with icodec than with glargine, did not reach statistical significance, just missed it, p-value of 0.08, which was quite close to the statistical significance margin. And this, despite using a higher dose on glargine insulin, as you can see on the graph on the right, there was about 20% higher use of glargine insulin dose compared to icodec as well. So that was interesting. Then the hypoglycemia. So this is hypoglycemia rates. Again, icodec column, glargine column. You have hypoglycemia alert value, which is level 1 hypoglycemia. And then level 2 or level 3, which is more severe or moderate hypoglycemia, which is what we really care for. What we saw in this was the level 2, level 3 was actually quite similar. So no statistically significant differences. There was only one severe hypoglycemia event in the whole trial. But the hypoglycemia alert value hypoglycemia, so level 1, was actually a little higher in icodec compared to glargine U100. So you can see the rates of 5.09 with icodec, and glargine U100 was 2.11 on the rate. So then the suggestion is maybe the algorithm or the titration target is not right for a weekly insulin, and maybe we should try for a different titration algorithm. And that was tried in the other phase 2 trial with icodec, which had 3 different titration algorithms for icodec compared to glargine. So what were the 3 different titration algorithms? So on the right, rightmost column is the icodec titration algorithm from the previous trial, which is a very strict target of 70 to 108 milligrams per deciliter. Whereas for the other two icodec arms, it was a higher target, 80 to 130, which is still aggressive enough, which is actually the ADA target, ADA recommended target for insulin, basal insulin. And glargine also followed this target. So the ADA recommended target was followed for glargine arm as well. So it's actually fair that these are being compared. The other thing that was different in the arms was how this was titrated. So simpler titration algorithm. So in one of the algorithm, it was plus 28, minus 28, but then they also had a lower titration of plus 21, minus 21. So rather than multiplying everything by 7, maybe you subtract 7 from that, and then you get to plus 21, minus 21. So finally, why are we doing this? To get to a safe titration is what the idea is. And the results show exactly that. So this is CGM data. On the right is the graph of CGM for these three icodec and glargine arm at the end of the study, so 16-week study. And if you just look at the slower titration, which is the light blue, which is 76% time in range, which is very similar to glargine. That's what you want. You want the time and range to be similar, come out similar to glargine arm, and that we got from the plus 21, minus 21 with the ADA target. And what also you get is hypoglycemia safety. So again, titration arm A had very low levels of level 1 as well as level 2 hypoglycemia, very similar to glargine arm. And that's why the company has decided to go with similar titration algorithm to titration A, which is the ADA target for glucose fasting, as well as a plus 20 and minus 20 for titration. And that is what is being used then in the phase 3A program, which is almost completed. So this program is called the Onwards program. There are 6 trials in this program. The top 3 trials are in basal insulin naive people, so people who've never used insulin. There's some interesting facts that are there in these 3 trials. I don't have the time to go into details, but if you look at the bottom left, which is Onwards 2, we do have data in a headline form. It's not been presented yet, but it's been announced from the Onwards 2 trial, which is a basal switch trial, 520 participants in the trial, 26 weeks trial. It switched basal insulin, any basal insulin, to icodec versus degludec. And what was used in this basal switch was a loading dose as well. So there was a loading dose of 50%. So people who were switching to icodec got 50% higher dose at the first dose. And then at the second dose, they came down to the 100% dose-to-dose switch, and then titration to that target of ADA glucose with a plus 20, minus 20. And what has been announced is this, that is very, very interesting. For the first time in insulin trials, randomized trials ever, in a treat-to-target trial, we see a difference in hemoglobin A1C, which is statistically significant. It's actually better with icodec by about 0.22, which is similar to the phase 2 trial, which was published in New England Journal of Medicine, right? So it's a similar hemoglobin A1C benefit that we see, and this time against degludec, with no significant hypoglycemia increase as well. So safety is there, better hemoglobin A1C, and of course, better, you can say, utility of it, because it's only 1 injection a week, not 7 injections a week. So not 365 injections a year, but only 52 injections a year, right? So that's the difference that we're talking about. So this is super, right? If it was to be available, hopefully in the next year and a half in some parts of the world as such. So that's the data that we have. Of course, like anything new, we have lots of questions that still need to be dealt with. Some of the questions that I could think of, I put out here. I'm sure there are others that need to be addressed as well. Some of the thoughts I have is that we still need to look into the PK/PD of some of these new weekly insulins, especially BIF. We don't know a lot, and a 17-day half-life. How does that work? In long term, I'm not sure. Even a weekly half-life, 196 hours for icodec is still quite long. So we need to look at that. Of course, the targets and the algorithms for insulin titration still need to be fine-tuned, I think, for clinical use for both of these molecules. And is there a role of technology? In Dr. Fonseca's talk, we talked about machine learning algorithms, and maybe there is some artificial intelligence kind of thing that can help with a weekly insulin titration in a connected care environment in the future as well. And then do we have any, what do we do for recommendations if somebody falls sick, somebody gets hospitalized, somebody intensively goes for a marathon one day, or does fasting for Ramadan, etc., etc. And then how about the clinical inertia and adherence? We're talking that once weekly insulin should have an impact, but do we have any data? Would it actually make insulin use and reduce the delay in insulin that we see in clinical practice or not is still to be determined as such. So with those questions, I'll just end and thank the Diabetes India organizers for giving me this opportunity to share the data. Happy to answer any questions. Thank you.
Thanks a lot, dear Dr. Harpreet sir. You are very clear with the topic, and from our center, we are also part of this Onwards type 1 study. So we are seeing the data like what you have discussed in detail, and patients are doing wonderful, and they are on CGM as well.
Yeah. So do you find that the weekly insulin in type 1 they're happier as well? Because
definitely.
That's one of the because that's one of the things that is being looked at in phase 3 program versus the phase 2 is all these quality of life measures as well, right? So quality of life, does it improve if you switch from a daily insulin to a weekly insulin?
Yes. Like what you said, patients are happy with once weekly shots. And the questions which you had put forward, definitely we are also seeing how to address these questions. No idea. Let's see. So any more questions from the audience, sir? Raghu, sir?
No. There are no questions in the chat box. So I think we can finish and close the next, I think over to the organizers, Dr.
Thank you. Thank you, sir. Thank you.
Yeah, thank you.
All right. Thank you, everyone.
Thanks.